The Basic Science Symposium. To chair the session, we have our own Dr. Ajay Prajapati and Dr. Pratap Jethwani sir. Over to you, my esteemed chairperson, for further proceeding.
Good morning, everybody. Good morning, dear friends, colleagues, juniors, and respected seniors and speakers. Welcome all to DIACARE Conference 2022, wonderfully organized and well managed by RX Event as well as Dr. Bansi Sabu sir. After online session, in second day, we have a in-person session at Hyatt Regency today. So in our best hall, we will start with basic science that will be delivered from Dr. Uman Dhruv sir, Dr. Benny Nagul sir, madam, and Dr. Vinod Mittal sir. So to start with, we will have a wonderful speaker, Dr. Urman Dhruv sir. I will ask him to come on stage. He has completed MD Medicine, LLB and MBBS. He has successfully completed course of Fundamental of Medical Ethics in 2018. Successfully completed diploma course on hospital management from a very well-known university and organization in 2004.
I think Dr. Ajay, we can skip that. That's fine. Thank you.
Okay, sir. You can go ahead.
I think we will be hearing Urman Bhai about the basic science. And tonight we will be getting a glimpse of his other side, that is music. So let's learn basic science from him. At evening we will learn a lot about music from him also.
Thank you, Dr. Pratap, and thank you, Dr. Ajay. Modulators of glucotoxicity and lipotoxicity, that is the basic science, really the basic science that is required to be understood. And in fact, the topic was selected by me because I wanted to know about this topic, and I came to know a lot about this topic after going through the literature and many of the things that I didn't know. So we all know type 2 diabetes is generally viewed as a clinical syndrome with variable phenotype. However, it could be polygenic in nature, and this polygenicity, that is multiple factors involved in the pathogenicity, can also be talked about in the form of gluco and lipotoxicity. For years together, we have been talking about simply insulin resistance, beta cell dysfunction, but what is lying behind it is hardly known. We believe that beta cell dysfunction causes hyperglycemia, but we hardly remember that chronic exposure to hyperglycemia causes beta cell dysfunction. So the terms were coined since 1985, glucotoxicity, 1995 lipotoxicity, and glucolipotoxicity was coined in 2004. So what is glucotoxicity? Ideally, the glucotoxicity refers to the adverse effects of higher than normal concentration of glucose on cells and tissues, and that includes all the cells and all the tissues of the body. However, of late, the definition has been restricted to the ability of excess glucose to impair insulin secretion and action, resulting in a vicious cycle of worsening glycemic control in diabetes mellitus. So now the glucotoxicity is talked in reference to diabetes only. We all know this slide very well. Genetic predisposition on one side in lean phenotypes, it may lead to the glucotoxicity. On the other side, in obese people having high BMR, it may lead to free fatty acids and lipotoxicity, and both will combine together. However, one should always remember lipotoxicity comes only after hyperglycemia, that is glucotoxicity. Lipotoxicity does not precede glucotoxicity. So the debate was going on for years together, what is more important, glucotoxicity or lipotoxicity? But of late we have got lots of references and evidences to show. So let's start with few evidences. Number one, increased oxidative stress in type 2 diabetes. Multiple biomarkers have been utilized to find out that biomarkers of oxidative stress, which suggest that in type 2 diabetes, the oxidative stress definitely goes high. Evidence that chronic hyperglycemia can increase the reactive oxygen species levels. So what is ROS, or reactive oxygen species? Actually, it is a metabolic reaction continuously producing reactive oxygen species such as superoxide, hydroxyl radicals, and peroxidases. These are all substances that can cause the damage. ROS is generally involved, with lots of evidences we know that ROS has generally been involved in inflammation, carcinogenesis, aging, and atherosclerosis. But now we have realized that ROS is also involved in type 2 diabetes. And it is glucose itself. Remember, it is the glucose itself which is capable of generating ROS. And therefore, glucose itself is toxic to the cells, especially the beta cells. There are a couple of markers like 8-HDAU and 4-HDAU, and these markers are seen to be increased, especially with high diet with sucrose. This 8-OHDG is an indicator of oxidative damage to the DNA, and that is the reason which increases during type 2 diabetes. So now we realize oxidative stress, multiple biomarkers, ROS, multiple biomarkers. What next? There are three ways in which the oxidative stress can occur. One is Schiff base leading to amidori compound. Second one is electron transfer system leading to increased ATP. And then the third one is the glucose with the help of glucokinase activity and insulin biosynthesis. So these three different pathogenesis that has been hypothesized for increased ROS activity. Not only this increased ROS activity, as we have seen, is detrimental to the beta cells, and beta cells would deteriorate. The glucose itself, or the glucotoxicity itself, increases insulin resistance even in liver and fat cells. So glucose is not only toxic to the beta cells, the glucose itself is increasing the insulin resistance, especially in cases of liver and skeletal muscle and adipose tissue. So, for years together we have been searching what increases the glucose, but we have hardly realized that it is glucose itself which is causing insulin resistance and which is causing beta cell dysfunction. Evidence is to show the antioxidant capacity of islets. Now we have realized that it is the oxidative stress of islets. What's the capacity of islets as compared to rest of the tissues? So, these are all antioxidant enzymes, and oxidative stress has been considered by many as an explanation. However, most of the studies on the oxidative stress were carried out till 2008 only on non-islet tissues. But it was only after 2008 that we realized that the islet has been the lowest intrinsic antioxidant capacity, which means islet cells contain the lowest antioxidant property. As you can see here, chronic hyperglycemia causing ROS, but add to it this something, low capacity of antioxidant enzymes. So, the armamentarium that is required to fight out the oxidative stress is minimal in islet cell all across the tissues of our body. So not only beta cells are exposed to glucose, oxidative stress, ROS, but they've got very little or poor defense system as compared to rest of the organs. Evidence that antioxidant drugs and overexpression of antioxidant enzymes in beta cells protect against glucose toxicity. Does this mean that if you add antioxidant and if antioxidants reach beta cells, it would protect? Yes. In animal studies and in preclinical studies, nicotinamide, dysferrixamine, these are all substances like metformin and troglitazone, superoxide dismutase and catalase. All these substances have protected beta cells in the diabetic rats. which are known as GK rates. Same is the influence of vitamin E, although all these things have not been still accepted in the human beings. The trials are going on. So, now we know type 2 diabetes is associated with increased markers of oxidative stress. Glucose can increase the beta cell level of ROS. Antioxidant treatment can ameliorate hyperglycemia. And overexpression of antioxidant enzymes in the beta cell protects against the increase in oxidants. Then what should be the antioxidant strategies to protect beta cells from hyperglycemia? In other words, what could be the clinical implication? So, two sorts of clinical implication: activation of antioxidant defenses and simultaneously repression of ROS producing systems. So one that destroys beta cells, they have to go down, and one which protects the beta cells should go up. And then there are, you can see as in the lowest portion, practically 16 systems that are being tested these days on human beings, and probably will come to know them in next near future. One of them is metformin. Remember, we go on saying metformin reduces insulin resistance, but now we have come to know that metformin probably does it by acting as an antioxidant in the beta cells. Same way, this pathway you have been knowing for years, heme, biliverdin, bilirubin. But something that we hardly know is this is because of antioxidant action. And this has been proved in beta cells when heme oxygenase 1 seems to mediate protective responses to the beta cells. So probably this is one of the important weapon that would be utilized in near future. Same way, this fluorositagliptin that also is protective by way of its antioxidant property. So now, next 5 years we are going to see the utilization of antioxidant properties of most of the compounds to protect the beta cells. Okay, coming to lipotoxicity. Lipotoxicity is an acquired cause of impaired beta cell function. Only after chronic hyperglycemia sets in, it is lipotoxicity that sets in. And what it causes? There is ample evidence that fatty acids, which are required for the metabolism, they become toxic when present at elevated concentration for prolonged period of times. They can cause decreased glucose-induced insulin secretion. They can cause impaired insulin gene expression and increased cell death. However, this cascade of free fatty acid becoming toxic, which is known as lipotoxicity, does not start before chronic hyperglycemia sets in. We just heard Dr. Makar saying that we should not allow HbA1c go to 7, then bring it back. Once again goes to 7, bring it back. Because during the period that it goes to 7 or above, you are exposing beta cells to chronic hyperglycemia, which not only is detrimental itself for the beta cells, but it sets in a cascade of the fatty acid which becomes lipotoxic. So lipotoxicity and type 2 diabetes, you can see as the BMI goes on, the chances of type 2 diabetes goes on. Prolonged in vitro exposure of islet cells to fatty acids decreases the insulin gene expression in presence of high glucose concentration only. Without high glucose concentration, fatty acids do not become lipotoxic. So, the term that was coined later on was neither glucotoxicity nor lipotoxicity, but now the term is glucolipotoxicity, meaning thereby it is the glucose that sets in or rolls in the cascade and then the lipids join them. Under circumstances where both fatty acids and glucose are elevated, accumulation of metabolites derived from fatty acids esterification would inhibit glucose-induced insulin secretion and insulin gene expression. So only when both of them are high, this can happen. Hyperglycemia is required for lipotoxicity to occur. They are consistent with a clinical observation that, and this is something that we have very frequently seen also, that all diabetics may have abnormal lipid profile, but all those who are having abnormal lipid profile will not have type 2 diabetes. at least to begin with. So that means the beta cell function is usually normal in patients with disorders of lipid metabolism, but the vice versa is not true. However, in presence of chronic hyperglycemia, you can see the destruction that fatty acids can do to the beta cells. So, ultimately, the most important message that should come to us is the main regulator of pancreatic beta cell functioning and regulator of insulin gene expression, synthesis, and secretion is glucose. High glucose levels increases the cholesterol absorption. Coming to one more pathogenesis, how glucose can be toxic. And the answer is, you can see the gene expression. Glucose not only increases ROS, it not only increases the oxidative stress, but it completely changes the insulin gene expression. And now it has been shown in multiple trials, especially 3 gold standard trials in 2018, that hyperglycemia itself changes the insulin gene expression, as you can see in the second slide, and the insulin becomes ineffective and insulin resistance increases. How does it happen? Chronic exposure to hyperglycemia, insulin mRNA changes, insulin promoter activity reduces, insulin gene transcription factors reduce, which are known as STF1, PDX1, IPF1, IDX1, and MEFA. This leads to reduced glucose-stimulated insulin secretion, and the insulin content of beta cells go down. This is all in response to chronic exposure to hyperglycemia. So summarizing, in human studies of type 2 diabetes, markers of oxidative stress are increased in type 2 diabetes. It has been shown in all trials across the globe. Reducing plasma-free fatty acids levels may decrease the relative risk of type 2 diabetes, but it does not completely ameliorate the possibility of type 2 diabetes, which means it is secondary to hyperglycemia. Glucolipotoxicity are secondary phenomena that are proposed to play an important role in type 2 diabetes. Patients with type 2 diabetes continually undergo oxidative stress. Elevated glucose concentration increases the levels of reactive oxygen species in beta cells. Islets have intrinsically low antioxidant enzyme defenses. This is very, very important. And now, since 2018, 3 more trials have come in which have suggested that islet cells in the body are having the lowest antioxidant enzymes, the 3 enzymes that I showed you. Antioxidant drugs and overexpression of antioxidant enzyme protect the cells from glucose toxicity, and this is probably going to be the important weapon to maintain the beta cell function in near future. Lipotoxicity, to the extent that can be attributable to hyperlipemia, occurs only in the context of pre-existing hyperglycemia, whereas glucose toxicity can occur in the absence of hyperlipidemia, meaning thereby the role of diabetologist is still more important than the role of so-called lipidologist or so-called cardiologist. Because hyperglycemia is a prerequisite for lipotoxicity to occur, the term glucolipotoxicity rather than lipotoxicity is more appropriate. Thank you very much.
Thank you, Urman Bhai, for highlighting the importance of that glucolipotoxicity in the pathogenesis of type 2 diabetes. I think we will take questions at the end of session. So for next talk, I think we all are focusing more and more on pancreas, but we all know that brain and liver has got an important role in the glucose homeostasis. And to speak on that subject, I will invite Dr. Beni Neglu. Madam is director of Dr. Neglu's Diabetes and Thyroid Specialty Center, and she is consulting diabetologist at Jupiter Hospital, Thane. She is fellow of American College of Endocrinology as well as American College of Physicians and Indian College of Physicians. She has been teaching faculty at D.Y. Patil University and PHFI, and she is doing a lot of work in the field of diabetes and women. She is founder, president, and organizing chairperson of VoteCon, Women in Diabetes Conference since last 5 years, and also founder and executive committee member of Association of Diabetes Educators of India. So over to you, madam,
Full screen, full screen.
for that talk related to brain and liver role in glucose metabolism.
Thank you so much, Dr. Pratap. And I also congratulate Dr. Bansi for having wonderful programs and a good scientific session year after year. And he's a true leader for us. Going back to liver and brain control of diabetes, let's first understand the normal physiology of glucose homeostasis. As we have learnt in medical school, we know that glucose is maintained tightly between the range of 80 to 120 by the action of two hormones, insulin and glucagon, which have the effects on various tissues of the body and are regulated by the liver, which is the main regulator, and then also by the brain, which you will subsequently see. It also depends on the uptake of glucose in the peripheral tissues, and these changes are seen when these regulators get disrupted. It is not only the liver, but brain is an important regulator of glucose homeostasis. And as you can see here, the excess nutrients that come to the brain centers, like the hypothalamus, is basically responsible for sensing the nutrient excess or the lipid oxidation that happens in the hypothalamus, mainly in two separate set of neurons. One is the POMC neuron and the neuropeptide Y and the agouti-related protein. These are basically have to have a good balance to increase or decrease appetite and maintain the energy. Activation of the POMC receptors will give rise to decrease in the food intake, and also have its impact on the liver by decreasing the hepatic glucose output. Whereas activation of the neuropeptide Y will cause hyperphagia and energy excess, which gives rise to obesity. So the brain and the hypothalamus mainly has a marked regulatory effect on the liver, controlling the hepatic glucose output. It all in type 2 diabetes, it starts with overeating and inactivity, where there's excess fat, especially in the viscera and the ectopic sites, and this gives rise to the deposition of this fat in tissues like the liver, giving rise to a fatty liver, and also in the pancreas, around the heart, and in the muscle, disturbing the hyperglycemic control and giving a risk factor for type 2 diabetes, which subsequently gives rise to characteristic atherogenic dyslipidemia, increase in leptin, decrease in adiponectin, and finally having its effect on the endothelial vascular function and also on the heart, giving rise to the macro and the microvascular complications. As we can see that this physiology is disturbed in type 2 diabetes when there is an insulin deficiency, and the uptake of glucose in the tissue is reduced because of the deposition of excess fat in the ectopic sites, and the regulation or the hepatic glucose output is disturbed both in the fed state and the fasting state. It is the lipotoxicity in the liver that gives rise to hepatic insulin resistance. And as you can see on the right-hand side figure, that the insulin resistance actually causes disturbance of the post-receptor chemicals, and primarily because of excess diacylglycerol, which actually upregulates and downregulates the messengers, which I will show you in the next slide, altering the glucose production and causing hyperglycemia. In effect, this is a simple, nice little diagram to understand this. You will see in the normal liver, when there is adequate amount of insulin, there are two messengers in the liver. One is FOXO and the second is the strep IC. There is an increased activation of the FOXO will decrease the glucose in the liver and decrease the hepatic glucose output. At the same time, inadequacy of insulin will increase the strep IC and increase the triglyceride, maintaining normal levels of glycerides or VLDL and also normal level of glucose. But what happens in selective insulin resistance, as happens in type 2 diabetes? Insulin deficiency will decrease the insulin action on the liver. It will downregulate the FOXO messenger, which actually gives rise to increased glucose production and increase in the hepatic glucose output. But it does the opposite to the strep IC. It upregulates the strep IC, increases the triglyceride. So in type 2 diabetes, a selective insulin resistance will not only give rise to hyperglycemia, but it will also give rise to hypertriglyceridemia. And the effects of this, along with the inflammation and the oxidative stress, which Dr. Dhruv mentioned, will give rise to an heterogenic hypertriglyceridemia, alteration of the coagulative pathway, increasing the C-reactive protein, increased fibrinogen, increasing PI1, and a low HDL, increased small dense LDL, and increased triglyceride, the perfect setting for heterogeneity and increase in coronary artery disease. And this is the ominous octet, as you have seen. It is not only the liver, but there are other drivers as well. But today I will talk mainly about the regulation of the brain in glucose hemostasis. Let's understand this from the beginning. We know that glucose is the only fuel that enters in sufficient amounts to support the energy requirements in the brain. But insulin is not the major regulator of glucose in the brain. Even though the brain is insulin independent, it is still insulin sensitive. The amount of insulin in the brain is 10 to 100 times higher than in the plasma. And why is it that the insulin levels in the brain is high? Because insulin is produced by the brain tissue, the neurons and the astroglia tissue. It actually is the second pancreas. When the glucose enters the cell, it forms ATP, closes the potassium channel, opens the calcium channel, and then secretes insulin inside the cell itself. And therefore, the brain is not really dependent on the insulin that comes from the circulation totally. Or, having said this, you'll see that the insulin is required in the brain mainly to increase the neurotransmitter levels, to produce glucose utilization, and also it enhances memory at optimal dose. Insulin receptors are present in the hypothalamus, in the hippocampus, and we know that the hippocampus is the center of all memory. It is present in some parts of the temporal lobe and also in the frontal cortex. Thereby, if there's an insulin deficiency, it will give rise to cognitive dysfunction and glucose dysregulation. Besides the insulin produced in the brain tissue itself, insulin can also come from the circulation in two forms. Once it comes into the CSF by the choroid plexus, and which is a very, very slow process. And the second is it comes through the blood-brain barrier only in specific areas. There are about 5 to 7 areas which are amenable to entry of insulin into the brain. Otherwise, in the rest of the brain, the blood-brain barrier is so tight that insulin cannot enter the cells easily. This is very, very restrictive. The action of insulin on the brain and the sensing of the nutrients that go into the hypothalamus, basically the lipid oxidation that happens in the hypothalamic cells, the POMC and the neuropeptide Y, then produces closure of the potassium channels, activates certain areas of the brain stem, and passes the information via the vagus to the liver. So the impact or the glucose or the sensing of the nutrients in the brain has a lot of impact on the liver regulation, either increasing or decreasing the hepatic glucose production. But it is also the brain insulin resistance that happens in type 2 diabetes at the hypothalamic region, also in the forebrain, that can increase appetite. It can produce a hypothalamic hypogonadism. It can also produce hypothermia by decreasing fat activity. And besides the regulation on the liver, it also has an impact on hypoglycemia. We've heard of recurrent hypoglycemia producing hypoglycemia-associated autonomic failure. And in addition to this, there is cognitive dysfunction and mood disorder. As we see this in many of our patients, defective sensing induces a reduction in the insulin's ability to block the hepatic glucose production. The insulin action also decreases the synapse formation, decreases the synaptic vesicles by acting on the cholesterol synthesis. Insulin action is required for cholesterol synthesis, and we know that cholesterol is a large part of the formation of brain tissue. Because of the defective cholesterol, there is behavioral changes, cognitive dysfunction, and decrease in endocrine regulation. And we spoke of hypoglycemia, which is half in recurrent hypoglycemia, especially seen in type 1 patients. There is an autonomic failure, and the patients are not able to recognize the low sugars. We've heard of patients saying, my sugar is 40, but I'm not having any symptoms. And generally, we tell our patients the symptoms of hypoglycemia. This is because of the autonomic failure that happens with a brain or central insulin resistance. Not only that, this insulin resistance increases the tau phosphorylation, increases the amyloid deposits and the neurofibrillary targets, giving rise to Alzheimer's disease, which is also known as type 3 diabetes. And you can see the pattern of the brain just like it shows in Alzheimer's disease. Increased insulin resistance was associated with a similar pattern in the scan as seen in the classical Alzheimer's disease. Liver, as we know, collects the fat, steatosis, finally going into steatohepatitis and liver fibrosis. It actually perpetuates hyperglycemia, type 2 diabetes metabolic syndrome, and this perpetuates more of hepatic failure, finally giving rise to the complication of coronary artery disease and also hepatocellular carcinoma. This is a meta-analysis showing that NAFLD is a risk for type 2 diabetes. The hazard ratio is 2.44. The microbiota is also involved because of the increased permeability, giving rise to the invasion of bacteria into the cells and also in the liver. So finally, is metabolic syndrome an infectious disease? That's a big question. Serum alanine, ALT, is an indicator of health and disease. This was a Korean study. Actually, they said that the liver is the cause of all diseases, and therefore when they do their insurance program, they also estimate the ALT, and they say that the ALT, if it is increased, it can give rise of 4C diabetes in the patient, and so the premium is higher in Korea. Hepatogenous diabetes, I think Dr. Mittal will tell you more of this. This is identified in chronic liver failure patients even without diabetes, and it can give rise to hyperglycemia in patients of cirrhosis or end-stage hepatic failure. You can distinguish between the two, but the complications of liver-related complications are higher in patients of hepatogenous diabetes. How can we change all this? Lifestyle intervention, we know, has a great impact on hyperglycemia and also on obesity, but it has been shown from the scans that aerobic exercise not only affects the glycemic control, but also increases the gray and white matter volumes in older patients, and therefore it is beneficial to have a good regulator from the brain cells. Bromocriptine, as we know, the quick release actually resets the hypothalamic influences of high glycemia and increases the dopaminergic activity in the morning, decreases the sympathetic activity and also the serotonergic activity, thereby decreasing the hepatic glucose output. Sulfonylureas have the effect on the potassium channels. As we know, this patient has DEN syndrome, DEND, and this DEN syndrome has neonatal diabetes as well as neurological symptoms. The same impact, the potassium channels happening in the beta cells, also in the brain cells, and therefore correction of the potassium channel activity or closure can also treat DEN syndrome and neonatal diabetes. GLP is a growth factor in the brain. It protects against oxidative stress and prevents apoptosis. And it has been shown that deletion of GLP receptor impairs learning and long-term potentiation of synaptic transmission in the hippocampus, and giving GLP analog can be beneficial. It also produces weight loss, and this weight loss has an impact on fatty liver. In fact, more than 10% weight loss can also reverse fatty liver in the initial stages. Metformin, they say, is not intrinsically hepatotoxic. Hence, you should not withdraw metformin even if there is an abnormal ALT-AST ratio, and there is no need to routinely measure transaminases on giving metformin. You can still continue that. SGLT2 also has great promise in hepatic liver disease and fatty liver and NAFLD, and it is also as we have heard several times, that it is in the first line treatment of dual and triple therapy in diabetes as well. Saroglitazar, a PPAR alpha and gamma agonist treatment for NAFLD, has shown great promise. It has shown a decrease in the liver fat and thereby good results in fatty liver. So all in all, the liver and the brain are very instrumental in the control of glycemic regulation. The brain has an impact on the liver metabolism and the hepatic glucose output, and that's how the brain and the liver control the glucose metabolism. Thank you very much.
Wonderfully narrated in-depth science about the liver and brain by respected Dr. Benny. Whatever innovation we are enjoying, that is a base of science. So we should not forget, keep on discussing science again and again. So apart from pancreas, nowadays, today morning, we are discussing about liver. Whenever we are discussing liver, without talking about non-alcoholic fatty liver disease, we cannot end our session. For next talk, we have a Dr. Mittal, Dr. Vinod Mittal, who is have a MD Medicine, FRSSI, DI, FIMS, and various degree from US. He is a senior consultant diabetologist and head of Center of Diabetes, Delhi Heart and Lung Institute. He is a director of Delhi Diabetes Care Center. He is a past chairman and secretary of RSS Delhi chapter, regional faculty in certificate course of diabetes, graduation and post-graduation done from Maulana Azad, New Delhi. Is a fellow of American College of Physicians, RSSTI, Diabetes India, ICP. He has done master class in Royal College from UK and done post-graduation course from US and UK. He has a vast clinical experience for last 33 years. He has been awarded by various excellent awards like National Award of Excellence in Diabetes Care 2018 and etc. He has been invited as a speaker in various national as well as international conference, and he has been involved in various trial as a principal investigator. So we'll have a well-known speaker, Dr. Vinod Mittal sir here. Over to you, sir.
Yeah, good morning, everyone. It's my proud privilege to share my knowledge on NAFLD and diabetes and overlooked complication, diagnosis and emerging treatment. So, I can't control from here. Can... Okay, okay. Yeah. So basically, NAFLD is very common world over, and since when there is an increase in the prevalence of diabetes and obesity, there is more. So NAFLD is there, and overall around 15 to 20%, but in India it's around 25 to 30% in adult population. And NAFLD, which is taken as a marker or a risk factor for chronic liver disease, more than that, it is a risk factor for cardiovascular disease. So this point has to be understood well. Once we diagnose NAFLD, it is not only chronic liver disease, it is more than that, cardiovascular disease as well as CKD. Now, we can see in this slide that they almost, in observational studies and overall prevalence, if we see in some population, in diabetic population, up to the tune of 50%, and maybe more than that, around 70%. While in 19 observational studies, the lower one we can see, there is almost, 30%, patients who have diabetes have NAFLD, and vice versa. Patients who have NAFLD, the more severe the disease, more are the chances of having diabetes. So these are 4 criteria which we have to understand. One is hepatic steatosis, and then is absence of significant intake of alcohol, absence of compelling etiologies of hepatic steatosis, other diseases, and then coexisting chronic liver disease like viral hepatitis and other causes. So these 4 criteria we have to meet before we diagnose. And this is the spectrum and pathogenesis, of NAFLD. And here we can see it's a multiple hit theory. So the first hit theory is whenever there is an increased intake of calorie-dense diet, there is, more storage of fat in the fat cells, and it is not only, a normal fat, it is abnormal fat, and there's increase in the size of fat cells, adipocytes, release of free fatty acids, which are taken up by liver, and there's increased intake of this triglycerides in the liver. So abnormal accumulation of abnormal cells in liver is basically leading to NAFLD. If this continues, then there is a changes in the liver enzymes, and there are other features of, because it is a part of metabolic syndrome, NAFLD. So there are, basically dyslipidemia, hypertension, and other abnormalities. So ultimately this goes on, and there are multiple hits, multiple injuries to liver, and there is, signs of then portal hypertension, cirrhosis, and then ultimately some patients develop hepatocellular carcinoma. So that's how we can see, some patients, initial stages of steatosis leading to steatohepatitis, which is NASH, leading to cirrhosis, and then hepatocellular carcinoma. So one important point we have to again remember, NAFLD, which is reversible, totally reversible in the initial stages, we can avoid not only cardiovascular disease, CKD, as well as hepatocellular carcinoma. Now, other important point which we have to understand is there is a complex relationship whenever there is, lipotoxicity, as the first speaker mentioned. There is abnormal, release of free fatty acids in the blood, and which are taken up by the beta cells, leading to toxicity of beta cells as well as liver. So abnormal accumulation in amount as well as quality. So quantity and quality of fat matters, leading to steatosis, leading to inflammation, necrosis, and fibrosis. Now, this is another theory, which is a twin cycle theory, that whenever there's a release of free fatty acids in the blood, it is taken up by not only the liver and other cells, but by the pancreas, and even 1 gram of this fat inside the pancreas lead to toxicity in the beta cells, leading to deficiency of insulin as well as insulin resistance. So this free fatty acid, they'll not only lead to insulin resistance but also lead to insulin deficiency by directly suppressing beta cells. And other is, on other hand, so this is pancreas. On other hand, when these free fatty acids are taken up by the liver, then there is basically an increase in the fat in the liver, leading to suppression of the normal processes, more glucose uptake, more glucose glycogenesis, and more release of glucose. So hepatic glucose output also increases. So on two hands, one hand, there is a suppression of beta cells, toxicity to beta cells, decrease insulin, and at the other hand, liver toxicity, increased free fatty acids by the liver, increased glucotoxicity. So parallel both the things are going on, and which is very, very important. So basically there is a complex interaction going on between adipose tissue, muscles, and liver. These three things, and ultimately this has an impact on cardiovascular system. And not only, it is leads to a lipotoxicity. There's inflammation, more, release of oxidative, oxidants or inflammatory cytokines, as well as there's increased procoagulant state. All this lead to ultimately increased atherosclerosis and cardiovascular disease. So this slide is again very important. NAFLD and diabetes, again, there's a very, very close relationship. Once there's increase in free fatty acid in the blood, which are taken up by the pancreas, insulin deficiency, and are again taken up by even the liver. So ultimately, this NAFLD and diabetes, they have a hand-in-hand, a relationship, and they mutually increase each other. So if a patient is having diabetes, there are more chances of having NAFLD, and vice versa. If a patient has NAFLD, there is a very high risk of developing diabetes. And these are different mechanisms which lead to complications in NAFLD, like decreased adiponectin, and there is lipotoxicity, decrease IRS, mitochondrial dysfunction, adipose tissue dysfunction. Whenever we have an increase in weight, there is increase in lipogenesis, that time also, but that is only increase in the number of adipocytes, not the size. When we take calorie-dense diet, then there's increase in the size of the adipocytes also simultaneously along with the number, and this increase in size of adipocyte leads to inflammation and release of adipocytokines. Now, these are again different mechanisms leading to cardiovascular disease. One is systemic insulin resistance, endothelial dysfunction, altered lipid metabolism, systemic inflammation, plaque instability, PAI1 also increases, and oxidative stress. So multiple things are going on. It's not one. And that means, we have to have a multifactorial approach. Lifestyle along with, treating NAFLD and all other cardiovascular risk factors. There are again, there's a relationship, between NAFLD and atherosclerosis. And there is atherogenic dyslipidemia. Whenever there's insulin resistance, we all know there's increase in TG, increase in small dense LDL, as well as a decreased HDL. That's how, there are so many complications, the cardiovascular, not only coronary artery disease. We limit our knowledge to, heart problem, or it's CAD. No, there are many more things. One is, heart failure, which is coming up in a big way. HFpEF. So patients may be, appearing normal, and after 3 to 5 years of diabetes, almost, 40% of them can have HFpEF. Then cardiac dysfunction, cardiac hypertrophy, then aortic valve stenosis, and then annulation, calcification, atrial fibrillation. It's very common, in patients who have insulin resistance, NAFLD, and QTC prolongation. So that point, again, we have to understand diabetic patients, and if they have CVD, there is already increased QTC, and if we add medications which lead to further increase in QTC, like, azithromycin was given left, right, center in COVID, that's wrong. So we have to see to it, patient is already having a risk of increased QTC, don't use such medications. So diagnosis is basically on clinical, parameters, and then, imaging, and then biomarkers. I will be taking one by one. FIB-4 score is the most important. And this, basically, if it is less than 1.3, it is low probability, and then if it is intermediate is 1.3 to 2.67, and more than 2.67 is severe. And this depends on 4 parameters: age of the patient, AST like SGOT, SGPT, and platelets. So 4 things you have to know. There's a formula given here, and calculate the risk. Once you find out this, you can always intensify, and accordingly, you can tell the prognosis and treat accordingly. Now, there are other models also. One is a model of end-stage liver disease. That's again a calculation of the risk factor, and then EPRI. EPRI is very important. This is basically AST platelet say ratio index. So here, what you have to take is just SGOT, the patient's value, upper limit of SGOT over the platelet count of the patient into 100. It's very easy. You don't need to go for ultrasound. Not everybody can afford ultrasound. So only as CBC, complete say count, including platelets and SGOT, and you can find out EPRI. And once EPRI is more than 1, it is a risk for NAFLD. So this is a one test which can be done very easily. And then there are multiple other tests besides ultrasound. Ultrasound is a very small test, not very significant, but we have this magnetic resonance elastography is the one of the best, and then it can be but the cost is too much. Then NAFLD versus MAFLD. Now, in times to come, take my words, today we are talking of NAFLD. I think tomorrow onwards, in couple of months, we would be talking MAFLD, metabolic dysfunction associated liver disease. Today, everybody says liver biopsies and other things to diagnose, and like MRI, but it should be clinical. And I will tell you how we find MAFLD. So MAFLD is basically hepatic steatosis with some blood markers like liver function test and any of the following: maybe diabetes, maybe obesity, and any of the metabolic features, metabolic syndrome. You must be knowing central obesity, triglycerides, HDL, fasting plasma glucose levels. So these are certain parameters. So either say on ultrasound there is some grade 1 or 2, and you may not go for fibroscan, HGOT is little high. Then presence of diabetes itself makes it MAFLD, or obesity, or any of the 2 of the 5 parameters of metabolic syndrome, any 2. So once it's there, that's how, in times to come, because ultimately the treatment has to start. So why we depend on fibroscan and other things? So, ultimately MAFLD would be, ultimately the diagnosis. And that's how, I've already told you about this, how to diagnose. And, for MAFLD also, we calculate accordingly, but here the, index is taken low as 1.45 and 1.45 to 3.26, and then more than 3.26. Now, again, important thing which we have to understand is once we diagnose, we should always grade whether it is mild, intermediate, or high. Because it's like, doing HbA1c. If it is more than 9% at the diagnosis, either a triple drug or, insulin treatment. So same is here, that higher or more severe is the disease, more intensive is the treatment. So basically for NAFLD, there are 3 things which we have to diagnose and which we have to target. One is lipid metabolism, other is fibrosis, and other is inflammation. So by weight reduction, we target all 3, but no medicine has all 3 features. So in times to come, we will have medications which target lipid separately, fibrosis, and then inflammation. These 3 important points have to be understood again. And there's so many studies are already going on, and one of them, saroglitazar has already been approved by DCGI, although it has not yet been approved by FDA. And there are so many evidences. The trials itself, the name is Evidences 1, 2, 3, and 4, and these trials have shown that when you give saroglitazar, there is a reduction in SGOT-PT, there is a decrease in ballooning, as well as a decrease in lipid levels inside the liver. Even we have studies, which is on biopsy, proven studies in these patients, although the number is very small. And these are different levels. We can see ALT, SGOT, PT, and other, say, changes in the fat content of the liver by saroglitazar. So overall, here again, you can see the fat content decreases by almost 30% with saroglitazar. So that point has to be understood well. Now, this is, triglyceride levels decrease total cholesterol, LDL, and increase in HDL. Saroglitazar is a dual, say, alpha and gamma PPR agonist. So it not only has a role in decreasing a lipid or controlling lipid, also it improves insulin sensitivity like pioglitazone. So it has got a dual action of having a control on hyperglycemia as well as lipid lowering. Then saroglitazar also was found to decrease CK18 like markers of fibrosis. Now, this is a new drug which is already available, obeticholic acid, which is a fascinoid receptor, X receptor agonist, FXR agonist. It is an anti-fibrotic and anti-inflammatory agent, which very few of you would be knowing. And this has, it is 100 times more, potent than chenodeoxycholic acid, as well as it regulates the genes which are involved in acid, bile acid metabolism, and it has already been, it is also approved for the treatment of NAFLD NASH, and there is a significant, role. So overall guidelines, if we see today, there is basically reduction of weight, but at the same time, less, bariatric surgery can also be undertaken. And like overall, if you, we see that NAFLD, like this is my last slide, it affects nearly 1/3 of the general population and 2/3 of the obese and diabetic population, maybe more, maybe more. It is an emerging cause of CLD. It has replaced alcoholic liver disease already in causing cirrhosis. Now the world over, it is basically, NAFLD, which is the cause for chronic liver disease, and it is an independent risk factor for cardiovascular disease. This point has to be understood well. It is an overlooked complication because, sir, it is fatty liver. I was at gone, got an ultrasound, incidental finding, and nothing is done after that. Please, no. Take it seriously. Try to evaluate the patient, find out. There may be some other cardiovascular risk factors. Treat all multiple risk factors. And weight reduction is the most important. Now, early and timely intervention, and in times to come, I think, we would be talking MAFLD, not NAFLD. It'll be more easy, for us, because clinical diagnoses are always easier, and then, the treatment would be started. Weight reduction is the only approved treatment as of today. Saroglitazar is the only which is approved by DCGI, but not FDA. All other molecules like vitamin E, even pioglitazone, these trials have shown, but not approved. Pioglitazone in diabetic patients, not in non-diabetic patients. Take my words. Non-diabetic patients, only weight reduction. Diabetic patients, yes, pioglitazone, even metformin, and even GLP-1, DPP-4, and SGLT2 inhibitors also have shown, to reverse NAFLD. So at the same time, don't forget to reduce and take care of all other cardiometabolic risk factors. So basically, today, pharmacotherapy is, again, we still are in a, infancy phase, weight reduction, and, management of cardiometabolic risk factors. Yes, in times to come, maybe, as I told you, obeticholic acid is also a new drug, which can reverse even fibrosis and anti-inflammatory. So with this, I conclude my talk, and I convey my thanks to all of you.
Thank you, Dr. Mittal, sir, for nice overview of NAFLD in diabetes. So House is now open for questions and comments. We'll request you to be very brief in your comment or question.
Nice talk. Actually, the point about the obeticholic acid you were talking, so lots of cases we got in the diabetic cases, non-diabetic cases with this fatty liver. It is quite a huge problem now. So what is the evidence and what are the basic recommendations by the authority to start this obeticholic acid, or is it something like just a bit better than what we are using previously?
Yes, so as of today, the guidelines don't recommend international guidelines, but yes, it has been even used in primary biliary cirrhosis, that one condition which is cirrhosis, where UDCA is found to be failed, like other OAD failures, we start with some other medication. So one is primary biliary cirrhosis and other is NASH and NAFLD. So it is just like, giving metformin or other medication, but international, organizations have not given any approval today. That's an important thing to be, yeah.
About obitocolic acid, it does increase LDL level. It causes marked intense itching. So therefore these patients do not tolerate it well. And it's only proven to be anti-fibrotic.
Yes.
So it's not for every patient of NAFLD. Good talk, Dr. Mittal. I want to ask you a question. There are many patients who are not overweight, yet they have the NAFLD.
Yes.
Now how do you explain this when the patient is not overweight, yet they have the NAFLD?
Yeah, so it's a very good question. I told you metabolic syndrome. So they must be having, it's a part of insulin resistance. So we have to have central obesity measured. I told, in times to come, like out of 5 parameters, one is central obesity, and which I think, for the house, everybody knows, but just maybe for some people, for India and by WHO, Southeast Asian, ladies more than 80 centimeter and males more than 90 centimeter central obesity, then TG more than 150, and fasting more than 100 milligram percent, HDL less than 45 and 55 ladies and males. So these are, criteria, 5. If two are there, along with LFT, even mild dysfunction. See, liver function may not be totally deranged. It may be just 50 of, SGOT. So borderline and a small decrease in platelets. Most of the patients, they have a decrease in platelets. We have seen so many patients. We don't bother about this. We have to check that. Any patient is having low platelets is a sign of, again, inflammation, and all cirrhotics have decreased platelets.
These patients who are not very heavyweight, they have a de novo synthesis of the fat in the liver. Either the fat should come from outside by eating food, or lack of physical activity, or sometimes hepatitis C virus also has a tendency to push fat into the hepatocytes. One of the important reasons when non-obese patients come with NAFLD is the liver has a tendency to produce more amount of fat itself, de novo fat synthesis, and that's the cause for a non-obese NAFLD. Question for Dr. Benny. You talked about bromocriptine, quick release. Now, we have been using bromocriptine for patients of Parkinson's disease quite often. What is this quick release bromocriptine, and how does it help the patient of patients who have a brain disease?
Normally what happens in the brain is involved in type 2 diabetes because of the affection of the hypothalamus. It resets the hypothalamus in insulin resistance, increasing the blood sugars in the morning. And what bromocriptine does is that it brings that setting back to normal and basically decreases the hepatic glucose output early in the morning. And therefore, bromocriptine quick release has to be given in the morning within 2 hours of getting up with the first with food, and that will decrease the sympathetic activity, increase the dopaminergic activity, and have an influence on the hepatic glucose output, thereby reducing it, and it is implicated in the treatment of type 2 diabetes. It decreases the HbA1c by 0.4 to 0.6. In Parkinson's disease, it acts as a dopamine agonist, and it produces a balance between the sympathetic and the dopamine activity, increasing the dopamine which is deficient in Parkinson's disease, and thereby it helps patients of Parkinson's disease.
There was a time when this bromocriptine came in the market. There was lots of companies were focused on promoting this. What happened later on? Why this today we don't get any company coming to us and telling you prescribe the bromocriptine? So I think the early what the enthusiasm was with the bromocriptine, today it is not at all. So what is your comment?
Yes, I think bromocriptine is, the efficacy of bromocriptine in the treatment of diabetes is not great, and therefore it fell out and did not help in the management of type 2 diabetes. It reduces the HbA1c to a very small degree, and therefore it just comes at an addition to other drugs. About the resetting of the hypothalamus, it is not well known because type 2 diabetes and obesity is a vicious cycle. So more the nutrients taken in type 2 diabetes, the more the problem with the hypothalamus, and so the effect of the drug was not seen as seen as in the hypothalamic area. think
I
that
want
is
to add,
right.
Dr. Benny, I want to add one small point here. So besides a very low potency, that's one, but significant central nervous system side effects, especially when you're giving antidepressants, SSRIs and SNRIs, there's an interaction between bromocriptine and that. So the chances of having, so we are getting less and giving more, means more side effects and less reduction. And now DPP4 inhibitors also and GLP-1 have some neurotransmitter. They also act like liraglutide and all, even central nervous system. So we don't really need this molecule, at the cost of significant side effect.
I think tolerance was a major issue. A lot of people did not tolerate it well. People started throwing it up.
Headache.
And that's why it
Headache was
not-
very.
I want to ask one Urban through one question. You mentioned about lipotoxicity, glucotoxicity. You have a lot of nutrients which come in excess. And these excess nutrients in the cell have a lot of intermediate products being accumulated. And that in turn causes upregulation of AKT and a downregulation of SIRT1 gene, FGF1 alpha, and also to some extent the other good genetic structures which improve the cell function. You think it's the excess amount of this nutrition causes the problem in the cell where the autophagy was involved? And because of lack of autophagy, the patients had these problems of increased lipotoxicity and glucotoxicity?
Autophagy was considered to be one of the important cause of lipotoxicity in the past, but couple of trials in 2016 suggested that it was not the cause, because even those who were not taking or nutritionally deficient did not develop lipotoxicity in absence of chronic hyperglycemia. So the amino acid cascade that I showed does not start unless there is a chronic exposure to hyperglycemia, at least for 6 months. Otherwise, amino acids remain neutral or beneficial to the beta cells until and unless there is exposure to the hyperglycemia, and that too for more than 6 months in most of the trials.
Thank you very much all the speakers, and thank you participants and Dr. Neglur for interaction with the speakers. So I think we conclude our session here and we hand over to Dr. Dharmendra.
Thank you, respected speakers and chairpersons for having this session. Now we are moving to the next session on the state of the art, and for chairing this session I would like to invite a senior physician from Ahmedabad, Dr. G.R. Badlani, and to accompany with him would like to invite my own friend Dr. Viral Raj Singh to be on the desk as a chairperson for this session. Thank you. Over to you, esteemed chairpersons.
Good morning, everyone. At the outset, I want to thank Dr. Bansi Sabu, who has given me opportunity to chair the session. And I want to congratulate the whole team who have really worked very hard to bring this show. In this session, we have the state of art lectures by 3 eminent speakers. The first is Dr. Bansi Sabu, Dr. Nandita Arun, she has not come. So instead, Dr. Bansi Sabu will deliver his lecture. We have Dr. Sanjay Shah and Dr. Amit Saraf. Dr. Bansi Sabu will speak on focus on TIR, time in range through CGM to target better clinical outcomes in diabetes. Bansi, please.
Thank you, Dr. Badlani, sir, and Dr. Viral. I'm a last-minute replacement. Yesterday night, we got the call from Dr. Nandita. She could not come because of high-grade fever. Thanking Abbott for supporting this talk, but this is completely, it does not have. So even it is supported by them, but I don't have any disclaimer to make on this particular talk. I'm going to talk in next 18 minutes the focus on time in range through continuous glucose monitoring in target for better clinical outcomes in diabetes. Now, first very important message which I want to give to everyone, that if you cannot measure it, you cannot improve it. And I think one of the major reasons for our country not to have a very good control of diabetes is because people are not measuring the diabetes. There are three pillars to manage diabetes or dysglycemia. Actually, chronic hyperglycemia is to be treated. It was DCCT and UK PDS trial taught us that yes, type 2 diabetes is to be treated. If you get a good control of diabetes, you are going to have less and less complication. But unluckily, it was the hypoglycemia which was a limiting factor for a tighter glycemic control, and we could not achieve a tight glycemic control for most of our patients. And then in last decade, one thing which we have realized, it is glycemic variability, which is also very important and emerging glycemic target. It is the glycemic variability which is also responsible, even if you achieve a good A1C control, still you get lot of complication. It is because of the glycemic variability. Let me give you one example. This is one type 1 diabetic patient measuring 4 times sugar. As per international recommendation, a type 1 child measuring 4 times sugar, you can see almost all reports are relatively good control. And I am sure the clinician, the patient, the caregiver, everyone will be happy. But what about the continuous glucose monitoring? If I do the same patient as CGM, you will find the patient actually developing pre-lunch hypoglycemia, post-lunch hyperglycemia, and there is a midnight hyperglycemia also. So continuous glucose monitoring is like a videography, while doing a random blood glucose monitoring is like a photography. It's a simple example. Someone can say you have a 600 doctors registered for a meeting, but only 30 or 40 doctors are sitting. Unless you do a videography, you will not find in which particular hall, how many number of doctors were attending and how many were going out. The similar way, if you don't do the continuous glucose monitoring, you will not able to know. It is a random blood glucose monitor, which is at that point of time maybe normal or maybe abnormal, because it never tells you what is going to happen after 4 hours. So how do we monitor our glycemic control? We monitor our glycemic control by A1C. You may have 2 different type of patient with the same A1C, but one patient may have less glycemic variability, other may have very high glycemic variability. I give you one more example. This slide we have taken from a diabetes care which was published. There are 4 different type of patients. All of them have a similar A1C with 8. But you will find on first patient, actually it is the fasting hyperglycemia which is responsible for their high A1C. The second patient, actually there is a fasting hypoglycemia, but still the patient A1C is same. The third patient, it is a post-breakfast, post-lunch, and sugar is very high, and that is the reason A1C is high. And the fourth patient, it is only the post-dinner sugar which is high, and that's the reason A1C is 8. So you may have a patient with 8 A1C. Unless you do the continuous glucose monitoring, all these 4 patients will require different approach to treat these patients, and that is what precision diabetology is. You can't treat all these patients with the same way. If they have 8 A1C, you can't increase the dose of whatever the medication which you are giving, and you may end up with the patient with hypoglycemia. So this you can achieve only through continuous glucose monitoring. So what's the rationale? Do you think that each and every patient needs continuous glucose monitoring? Yes, if possible, because A1C does not track glycemic excursion. 60% glucose low, which patient may not have the symptoms, will not be revealed on self-monitoring of blood glucose. Continuous glucose monitoring identify 4 times more serious glucose excursion than self-monitoring of blood glucose. And I am talking of self-monitoring blood glucose mean 4 times in a day. It's not SMBG or random blood glucose monitoring, which we do sometimes once in a day. So it is useful for those who are not reaching their A1C goal, having frequent low glucose level, they are unaware of their low glucose sugar level, they are not able to achieve the targets without increasing the hypoglycemic events, and those children and adolescents who can afford to use the continuous glucose monitoring. So the classification, we have real time, which is available in our country. We have intermittently scanned CGM, which is flash CGM, which is also available to our country. We have blinded professional CGM, which is also available with us, Libre Pro and iPro, and we have integrated CGM within the pump also. We have a CGM. So all 4 varieties of continuous glucose monitoring is available luckily in our country. Now, do we have a scientific evidence? Do we have a data to support that yes, by doing CGM, you are going to decrease the risk of hypoglycemia and still you are achieving a tight glycemic control? I started talking with the DCCT trial, which was done in type 1 to achieve A1C of 7. That was the target, but they could not. The mean A1C of these children were 9, and they could reduce it to the 7.2. But at the risk of developing hypoglycemia, which is 62 per 100 patients a year. It is in 1983. Then after 25 years, these patients were put on a continuous glucose monitoring. And this was a JDRF trial, JDRF continuous glucose monitoring. The mean A1C of these children was 7.6. They could achieve A1C by 7.1. What different things they have done from DCCT to JDRF CGM? These patients were put on a continuous glucose monitoring. And you can see the result. The risk of hypoglycemia from 62, it has reduced to 20. Again, after 8 years, there was a pivotal trial where these patients were put on a CGM along with pump therapy also. It was integrated CGM, and you will be surprised, the mean A1C from 7.7, it had come to 6.9, but the risk of hypoglycemia became 0. So no hypoglycemia, and still you are achieving for type 1 children. So this is what the advantage of this continuous glucose monitoring and the pump and the technology used for type 1 diabetes. Now we have a lot of data for type 1. But anyone can ask, because we have a lot of type 2 diabetic patients, do we have the data for supporting it using continuous glucose monitoring for type 2? Yes, there is a consensus statement which we had published in JAPI, in our own journal, for a type 2 diabetes who are on oral anti-diabetic agents, where A.G. Unnikrishnan and myself was the primary author. We have with us Sanjay Agarwal. He was also the part of this consensus statement, and we had used that using even the patients who are on oral anti-diabetic agents, can we use the continuous glucose monitoring or ambulatory glucose profile? This is one more paper where V. Mohan had talked about the retrospective continuous glucose monitoring in patient of type 2 diabetes for optimizing the therapy for type 2 diabetes. This is the consensus which was international for continuous glucose monitoring. Whether all type 1 diabetic patients, all type 2 diabetic patients who are on insulin, all type 2 who are on hypoglycemic agent, they should be preferably on continuous glucose monitoring. This was consensus where more than 35 experts from all over the world were there. In 2017, I was lucky that I was part of this consensus meeting, and I was the only one from Asia who was representing this as an international consensus on use of continuous glucose monitoring. And we, after 1.5 years, we had come out with a target that on continuous glucose monitoring, what should be the time in range? And time in range for any type 1 and type 2 garden variety of patients coming to your clinic, more than 70% of the time their sugar should be between 70 to 180. It is not acceptable if their sugar goes below 70 for more than 5% of the time. It is not acceptable if their sugar goes more than 5% of the time, more than 250. If it goes, we have to change the therapy. Similarly, those who are elderly, high risk for hypoglycemia, we make it instead of 70%, it should be 50%. For pregnancy for type 1, slightly more tighter glycemic control. Instead of 70 to 180, it should be 63 to 140. And again, more than 70% of the time, they should be in the same range. GDM typical or type 2 who is becoming pregnant, more than 90% of the time, they should be in the tighter glycemic range between 63 to 140. This was one paper which was written by me, and a time in range is a target in type 2 diabetes. It's an urgent need. For a type 2 diabetes also, we have to move beyond A1C. We have to come out with a time in range for type 2 diabetic patients. These are some of the papers to support that. Better the time in range, lesser the complication, whether it's a microvascular complication for type 1 as well as for type 2 diabetic patients too. It was in 2019 when the time in range was published, and the first association in the world, in 2020, American Association of Clinical Endocrinology, they had put in their 11 principles of comprehensive management of type 2. I'm not talking of type 1. Type 1 is already well established fact all over the world. In type 2 diabetes management, also the continuous glucose monitoring should be used using continuous glucose monitoring whenever indicated to assist patient in reaching glycemic goal safely. The first Association of Clinical Endocrinology in 2020, they had come that CGM should be the part of comprehensive management of type 2 diabetes patients. Also, we had again put a few more papers using continuous glucose monitoring for improving monitoring and management of type 2 diabetes. And before even 2017 CGM guideline, which was made in Europe, we had come out in 2015 a consensus guideline for glycemic monitoring in 2015 too. Recently, one more paper that how frequently one should go for time in range, how frequently for type 2 diabetes. Can we afford all our patients to do continuous glucose monitoring to achieve a tight glycemic control? And we were really difficult. And this was the recommendation from South Asia, with Jyoti Dev, Anup Mishra and myself. We had come out that time in range and a frequency of continuous glucose monitoring can be done for patients who are uncontrolled every month, For those patients who are relatively controlled, maybe 2 months or 3 months, or those who have very good control, it could be done even 6 months to 1 year also, because we are using intermittent using this continuous glucose monitoring or professional CGM. So at this point of time, I will say these all 3 core glucose technique which are complementing each other. They are essential for type 1 and type 2, whether you talk of finger stick testing, which is a random blood glucose monitoring, A1C, or continuous glucose monitoring. We have evidence more with type 1. We have also evidence for type 2, but still we can't say that only CGM is sufficient, because all our patients can't afford for CGM and we can't have time in range for each and every patient. Let me talk with my last slide in 2 minutes that in how practical we are for type 2 diabetic patients. Let me give an example. This patient in 2018, in 9.2 HbA1c with 3 drugs, with gliptin, with metformin, and with sulfonylurea. Patient with 9.1. We all will agree that this patient will require insulin. As per guideline, triple drug, already on sulfonylurea. There is no way by which patients can be good controlled by putting the patient on any 4th or 5th drug. Patient was to be initiated by insulin only. Patient had gone to 2-3 diabetologists, endocrinologists of the city. They all advised the patient to start with the insulin therapy only. Patient had come to me. I also talked the same thing, that insulin is required because you are 9.2 HbA1c with a triple drug oral anti-diabetic agents with sulfonylurea. Patient was not ready. We explained the patient and we asked the patient, let us get your continuous glucose monitoring. Let me do your FGM and see what happens. And the patient, when we call the patient on 5th day, you can see all on the first side of the graph, all sugar are high. Fasting was more than 180 almost. 180 it is touching, and 250 to 300, 350 was the post-meal glucose level. By all means, patient fit with the insulin therapy only. We explained the patient that we can think of GLP-1. That's what we can give. We can offer you SGLT2 if you are not ready for the insulin therapy, and we can remove your gliptin part. So 3 things will be oral tablet and 1 will be injectable. To my surprise, we also asked the patient that every alternate day you have to call. I mean, to our diabetic educator or our associate doctor or to myself, there is a possibility patient may go in hypoglycemia. Even on the 4 milligram glimepiride patient was taking, we made it 2 milligram on the day of prescribing the GLP-1. And patient, every alternate day patient was calling us, and from 180 fasting sugar had come to almost 70. We reduced from 2 to 1 milligram of glimepiride. Again, after 2 days, patient sugar was fasting was almost around 70 to 80. We again reduced it from that to half milligram, and on the 6th day before coming to patient again called them, that day we stopped the patient glimepiride. So when patient had come to us on 10th day, patient was on GLP-1, patient was on SGLT2, and patient was on metformin, and you can see on the third side the graph which is 70 to 120, almost the sugar is absolutely well controlled, and the patient was continued with this therapy, and we explained the patient now we will continue with this. Yes, it is injectable. Patient continued this for 2 years, significant weight loss. Now we stop the patient GLP-1 also, we stop the patient on SGLT2. Now he is only on metformin. Now why I am giving you this example, that the guideline suggests us that this patient should go on this. While doing a continuous glucose monitoring, it gives us the right direction, and that is what the precision diabetology. We could understand from the history as well as by first graph that patient eating behavior, the carb content of the diet, and patient what he is eating, that is responsible reason for them to have a sugar of 350 or 250 or 180 fasting. But as soon as we change the diet pattern, and that was supported because of GLP-1, as patient we started, and you can see how SGLT2 had worked in this particular patient. This may not be case for each and every patient, but that is what we have to treat patient individualized, not on the only on guideline based, and how the continuous glucose monitoring can help us for treating these type 2 diabetic patients in our clinic and getting absolutely well, I mean getting good control without getting hypoglycemia. This patient after 2 years had lost almost 15 kg of weight. Now only on metformin, we can say it's almost reversal of diabetes, and patient is only on lifestyle modification, none other than any other GLP-1 or any other medication. We can have multiple such example. You can have a patient only with fasting hyperglycemia, only with post-dinner. This is very interesting, that sometimes patient goes in the outside dinner, you can see the patient sugar level goes even up to 350. Normally sugar post-dinner is not going more than 250 or 220. So this will self-explanatory for the patient that how your outside dinner can increase your sugar up to 300, and that may be the reason for his A1C is getting uncontrolled. You may have post-lunch, post-breakfast, post-evening dinner. All these different type of pictures you can find in a continuous glucose monitoring. So we are using this professional CGM for monitoring, for motivating, for educating our type 2 diabetic patients to achieve a tighter glycemic control and without getting increasing the hypoglycemic risk for these patients. So to summarize my talk, continuous glucose monitoring and achieving a tight time in range assist in discovering unknown hyper and hypoglycemia. That is what the CGM is helping us in observation of glycemic variability, assessing percentage of time in range and percentage of out of range and in range. Someone say that if my patient is not able to achieve, my type 1 diabetic patient is getting multiple hypoglycemia, what should I do? You have to change the lifestyle, you have to change the therapy also. That is what we have to do. Severity of hypoglycemia and hyperglycemia during daytime and nighttime can be significantly reduced. It provides you actionable information, because what action you have to take, that depends on what type of CGM had come. Some patient we have to talk about the breakfast, some patient you have to talk about the dinner, and that you can get only with this. Highlighting the impact of behavioral variances, it analyzes glycemic effects of new intervention effectively and efficiently. This will give you the new intervention which we had put, like GLP-1 for this patient, other patient you had put on SGLT2, you put some patients on a ultra long acting, short acting or ultra long acting insulin. That is going to give you analyzing for that. It gives you the care for diabetes getting digitalized. Even in this COVID time, some of patients who are using continuous glucose monitoring, even distantly they are monitoring and sending us reports only through WhatsApp or message. So you are digitally getting connected with these patients also. With continuous glucose monitoring, it enhances patient self-management, adherence and confidence in diabetes management. With this, I thank you very much, both the chairperson, and thank you all the participants for this talk. Thank you.
Thank you, Dr. Bansi, for emphasizing the importance of CGM and TIR, which I think we should regularly bring it on our practice. Now, since Bansi, you are very busy traveling from one hall to another, if there are any questions?
What do you, I mean?
Because you are going in all the halls, so I think if there are any
yes.
questions,
Yes.
they should ask now. Otherwise, in the end, we'll have all the 6 questions.
So if anybody wants to make any comments, I'm sure that all of them are experts. They may not have questions if they want to make any
Bansi,
comments.
when you are having this TIR of 14 days, sometimes we find TR 70%, sometimes 40%, someday 30%.
Sir, actually time in range, the concept had come for those who are using continuous glucose monitoring continuously. It's not for this 14 days professional CGM which we are using and then asking patient to come back. It also gives you the rough TIR because it is predictable for next 3 months. The 114 days continuous glucose monitoring gives you the prediction for next 14 days, and we are more smart. We are trying to use it even not 14 days, every 5th day, 6th day, we call back the patient. We see in last 6 days what happened, then again we change the therapy. Again next 4 days, 5 days, we again call, and again 4 days. But the concept of time in range had come for those who are using continuous glucose monitoring and seeing every day you should achieve time in range more than 70% of the time. If somebody is achieving like this. But we had seen even with the professional CGM, those who are achieving a good tight glycemic control, it gives you good prediction for next 3 months. And that's the reason we have written one paper with Anup Mishra and Jyoti Dev that you know how frequently one should do the CGM. Suppose you have done for one patient today, he is achieving good control, whatever the modification which you have done, again you have done after 1 month or 2 months, you found he is having a good tight glycemic control. Then patient may ask how frequently I should do. And for that we have written the consensus. If it's very good control, you can say 6 months to 1 year, that's fine. But if it's not very good control, every month, every 2 months, every 3 months, that's what we can recommend the patients.
Any other question?
Yes, Amit.
For the real-time CGM so that they can monitor. But at the end of the day, what we are seeing is the titration and the correction of the doses are more accurately done when we are using the Pro, but the behavioral changes are happening more when the patient is using the real-time.
I fully agree. For behavioral changes, it is Libre. It's a continuous glucose monitoring, a real time that is required. But how much you are empowering your patient, that is more important. How much education you are doing for your patient. If you can educate your patient and he can use the continuous glucose monitoring, and simultaneously you are empowering your patient so much so that they can change their therapy also. with some minor changes, or you have a sufficient staff or your supporting staff who can also guide them on day-to-day basis, then it is really good. Some of our type 1 diabetic patients, they use Libre. Type 2 diabetic patients, many of them are not very comfortable to use it, and you are the one who is the best one to change their therapy. Some of type 2 who are on multiple daily insulin injection, particularly post-transplant patient to whom I had put, because they are on steroid dialysis patients where I had put, because again it is not approved, but because they may have a fluid change and their sugar level may show slightly hypoglycemia, but these are the patients, or somebody who's not ready to prick for 3-4 times, they are the one to whom you can ask for that. But both are good. Cost is higher for the Libre, but otherwise fine with the Libre. If someone can have, it's very good.
If there are no questions, I think that we should thank Dr. Bansi Sabu for the excellent
Thank you, sir.
lecture.
Thank you.
And now I will invite Dr. Sanjeev Shah for the next lecture.
Just one comment, sir, last. We have seen in practice that when we are applying freestyle Libre for first time, we have to tell patients that you have to live your lifestyle as you are living, eat what you are eating from previous day, because patients many times changes, they will be caught in this patch.
I agree, but it's always, like someone says that here CCTV is there, your behavior may change. So it's, I mean, your behavior will definitely change. Once you are saying that now you are continuously monitored, your behavior will change. Thank you.
Okay. Dr. Sanjeev Shah will speak on multi-factor approach in the management of type 2 diabetes, evidence with once weekly GLP-1 receptor agonist, that is dulaglutide. And Dr. Sanjeev Shah doesn't need much introduction. He is an endocrinologist at Nanavati Mag Superspecialty Hospital, Mumbai. And he is an academic clinician in private practice since last 40 years. And he is in Mumbai. And he has 50 original research clinical studies, and he has written 20 chapters in book. And over to Dr. Sanjeev Shah, please.
Thank you, Chairpersons. The subject of GLP-1 RA was well introduced by a case report from Dr. Bansi Sabu in a previous talk. If you remember those 3 keywords what he narrated, one was a glimepiride withdrawal. Second was a lifestyle change which resulted into a 15 kg weight loss. But the trigger point was introduction of GLP-1 receptor agonist. It is not captured in the GLP-1 RA trial or in the real world data that the drug could induce 10-15 kg weight loss. But the success of going off treatment, remission in diabetes, all could be achieved simply with a change in the diet, change in the appetite, and an excess eating was eliminated. So how appetite modulation and a weight management would change the diabetes? At last ADA, there was an excellent debate regarding weight is an important target versus glycemic target. So probably we are moving in the direction of addressing obesity, NAFLD, and the weight in a diabetic patient, which would change the outcome. So with this, I am a speaker and advisor for a couple of companies, quite few. This is a CIPLA sponsored, as you can see on this. So I am an advisor and a speaker for CIPLA and Lilly. And in our practice over last 5 or 10 years, we have shifted from glucose-centric to cardiocentric or a vascular-centric. This had been a movement and a strategy and a guideline, and everything had been happening over couple of decades. There is nothing much to say. It's a well-known fact that why diabetics are at higher risk. But if we have a drugs, since after EMPIRE-XCV outcome trial, we have learned that a trial or a drug which results into improvement in multiple CV risk factor, probably we would have better outcome in diabetic people. So what interventions would benefit type 2 diabetic patients? If we have to have an algorithm for how should we be managing, I have always given very high attention to people who do not achieve glycemic control. From UKPDS, I know that 1% A1C reduction would reduce MI risk by 16%. Severe risk and glycemic control is poorly linked. And I thought that all such uncontrolled diabetics in my clinic, I should offer them a good high intensity statin, a good LDL target, and a good antihypertensive program. So that is equally important. So you need a drug which addresses more than glycemic control. This was well proven long back from a Steno Denmark center that a multifactorial intervention, and mind you, this participant number was not great. Peter Gade and we have interacted many times, and he said we never achieved A1C of 6.5 or 7. Most patients over 10-20 years achieved consistent 7.5. Only thing, all the drugs which were given to them included even antiplatelet. And the drug used for glycemic control was glyclazide. So comprehensive management was very important. At that time, SGLT2I and GLP-1RA was not available. So how do we offer a comprehensive management? So we come to the so-called a subject of GLP-1 receptor agonist. Try to focus on the left side. We know the action of incretin axis on pancreas and liver is quite well known. But the most important critical benefit of controlling PPG with GLP-1RA more than a DPP-4 is an effect on a gastric emptying time. It's not the glucose-induced pancreatic insulin secretion which controls PPG, but it is the gastric emptying effect which is not there with DPP-4 inhibitor. The other two effects on appetite center in the brain and on adipose tissue. Now there is a great science and a great chapters written on adiposopathy or a dysfunctional adipose tissue. So we have learned adipokines and the impact of adipokines on the behavior of future behavior of cardiovascular disease is quite well known. Probably by reducing weight and changing adipose tissue abnormalities, we achieve something better with SGLT2I and GLP-1RA. And if we look at on the right side of a slide, you have a multiple pathways through which GLP-1 receptor agonist will have an impact on a atherosclerotic plaque and a plaque in progression. If you see, the benefit of SGLT2 inhibitor is not in reducing myocardial infarction. The great benefit was obtained in people who have heart failure or people who would die due to cardiovascular disease. But the impact on MI was seen more with GLP-1 receptor agonist. And a combination of two would obviously make the best partner to go ahead. And that's how ADA and AAC all along have given a higher importance to drugs which result into a weight loss. And that's how they are in the top priority. Presence of one additional CV risk factor like LDL or hypertension increases the risk of diabetic people, and automatically presence of ASCVD risk factor would result in selecting a drug which would modify. So automatically metformin, SGLT2 inhibitor and GLP-1 receptor agonist would come into selecting. The fourth would be pioglitazone. If you remain within these four drugs for longer period of time, you don't need sulfonylurea and insulin, you are better, the patient's outcome would be better. Still till 22, in last 10 years, it is consistently written the first injectable has to be GLP-1RA. And many drugs have been compared with glargine as the first drug, and they have shown to be equipotent, equi-effective without hypo and with weight loss. So it's a better drug. But now I am going to focus in next 10 minutes on dulaglutide, which is once a week GLP-1 receptor agonist, and how much A1C reduction you would expect. And all oral agent will give you not more than 1% HbA1c reduction. Only in GLP-1 receptor agonist, right from LIRA to SEMA, you will find on an average 1.5. Real world data, if you look at on any drug, could be as low as 0.5%, similar to DPP-4. On the upper side, you may find up to 2%. We still have to wait for tirzepatide, which is dual GLP-1RA, which is shown to reduce 18 kg weight loss and 2.7% A1C. But that is couple of years for India. It's already launched in US. This is a comparison between two GLP-1RA on the left, Dula versus liraglutide, both injectable, 1.4% A1C. In the middle, you find dulaglutide with glargine insulin, both once a day kind of therapy, injectable versus once a week. On the right, you have multiple basal bolus injectable therapy in presence of Lispro and Glargine arm being compared. And in all three different patient profile, therapy profile, disease profile, phenotype profile, you will find that dulaglutide here has shown on an average 1.4% A1C reduction. If we talk about the weight loss benefit, there are a couple of trials, 3 trials put up here. Right extreme is on the renal disease patient, and you find just a 3 kg. And this is what you will find in all the trials, except recent SEMA is showing probably a 5 kg weight loss. But that's on this side of a wall. Exactly at this time, there is a GLP-1 RA, but there you will have to listen 40 minutes. Here in 20 minutes, you will learn the similar aspect of GLP-1 RA. It's not only how much weight is lost, it's a visceral fat. And that's more important. How much fat one would lose from liver? What percentage is needed? I'm sure that Dr. Mittal highlighted about NAFLD and hepatic fat loss with GLP-1 receptor agonist. But this is equally important, that dulaglutide also would result into reduction of hepatic fat. And this is usually associated with reduction in epicardial fat, which is also a so-called a marker and pathology for creating a cardiovascular disease. Now comparing the most important aspect of CV outcome trials, we got the leader trial first on GLP-1 quite long back, and we were not so impressed because we were impressed by EMPA-REG outcome findings, and that anything into 30% reduction and risk reduction 30-40 sounds larger. So we tend to neglect 12 or 15% of risk reduction, but the endpoints were different here. Now comparing different GLP-1 RA in a different trial, of course we can't easily compare. They happen at different time, different patient population. But the most important, what you see on Rewind, which is circled there, is 70% of participants were primary prevention. Absence of cardiovascular disease when they were enrolled in the trial. EMPA-REG was 100% patient with past CVD, while a leader has 72% with a past CVD. That becomes a secondary prevention trial. This has 70% people without CVD. So this is a low risk population in Rewind trial. That's why it makes more attractive. And if you see the duration of follow-up, everywhere it is 2 to 3 years. In Rewind, you have 5.5 years. So it's a long-term follow-up trial which has shown benefit. As you can see here, there are only 4 agents so far out of all GLP-1 which has shown benefit, but only 2 are available in India, liraglutide and semaglutide, and you will find 12% risk reduction with primary 3-point MACE, which is a non-fatal MI, non-fatal stroke, which are very, very important, which is not being addressed. If you look at DAPA declared TIMI also has similar 12% primary prevention. So declared TIMI or EMPA-REG, all of them have between 12 and 14% reduction in MI or a non-fatal stroke. So in terms of primary 3-point MACE, they are all identical. Only in heart failure, the drugs are different. So this is primary prevention compared to placebo, and this is secondary prevention. Now if you look at closely, these 2 points in the lower part, history of CVD and no history of CVD. So in 2 different subset of this 70% and 30%, the benefit is identical. So it doesn't matter whether past history or is there or not. If I show you here a Pioneer 6, you do not have any kind of a benefit there. Only in Sustain, which is an injectable semaglutide, you have a 3 points benefit, but we don't have injectable semaglutide. We have currently no data of CV benefit with oral semaglutide. The trial is currently on and we'll have to wait couple of years to get the findings. Now there is a small benefit in systolic blood pressure with dulaglutide and a small change in LDL. We do not know how much this has a contribution, but you don't have to worry about any change in heart rate, blood pressure or LDL. Now if you look at the microvascular complication, what was an impact in the REWIND trial, this is again in comparison to placebo. There is a benefit in diabetic retinopathy and diabetic nephropathy as assessed by number of patients needing a lesser photocoagulation, anti-VEGF injectable therapy or vitrectomy, or a fall in GFR, change in GFR, or a change in albumin excretion rate. The next is adverse events of interest. Again, no difference against placebo. No increase in hypoglycemia. We know that GLP-1 RA doesn't increase hypoglycemia. So finally, the only side effects about which all of us are worried, every time when we initiate the patient, people do come back with GI side effect. Nausea can be as high as 20%. 10% might vomit, and all these people need to be counseled, and during first month the side effects is maximum. They should be advised to eat slow, smaller meals, remain hydrated. I would always prescribe both the types of antiemetics, whichever work out, and if people can sustain little side effect, loss of appetite, feeling sad about food, couple of months passed, probably they will continue to eat and continue to manage that way and take injectable therapy continuously. And then you will see what Dr. Bansi Sabu showed that a patient could. So we all have similar kind of a patient. Patient loses 5-10 kg weight, patient looks at a flat sugar chart on the CGM, gets more motivated to follow the lifestyle, and then the more weight loss would happen. Now, if you look at the ease of injection in comparison to liraglutide pen, I am sure those who have used, those who have seen, have no doubt about the pen what Lilly had produced for dulaglutide. Non-visible needle, nothing much to do, extra sophistication. This is June 22, a real-world data on comparison between dulaglutide and oral semaglutide. So people preferred to take dulaglutide and not oral semaglutide. This is what is unlike what would expect. Of course, this is an American population where a huge number of people are currently on dulaglutide, but a propensity score matched population, 6,500 people. This is pharmacy-based data, and the larger number discontinued oral semaglutide, but they preferred injectable dulaglutide. So probably Trulicity had an impact. People were very comfortable. Our patients also find that once a week is no big hassle, and many of them do not wish to change. So finally, if your patient is inadequately controlled on multiple oral agent, blood glucose is higher than 8%, there is cardiovascular risk, and weight gain is an issue, or obesity is always an issue, GLP-1 RA or a weekly dulaglutide is a solution. And this probably will offer you multiple additional benefit to qualify for multifactorial approach. With this, I would stop here. And Dr. Badlani, we are taking at the end after Amit Saraf or together, as you wish.
In the end, sir.
Okay. He's talking on metformin,
Yes.
but we can combine two agents. No. Thank you.
Thank you, Sanjeev Bhai, for the excellent overview of the subject. Now I would like to call Dr. Amit Saraf from Mumbai, and he'll speak on metformin as supreme position as first choice. What are the pros, what are the cons? To introduce Dr. Amit Saraf, he's MD, FRCP, London, FICP, FACP, and he's the Director of Department of Internal Medicine, Jupiter Hospital, Mumbai. He's a head quality control, Jupiter Hospital, and he is a reviewer of the BMJ and Annals of Internal Medicine, editor Joppy, MRCP London examiner. He's a DNB teacher and MD examiner, and is a National API Governing Body Council member. Dr. Amit Saraf, please.
Thank you, Chairpersons, for those kind words of introduction. It's always difficult to come in at number 3 after stalwarts like Bansi Bhai and Shah sir have talked. You almost feel like a Kamri coming in at the bottom end and trying to then score over them, which is impossible. But I'll try my level best. That's my topic of this afternoon, that whether metformin, after the pros and cons, we shall see in my 22 slides. And so audience knows kitna slides hai. I think everybody should be having a disclaimer kitna slides hai, so people can time their next sessions and lunch and all that. So 22 slides is the first slide. Last slide has to be a thank you slide. So 20 slides. And at the outset, thank you to Bansi Bhai and the entire team for DiaCareCon. So metformin, we are all aware as clinicians, the journey began in the 1920s. The US FDA gave an approval in 1995, but it was used for the treatment of type 2 diabetes in the UK in the 1958 and Canada in 1972. It's a biguanide by classification. It helps in decreasing neoglucogenesis and increasing insulin sensitivity. I have divided my slides in a very simple. I am directly getting into the core of the topic. Cores of the pros of metformin, the cons of metformin. So first initial slides are purely the pros, next couple of slides are the cons, and then we take a tally and we shall see at the end whether it is still reigning the supreme OAD in the treatment of diabetes or not. So pros. No challenge here. We know that type 2 diabetes, especially the obese individuals, the drug of choice still remains metformin, especially in case of insulin resistance. We know it inhibits gluconeogenesis. It also enhances the GLUT1, that is a glucose transporter 1, mediated glucose transported into the hepatocytes, increases GLUT4, which is glucose transporter 4, mediated glucose update in the skeletal muscles, absorption of glucose from the intestine, and stimulates the glucagon-like peptides, GLP-1 release. So definitely no sort of a controversy there, used very much widely in the treatment of type 2 obese diabetic. GDM area, gray area, still a lot of people use, still a lot of people may prefer insulin. We know it's a category B drug, but the mechanism of action of control of sugars in a pregnant lady remains the same, reduces hepatic neoglucogenesis, enhances peripheral glucose uptake, and also increases insulin sensitivity. PCOS, polycystic ovarian syndrome, the important thing is it reduces the symptoms of a PCOS lady. So other than insulin resistance, other than better sugar control, also symptomatically these people feel better, reduces the body mass index of ladies who have polycystic ovarian syndrome or a disease, assists fertility, and thereby reduces the inflammation associated with PCOS as well. Obesity, it contains a primary anaerotic factor. So leptin levels are found to be much decreased. GLP-1s we saw in the initial slides were on the higher side, which promote a weight loss on patients taking metformin, increases mitochondrial biogenesis, decreasing fatty acid uptake and stimulating thermogenesis, and promotes sugar dysplasia, restrains reducing inhibition caused by insulin-induced expression of glucose transporter protein, thus increasing glucose utilization. So in obesity, definitely a valid role of metformin. What about people who get obese on medication? So especially the example which comes to mind are antipsychotics. Remember, most of our patients who go to a psychiatrist come to you, they are a little on the heavier side, increased BMI and thereby increased sugars. So those who put on 10% of their body weight on a drug are the ones who qualify for a metformin therapy. Again, the logic remains the same. Metformin contains an anaerotic factor, decreases leptin levels, increases GLP-1, all three reasons causing a weight loss. Cancer, surprisingly, when I looked up online to prepare for this topic, a lot of cancers, breast, liver, bone, pancreas, endometrial cancers, colorectal, kidney and the lungs are known to be benefited. How does it do that? The proposed mechanisms are through a tumor suppressor gene, the LKB1, which activates the AMPK. This AMPK you will see as a nomenclature in the coming couple of slides, which leads to a couple of things in the body's metabolism, whether it's inflammation, whether it's cancer reduction, and this leads to also in a cancer patient inhibition of the mTOR signaling and thereby disrupts the protein synthesis and suppression of cell growth and proliferation. It also reduces the secretion of pro-inflammatory factors, and importantly, because it's an anti-diabetic, it will decrease the sugars and thereby the milieu interior, as we saw in a physiological days. If the milieu interior is returned back to the homeostatic state, the cancer cells find it difficult to proliferate. Aging, same concept. So whatever worked for cancer works for aging. So by inhibiting the mitochondrial complex 1, it decreases DNA damage, it attenuates cell inflammation and suppression of inflammation and autophagy, all of which contributing towards prevention or delaying of aging. Liver disease, Diabetic patient, metformin caused around 50% reduction in hepatocellular carcinoma. Incidence improved survival, mainly again through the same mechanical cell pathways of cell growth, angiogenesis to the PI3K, the AKT, and the mTOR signaling pathways. So these three pathways basically, by reducing inflammation, are seeing in the benefits of metformin in aging, in obesity, in cancer as well. Cardiovascular disease, it ameliorates HDL dysfunction and reduces LDL. I think these two functions there and then in the first point itself can make it clear that it's going to help in cardiovascular disease betterment. Reductions in HDL dysfunction improve cholesterol transport and diminish the cardiovascular risk, and improves endothelial oxidative stress levels and attenuates hyperglycemia-induced inflammation. So again, useful in CVDs. Renal disease improves kidney fibrosis, normalizes kidney structure and function. Appropriate dosage of metformin is very important to note. I mean, this slide comes with a caveat. You can't give it at an end stage, especially GFR less than 45 to 40, but can be given otherwise. Summary of the pros in a nutshell here: obesity, liver disease, cardiovascular disease, diabetes, renal disease, aging, cancer, a lot of pros over there. Cons in a few slides onwards. Lactic acidosis. Now, most of the clinicians sitting here would agree with me. I think it's more of a theoretical side effect. We all have read it up in our pharmacological days. We mug it up. We want to write it in our theory papers. We tell it to our examiners. But how many of us have actually seen it after decades and decades of practice? So still a few caveats. It decreases the liver uptake of lactate. There is no doubt about that. It does that. And any condition that precipitates lactic acidosis becomes thereby a contraindication is a strong word. I think becomes a caution that in case of infection, recent surgeries, kidney or liver damage, history of heart disease, respiratory failure, excessive alcohol consumption, dehydration, you need to be a little careful if your patient's on metformin at these points. And does that by increasing the anaerobic metabolism and thereby the lactic acid production. B12 deficiencies, this is simple. It just causes increased bacterial overgrowth in the intestines and thereby decreased absorption of, increased consumption of B12 by the bacteria and thereby a serum B12 deficiency. Also inhibits the calcium dependent absorption of B12. Hypoglycemia, this is only and only in combination with other risk factors such as heavy alcohol drinking, dehydration, excessive use of other drugs for diabetes, insufficient calorie intake or bouts of heavy exercise. So patients who do all of that and consume metformin thereby stand a risk of developing hypoglycemia. Anemia secondary to B12 deficiency. The B12 decreases thereby causing the anemia. It's a secondary result of B12 deficiency. Cognitive impairment, two studies I have put forth. One is a larger subset of 7,000 patients. Other one is a smaller subset of around 1,500 patients. One has shown definitive impairment. Again, it's a controversial area. Others have shown yes, but it's elevated immediately the moment you put them on B12 and a calcium supplement. So the relationship actually between metformin and cognitive dysfunction is a little controversial. GI, all of us must have seen this to an extent. A little of bloating, a little of gastritis, a little of heartburn is seen with metformin, but that's in a way quite a bit tolerable, and the patient keeps on taking. The GI side effects actually become lesser with increased duration of usage. So to conclude, I think the pro slides were 10, the con slides were 6. So I think my take-home message then becomes metformin still retains the supreme position as the first choice of oral anti-diabetic drugs. Thank you so much for a patient hearing.
Thank you, Dr. Ambul Saraf. Now, house is open for the questions or the comments.
Hello. Dr. Saraf sir, I have a question for you. Lot of thyroid patients have infertilities. Can we utilize metformin in those patients?
So thyroid with diabetes, you could try. See, the point is a lot of these slides put forth the usage of metformin in a lot of case scenarios. So exclusively a infertile lady comes to you with hypothyroidism. Will metformin work to induce fertility? No, it doesn't work that way. You have to look into the factors. So if she's a type 2 diabetic, if she's obese, she has a lot of inflammatory changes, she has other conditions, you treat all of that. So in that entire basket of treatment available for infertility, metformin will work, yes. But if it's the only drug you are going to give it to her and say that this will cause pregnancy, it doesn't work that way.
Okay, thank you, sir.
One more question I want to. A PCOS lady who is already on metformin getting pregnant, what does you do for metformin? You continue for how long?
I put on insulin. I still believe a little old school when it comes to GDMs. I would still put them on, but then if they are already on metformin, they subsequently become pregnant. See, the entire thing, the organogenesis is very rapidly happening in the first trimester. So such other ladies I monitor very carefully, especially if they are PCOS females and they have become married and they're planning a pregnancy. I would ask them for a regular UPT, a regular follow-up. And the moment they do become pregnant, I actually in my clinical practice shift them on insulin, control the sugars. But as the slides and the research have shown, metformin does help a lot in the fertility and PCOS symptomatology. A lot of people, I'm sure the audience here and Shah sir is also here, would have used metformin a lot in GDM as well. But so
we continue to use. Dr. Badlani, I would revise your question into that if would you continue, Amit, if blood glucose is normal? There are two different situations. If blood glucose is high, then is a different story. You will need an additional agent. But if blood glucose is normal and patient has conceived, patient was taking prior to. And in relation to the first question of infertility, if a woman has PCOD, and a metformin is given and that induces probably a better ovulation, would result into fertility. Patients have come and said that we got pregnant because this medication helped us. Yes. So that kind of an association could happen.
Yes. For sure. I think sir has very rightly said, so I'll just take on the single point before Dr. Agarwal makes a comment. That I think, see, so a normal, not every PCOS lady is a diabetic lady and we still put them on metformin. So normoglycemia per se, so if you, for example, a lady is normoglycemic, she's having a polycystic ovary and she's on metformin, that is not an indication to stop metformin. In fact, metformin is being therapeutic in that case scenario. So
I think we shouldn't go home with the message that you should stop metformin. That's the first thing that we should. And second thing is people with PCOS who are given metformin and they become pregnant, irrespective of the fact that, okay, if they have a hyperglycemia, the fetal wastage is much lower with people who are on metformin. So people, PCOS who are on metformin become pregnant, continue. Because,
but,
yes,
but
because
when one
the
should
fetal
stop?
wastage and the take-home baby rates are higher in people who have been on metformin.
Withdraw.
Our only objection to is because we had all those MIG-TOFU studies and all those things which talked about fetal adiposities, childhood adiposities in people who are on metformin. But these are not sort of proven studies as yet. So it's not like the standard.
Should he continue throughout the pregnancy or stop during third trimester? Because
So
they say it can cause premature.
That's a little gray area that we have right now. But at least in the first and third trimester, I don't see any reason why you can't. The second trimester.
Continue in high-risk ladies, otherwise you'll have resurgence of hyperglycemia during the 7th month. So that one, please continue.
Thank you, thank you.
And the last question was in relation.
Can I have one? I'm sorry, sir. So how do you use this metformin while a patient being treated with AKT? Like patient in COX and metformin, because metformin has some AKT properties. So how do you manage that?
So again, dosages, you look at the liver profile, the liver HGOT, SGPTs, pre and post AKT, monitor them very well. Not every single patient who's on AKT and a metformin will have a liver damage per se. So you monitor, it's an individual case scenario. Those people where you see the first indication of OTs and PTs going higher side, patient having symptoms, you obviously shift to an insulin. So
what about the loss of appetite and cachexia? Metformin will enhance that cause of weight loss by TB.
Initially, yes. But actually, if you see in clinical practice, there are so many scores of a patient who are taking metformin for decades together. Not all of them are nauseous and anorexic.
No, while they are on AKT, they have already a factor for nausea, AKT itself.
Yes.
But the weight loss.
But the moment the AKT works, the feel-good factor is the factor which is actually inducing appetite, more appetite, putting on weight gain. So actually a patient, when he goes on AKT in 4 to 6 weeks, as they say, the feel-good factor, which the patient comes back and tells you, bhook lag raha hai, khana ja raha hai, a couple of kilos he starts putting on. So irrespective of metformin, what I'm trying to say is, look at the liver enzymes and decide. not on symptomatology. The liver enzymes are the key. So any which way you are going to do a baseline LFT before putting on AKT, the person is already on a metformin to begin with. The moment you see a rise in the, so next time when you call him with a sugar report, you might as well call him with another LFT. The moment you see a 10% rise or 20% rise in the LFTs, then might as well stop metformin, put him on a insulin. Any which ways scenarios, a lot of patients where you want a good rigorous sugar control in these situations, insulin becomes the drug of choice.
Thank you.
Thank you so
Sanjeev
much.
bhai, you want to say something?
I studying the aging related issues and centenarian population. And people who have reached centenarians had been 20% lower calories. And on anti-aging and longevity drug, there had been only 2 drugs. One of them had been a metformin, other was resveratrol. And all the studies showed that people who lived 100 years had lower insulin, lower glucose level. So creating a glucose deficiency within the cell, preventing a cellular signaling and all those things, what you achieve with metformin mimics those who have lived centenarians with or without metformin. So you need metformin for anti-cancer, anti-aging and all of them. Only thing at which glucose level you can still take, what dose to take, probably we'll have another session.
If there are no more questions, thank you very much, Dr. Amit Saraf and Dr. Sanjeev Shah. Now I will hand over the mic to the organizers for the next section.
Thank you, our esteemed speaker and respected chairperson. We are moving towards the next session. The next session is on diabetes and obesity. To chair the session, I would like to call upon Dr. Malay Parekh and Dr. Sandeep Desai for the next session on diabetes and obesity.
Yeah. So this is a pre-lunch session, I think, and the session is on diabetes and obesity. We have 2 very well-known speakers, Altamash Sheikh and Dr. Sanjay Agrawal. Dr. Altamash Sheikh, yeah. So he has done his MBBS, DNB, and DNB Endo, fellow IAD, and he's a consultant endocrinologist, diabetologist, and metabolic specialist at Saifi Hospital, Mumbai, and scientific committee ISB MR, FriendCon Thyroid. He's a treasurer at Maharashtra Endocrine Society. He has a Rising Star 2020 state ranker, best paper, best on outgoing distinction holder, speaker for various national and international conference, and he has co-authored in abroad various peer-reviewed journals and textbook chapters. Over to you.
Thank you so much. Good afternoon, everybody. I think a very, very complex topic. We're going to have very easy slides, a very simple understanding of how body weight is regulated. How do we take this patient's journey through the complexity and chronicity of obesity? Some understanding of the molecules of obesity, which of course my co-speaker, Dr. Sanjay Agrawal sir, is going to talk about. So let us look at what is normal. Generally what we hear from a lot of scientific bodies, from a lot of scientists actually, these are all done by the physiologists of their respective countries. So what is that normal thing that we are trying to harp upon today is that a simple equation which may not be fit, which may not be true for all the patients at all the times, but importantly, an intake should be equal to kind of expenditure. And what is that difference? Those pointers that we're going to talk is hunger, satiety, and nutrient absorption. Can anybody tell me what is the meaning of satiety? Satiety, yeah, it's a very common word when you talk about obesity, food. Dr. Banshi has really kept very good lunch, I was told. Satiety is the feeling of fullness in between 2 meals. So from your breakfast till your lunch, how much full you are, that is satiety. Or between your lunch till your dinner is satiety. Then what is satiation? Satiation is the feeling of satisfaction of food within the same meal. The moment you take your lunch plates and you're about to feel full your tummy, you feel that no, I've eaten sufficient, that is satiation. So these two things are very important. Satiation will give the signal that yes, stop the meal, now I don't want to eat anything more. But satiety is the one which decides what next you are going to take. It may be a new word for many, but this is what we need to understand. And apart from these three, how do you do the expenditure of energy is by knowing about exercise, by knowing about what is the thermogenesis of that particular patient. Some slides will show you about metabolic rate and about the NEAT. This is NEAT NEAT, this is the medical NEAT, which you have to understand, even make the patients understand. Anybody, what is the full form of NEAT? NEAT? Non-exercise activity thermogenesis. This gentleman who came in the yellow shirt and the lady who came in the green dress, they are moving, right? They did something with their bags, they did something with their paper, whatever she's trying to do. That's an non-exercise activity thermogenesis. The gentleman who just sat there in the black shirt, that activity is that. What all we are doing, me and Dr. Sanjay Agarwal and my chairpersons right now, we are completely static. There is completely no thermogenesis except for the basal one. So the gentleman taking a photo is an activity. So in a lecture of obesity, we would expect people to actually do some kind of activity. Maybe some people can stand at the end of 5 minutes and sit down again. That will be counted as a non-exercise activity thermogenesis. It is very important to teach our patients that what they should increase from their routine. Let's look at this particular slide, the energy intake, body weight, and expenditure. So that is what we've just explained about maintaining the balance. Most of the times our patients say, doctor, but I do not eat more. Please do not discourage these patients. This may be true because obesity doesn't happen to people, only those who eat more. I repeat this sentence. Scientifically, obesity can happen to people, those who are eating actually very less. I'll show you all these slides, how it is possible. There's a data on that. Energy balance, if you're looking at this particular patient, that the patient is eating food, there is something called as a resting energy expenditure. Dr. Sanjay Agarwal is my next speaker. He's not going to move at all because he's trying to see his last slides through his phone, right? So for example, if he moves nothing, he does nothing for the next 15 minutes, that's his resting energy expenditure. Some people, those who have sat already before I started, they also are in a state of a resting energy rate or their resting metabolic rate. That is what is your activity. Now, the physiological stress, some people are feeling cold, people are trying to set their jackets as this lady who did over here. Some people are looking at where is the warm tea that I can have before entering this particular session. Some people were talking about metformin, some people may have had tea with that cookie which is kept outside. So that heat production in response to current food or the energy that is produced or required during this particular process is your diet-induced thermogenesis. How many of you had tea and cookie before entering this hall? Maybe 1 hour before, 2 hours before. Okay, I saw a lot of you. Yeah, you can, don't try please. Yeah, very good, thank you. At least 70% of us have had. You people at the moment are in a diet-induced thermogenesis. The slides are very boring. I'm trying to make as interesting as possible. Now this activity, this man is trying to move from one place to another. The guy in the blue shirt, I don't know why he moved. That exactly is what is your spontaneous physical activity, which included change in his muscle tone because he changed his posture, change in balance, the second guy is trying to do that, and fidgeting with their devices, the cameraman did that, and even unconscious movements, again somebody's trying to put the hair properly and itch over here. Please, this is not jhukega nahi, right? So these are all your non-exercise activity thermogenesis. Let's further bore you all with this particular thing. Exercise-induced thermogenesis. How many of you ever walk in your life in the morning before breakfast? Oh, that's a very good number. I'm very happy with Gujarat. How many of you walk ever in your life, whether morning, evening, night, anytime? All walkers, all walkers. Okay. Oh, I'm in love with Gujarat. Okay. So that's a nice thing. Please continue your exercise. These are the 4 ways, these are the only 4 ways physiologically that energy can happen with a physical activity. And why does it happen? It is because of a very nice balance between orexin and anorexin. What is the meaning of orexis? Anybody? Orexis means hunger. Orexis means bhook lagi hai. That is in Greek. And orexin is the hormone which is also related with hunger. Yes, we know that ghrelin, there are many other hormones which are there, but that's why anorexia nervosa, people are very thin, because there is no appetite. Somebody did talk, I think Dr. Asked about a question that with anti-tubercular therapy, if their appetite is gone down. So he was talking about anorexia in tuberculosis, right? So this is a list, and that is a list of anorexogenic hormones as well as orexigenic peptides and hormones which are central as well as peripheral. You do not need to remember these. What you need to understand is this, that when there is an action in hypothalamus or arcuate nucleus, which are the first order neurons, your satiety peptides of PP, PYY, GLP-1 and oxyntomodulin, they come into play with the hunger signal. Now, the moment I talk about that there is a very good lunch which is kept outside, the hormones start. What will be in the lunch? This is a conference after 3 years maybe for some. This is a conference which is after 3 months for some. But it's a Hayat Regency, so food expected is to be really of good dopaminergic related satiety signal. A lot of you like moong dal halwa, right? Is there somebody who doesn't like moong dal halwa? It's related to this slide. Very excellent. Can you tell me what do you like? If not moong dal halwa, any one thing that, just tell anybody. Yeah. Gulab jamun. So moong dal halwa by and large is a dopamine secreting food. Instant मुंह में रखते ऐसा लगता है पता नहीं क्या गंगा नहाए. Right? That's the feeling that you really feel good. Maybe that gulab jamun is maybe for you it could be ice cream, maybe for you it could be a shahi tukda. So these food should be really taken in lesser quantity when you are about to eat that, because these are the ones which are going to put weight on you, and they may actually further increase appetite. After eating one gulab jamun, do you eat one more or no? Where are you? Who was that? Yes, see the yes. So look at that. Yes, okay. So that's how the regions of the brain stem, and the signal satiety, amylin, and GLP-1 again from the intestines that yes, we've received our quota for the time being for the day, and that's how the whole feeding, the whole gastric emptying, and the metabolic rate is decided. Now, I will show you 3 important things: prakritik eating, vikrutik eating, and vastavik eating. Okay, this has got a scientific thing. It is there on slide. Nothing is from Altamas Sheikh's house. This is called eating for hunger. This is what? This is prakritik. This is absolutely natural, right? Lunchtime, even though Altamas Sheikh says whatever I am going to eat because that is how my body is designed for, including our chairpersons and my co-speaker. Eating for hunger, eating when you need, is a natural phenomenon. That's the homeostatic eating. But I have attended a very good lecture in which I learnt weight loss, and I'm very happy about it. So let me eat something. I have got up at 4:30 in the morning. I took my flight, but I was there at the airport. The flight was late. So I will eat something really good today and something really extra, because I need to have energy, because there are a lot of good functions by evening. And that's how we would take it as a pleasurable eating, or because we are in a different place away from house, we would eat food in a pleasure. Oh, we are meeting Banshi Bhai, I'm going to eat something really nice today. Maybe that would be something for that. Pleasure eating. What is the third one then? Anybody? There are 3 types of eating, right? I told you in the start. If you're not eating for this, this is normal. If you're not eating for this, which is again normal, there's something which is causing the other kind of food. I already told you what's dopamine controlling want, and that is deciding to eat. Today, whatever Altamas Sheikh has said and Sanjay Agarwal has said, I am going to eat. It's my gala dinner time, right? That's how you decide. It's a compulsive eating. It could be an abnormal eating. It could be decide to eat. You're sitting in a plane, you've had very nice dinner, you're going to your home place, but the lady has served you food in the aeroplane. You decided, I will eat, face to jayega. But your tummy is not a dustbin, my dear, right? So decide to eat at the right moment. So your feelings of being in Daikar Con have really signaled your thoughts that your appetite is gone up, and your behavior is whether you decide to eat or you don't decide to eat. So that thought, feeling, and behavior is an absolute ongoing triangle. It's a circle that goes on in continuity, and that's what is the chronicity and complexity of obesity. Now, apart from the physiological part of this chronicity and complexity, what are the causes or etiopathogenesis of obesity? Once again, similar wordings in the slide. What does the mind think? Where does this food processors go from? Adipose tissue comes into play, the pancreas come into play, alpha, beta, delta, gamma, all cells, gut, a lot of hormones, your genetics comes into play, and certain medications. If you are on a medication like Dr. asked a question, AKT and metformin, he will have further lowering of appetite. Yes, that's very much possible. Added with palatability or pleasure. Somebody on the flight was constantly saying, if you are coming to Ahmedabad, you have to go to, what is that place? Manek Chowk and eat. I don't know what is available in Manek Chowk in Gujarat. So that was the talk of the town. Everybody, like, chala ave Manek Chowk javanu che. So that's how I learned one more line in Gujarati. Environment, inactive lifestyle, smoking cessation, psychological factors, and genetics and your epigenetic. The high heritability, I'll be done very quickly. High heritability of body weight, genes in hypothalamus, leptin, other pathways, and all these predisposed to weight. These are 300 plus SNPs. Do not get disheartened. I'll tell you very simply in one line. You need to take care of yourself. That is what this slide says. There are so many loci, there are so many genes distribution, fat distribution, more than 100 genes even here. The inherent factors for predisposing are socio-cultural. If I am watching this lecture online, I will eat maybe something healthy in the room, but I finally decide to order something else from the hotel menu. But however, if I am in my clinic and I am ordering something else, my food content, calorie, protein will be different. Traditional beliefs and peer pressure. Socio-economic factors, food environment, very important. What the person next to you is eating also influences a lot of time with our plate, and availability of inexpensive, highly palatable food which is there. There was one person in the flight who said, I will buy that 15 kg fafda from Ahmedabad. There's one street where crores of fafdas are sold in the evening. Is that true? Yeah. So this is what is highly palatable food. So associated with multiple comorbidities, and the ones in the dark are really to be taken into consideration, because these are very well documented, and of course they are divided as metabolic M1, mechanical as M2, mental as M3, and monetary factors as M4. M4 is not on the slide. So what are the benefits of weight loss and concept of weight gain in the last 2 minutes? We'll take it from there. Benefits of weight loss are many. For example, if somebody is of 100 kg weight as on today, 5 to 10% means a 5 to 10 kg weight loss for that particular person. A medical weight loss, a slow weight loss, a gradual weight loss, and a maintained weight loss. These are the terms which are very important to talk to the patient and the relative, because we have to give a realistic expectation. You cannot say, I want to reduce 20 kg in 1 week and let 2 Katrina Kaifs come out of me suddenly. No, that is an unrealistic weight loss goal. So the goal has to be absolutely correct at the start. Reduction of type 2 diabetes, absolutely, with a 10 kg or a 10% weight loss. The risk reduces. Remember, remission is a totally different ball game over here. Reduction in mortality, yes, benefits are there. Improvement in lipids, blood pressure, OSA, apneas, and improvement in quality of life. This is what would improve with just your 5 to 15% by reducing weight. So a lot of benefits are there, including your cholesterol, your osteoarthritis, stress continence, and a skin problem. The challenge is to maintain the lost weight, and that is the reason we need to have talking to the patient about the realistic goals and maintaining their nutrition for a long time, because there are diet-induced changes then after the patient has, when he or she has lost around 10 to 20 kgs depending on the goal that you've adapted. And why does the patient regain the weight? Now that those who attended the first 2 slides of the talk, these are the ones with the changes in hormones of satisfaction of hunger and changes in or increase in hunger hormones with the lost body weight. Supposing this patient has now 90 kg, this is what would happen. Satisfaction goes down, but hunger increases, which is again compensated by decreasing in the total energy expenditure, and the brain thinks that my body has got a disease because my fat mass has gone, some amount of protein has gone, I need to come back to my original weight. So you need to work out now with the newer metabolic rate, with the newer metabolic parameter. Anybody, what are the symptoms of obesity? We learned satiety, we learned satiation, we learned orexin. Symptoms of obesity are hunger, increase in hunger, and weight gain. Yeah. So very normally, very usually in the clinic, patients don't say, "Doctor, मेरा weight gain हुआ है." Some people are really funny. They say, "Doctor, मुझे कपड़े पहनने में difficulty हो रही है." Can you believe this was a chief complaint of a patient who came to me with blood pressure and diabetes the first time? I said, "Why did you do your blood test?" क्योंकि कपड़े पहनने में difficult हो रहा था. Because that person put on weight. So it's a very important sign. Sometimes I think we need to really look into history. And I think this was one of the biggest loser series which was there in the TV in around 2013-14. I'll show you the main slide directly. These people had lost 58 kgs, but they regained 41 kgs. That was because of this resting metabolic rate and metabolic adaptation. So my time is up, and I would call upon to my chairpersons. Thank you so much. We'll come back in question answer session.
So thank you so much, sir, for wonderful talk. So now I request welcome Dr. Sanjay Agarwal, sir. It's my honor and privilege to introduce sir second time in the consecutive days. So sir is a director, retail clinical diabetes care, head department of medicine at the Ruby Hall Clinic, senior consultant in diabetes and medicine at Jahangir Hospital, fellow of American College of Endocrinology, fellow of American College of Physicians, honorable secretary governing council of National RSSDI, member editorial board BMJ Open Diabetes Research and Care Journal, and associate editor IJDDC, and member of writing committee for RSS guideline.
There, I think we have enough time.
So without wasting time, over to you, sir.
Thank you very much, Malay. I think I enjoyed the talk by Altamash, and it kind of set the tone for my talk. And I think we all realize how difficult it is to manage weight. We swing from weight loss to weight regain, and then we come back again to weight loss, and the cycle just keeps continuing. And weight is a very dynamic, sort of parameter. We don't know what the optimum weight should be, but obviously whatever our current weight is, we obviously benefit by a weight reduction. The question keeps coming in is, how can we sustain the weight where we are and where we take it to? Obviously, we don't want to take it up, we want to take it down, and that's where the challenge lies. So I'm going to take a step further from what Altamaj just talked about, the physiological patterns of energy and how the body tends to regulate that. And we're going to modulate that with pharmacological and lifestyle interventions to see how best we can make this possible. These are the disclosures. But this is how I'm going to discuss my talk today. And we're going to talk about what are the options available for obesity management, the guidelines to integrate available treatment options, and transition from guidelines to clinical practice. Remember that we may have all the guidelines, all the knowledge. It's just a question of how can you discipline your mind and make whatever you learn, work. And unless you make that possible, we'll just be sort of having a lot of theory, but yet, we may not achieve the results that we're really looking for. And you have to always make small changes first to make an impact on the larger canvas. We don't sort of give them large goals to our patient and say you need to reduce 30 kilos of weight or 40 kilos of weight. That seems very unrealistic at all. So if you can encourage them to make small changes and make that happen, that gives them a kind of a boost to see that they can do it. The key factor is in all our practices, we need to have conversations related to obesity happening. When you see a patient with overweight or obesity, we don't really bring up conversations related to weight with them, and we tend to neglect that. And we all know today that obesity is the mother of all non-communicable diseases, wherever you look at it. And if you look at this time's ADA, majority of the lectures were focused on obesity management. And we have now more and more pharmacotherapy that is coming in for obesity management. And we are seeing new innovations that are happening in obesity area rather than diabetes area. And we know that if you can target obesity more effectively, then you're going to get better, downside better control of your blood pressures, your sugars, and everything that you look at, lipids and everything. So there is now a shifting focus towards obesity management, and the physiology which Altamash just spoke about is how can you modulate that physiology to see that, can you intervene with lifestyle and pharmacotherapies. So today, what is the options that are available for us? And this, I think, remains a key slide through my talk, that you always begin with healthy eating habits, physical activity, and behavioral therapy. And Altamash just spoke very well how simple activities can build up energy consumption. And if you can encourage people to do simple activities, it will definitely go a long way to keep them active. Very often we find that people just don't move, and they tend to then develop a lot of musculoskeletal problems, and that makes it even harder because the obesity just contributes more and more to musculoskeletal problems, and that sort of the vicious cycle continues of weight regains happening. Now, if you're not really successful when it comes to lifestyle interventions, then you obviously at some point of time want to see, can we intervene with pharmacotherapy? And ultimately, of course, for those patients who really have a major problem with comorbidities, then perhaps surgery may be the only solution for these people. And we are now, of course, understanding more and more the role of surgery. But let me sort of flip that around and say now we're getting better agents in terms of weight control with the newer molecules that are coming in, which promises almost to the tune of 20% or 23% of weight loss. We don't know whether surgery may be the best option for morbid obesity in future. And we may have better agents to control our weight problems. So let me just sort of, dwell a little bit on the lifestyle approach, because I think that remains the cornerstone. One is, of course, as the energy pyramid, energy cycle that Altamash spoke about, the energy intake and expenditure. So obviously, reduced caloric intake is a very important part of it. And you need to make this very individualistic. You cannot sort of have one size fit all for everybody and say that this is going to be a meal pattern. Then I hate it when the nutritionist will just come out with charts and say this is what you need to follow. Because every patient or every individual has his own tastes, and you want to see that if you go across India, even our cultural tastes are so different that if you go from north to south and south east to west, our patterns of eating tend to change. So you can't have a sort of a meal pattern that is going to be universal all across the country. Even the consumption or the composition of proteins, carbs and fats in every individual meal for the same sort of a dish cooked by different people may be different. So you need to be very individualistic in your approach when it comes to caloric restriction. So energy restriction remains a key. Intermittent fasting has been one of the ways that you can do a time-restricted feeding. And this is important because we have seen benefits out of time-restricted feeding and intermittent fasting. But again, it comes down to the fact that how long can you sustain it? Most of these therapies tend to fail after a period of time because the whole own human nature of eating. In India, eating is a religion. And unless we give a good food all across, come to meetings, come to religious functions, and a success is gauged by the fact that what is the food that is laid out there. And unless you really control that part of it, you're never going to be successful in terms of weight management. So you have to learn to say no. And unless you learn to say no, you're not going to be very successful out there, right? The second part is, of course, you need to encourage them to do a mix of exercises. And I sort of disagree with people who say, I walk 10 kilometers a day. I think walking is the worst exercise if you're doing only 10 kilometers a day walking. You have to do a mix of resistance training and endurance training. And if a good exercise physiologist will tell you that you need to balance out an endurance training with resistance exercises if you need to get more energy consumption out of an individual. So anybody who tells you that I walk 10 kilometers a day is not going to be a very successful in terms of their weight management. You have to encourage them to do a lot of resistance training, which is going to be very useful from their point of view. And then, of course, you need to set your own goals, what you're looking at. As I said, that if you're going to keep large goals for individuals, it's going to be a failure right from the beginning. Keep them on smaller goals. And that's why if you look at all the algorithms that we had earlier, we would talk about, we would say absolute numbers of how much weight loss you need to effect. And that was never a beginner. Now we talk about, as
Altama showed in his slides, 5% weight loss, 10% weight loss, or 15% weight loss, the gains that you get out of it. And if you tell somebody, just do 5% weight loss in next 3 months, it's more achievable by that individual. And he says, yes, I can do it perhaps. So then you say, okay, you've achieved your 5%, you do another 5%. So ineffectively, he's done 10% accumulated put together, and that is getting the benefit. It may be spanned out over a period of time. But you need to do goal setting for individuals, and you have to see how you can make it possible and encourage them to achieve those goal settings. And then, of course, mental distractions are very important. Like I said, as you were just pointing out all the possible things, how, mental attractions to food are there. The similar, you have to have mental distractions from food. And if you can do mental distractions from food, I think that's going to be a big achievement. I was just reading a sort of, paper while on my flight coming, which just figured in Nature, I think this month or last month, and I was reading that paper. And what they looked at was morning calorie loading versus evening calorie loading. And some of the earlier studies did show that if you have an evening calorie loading, then you tend to have a weight loss happening. And if you do a morning calorie loading, then you don't get a you get a weight gain. Evening calorie loading, you get a weight gain. And if you have a lower evening calorie loading, then you tend to achieve a weight loss. And this is how the circadian rhythm sort of behaves. Now, this paper was very interesting. They said that they looked at people who did a morning calorie loading versus evening calorie loading, and they found there was really no change in the weight. But what it did tell us was if you do a morning calorie loading, then there is a suppression of appetite that tends to happen. And sustenance of weight is much easier if you have a morning calorie loading versus an evening calorie loading. So that's something which is possible that you can tell people. So people who have large breakfasts tend to have a lesser appetite during the day and tend to eat less as compared to people who tend to eat more during. So the key thing is all of us, if you look at it, all of us tend to overeat at 5 p.m. And that 5 p.m. is a sort of a killer time when we tend to eat everything inside, because it's more like a fatigue, beating a fatigue by eating more. Or when you go back home after a day's work, you just grab everything inside because you're just hungry. And you may have done huge amount of calorie restriction during the day, but you break off at 5 o'clock and say, I'm going to eat everything inside. So that 5 p.m. is a very key factor, and that's been shown in various studies, that if you can sort of beat that 5 p.m. fatigue, so that's why people come out with all kind of, 0 calorie foods where you can say, okay, can I get a satiety at 5 p.m. and that will help me to beat that part of it, and maybe the calorie restrictions can continue. So these are all important in their own way, that how you do your meal planning and how it works. Now at some point of time, all this is good, but it doesn't help. And you want to see that what is the next step forwards when it comes to, changing your weight. And today, earlier we had very limited options when it comes to pharmacotherapy, but today we have got a number of them available. So when would you really require to start pharmacotherapy for obesity management? So when you have attempted good, decent lifestyle changes, but you could not achieve it, the goal. Or you're regaining the weight after losing it, and you want to break that cycle by saying, can I intervene and prevent the weight regain from happening? So something that becomes a habit will sustain then. And the last thing is, of course, people who have got a BMI between 27 to 29.9 with a weight-related complication, any of the comorbidities like sleep apnea, hypertension, or with a BMI of more than or equal to 30, these would be candidates where pharmacotherapeutic intervention would be beneficial. Now, these are the plethora of agents that we have today. Some of them we don't have in our country, but they are available. Orlistat, naltrexone with bupropion, liraglutide 3 milligram, phentermine with topiramate, and semaglutide 2.4. So other than orlistat, we don't have most of the other agents available with us as combinations for weight management. But just in a nutshell, if you look at the mechanism of action of orlistat, it's energy wastage. Naltrexone, bupropion, it's appetite, and all the other 4 actually appetite suppressants, and semaglutide 2.4 is appetite regulation. And what is the weight loss that you achieve? If you look at from orlistat, from baseline 1 year, intervention costs about 10.6 kilograms compared against placebo. Naltrexone, bupropion, baseline to week to 56, the intervention arm had 5.4 to 8.1% versus placebo 1.3 to 4.9% depending on the dosage. And liraglutide 3 milligram from baseline to 56 caused 8% versus 2.6% with placebo. And phentermine topiramate caused 5.1, 10.9 versus 1.6, that's again dose related, and semaglutide 2.4, 14.9. So 15% was what's 2.4. And if you look at the tirzepatide, it causes almost about 17 to 20%. And we are now initiating trials now with cargillinotide with semaglutide, and that we anticipate is going to be 20 to 23% of weight loss that will happen. And we are just one of our centers is the one which has been chosen for the trial for Cargi-Sema. So we are looking at how these pharmacotherapeutic interventions are going to be helping us in terms of weight reduction. And if it successfully works, and the main thing is patient tolerance to these agents. And that's the key limiting factor, that if they can tolerate, and if you look at the last line of adverse events, you'll see all across the board, all these agents have a predominantly GI intolerance. And if you can sustain that GI intolerance for a while and patients are able to continue, then of course it has a lot of success in terms of weight management. I'm not going to, because of want of time, get into this, but these are the various sites where all these agents tend to work. Now, when would you really offer surgery? And this is an option for selected patients. So it would be an option if the BMI is between 30 to 39.9 with an obesity-related comorbidity, or if the BMI is more than or equal to 40 kilogram per square meter. Or when there is a sort of complication to reoperations. Or gastric bypass is associated with a 30 to 50% lower risk of death in patients 7 to 15 years after surgery versus those who don't. So the bottom line is, patients with morbid obesity, if nothing else works, then your option is only surgery and you don't have any other choices. But remember that all patients with any form of metabolic surgery, it's not that the lifestyle intervention should not be continued. It still remains a cornerstone. And the discussion that favored around was that when you look at patients with post-bariatric surgery, even in those patients, weight regain remain a problem. And you find that after a while, even post-bariatric surgery, people tend to get a weight regain. So the argument was that if you have given a metabolic surgery to a patient, then why can't we maintain them on pharmacotherapy to sustain the benefit of the metabolic surgery? And we now are looking at trials which look at that patients who are left alone after metabolic surgery with lifestyle versus metabolic surgery, lifestyle, and a pharmacotherapy. And you find that there is a better sustenance of the weight after you have a maintenance of a pharmacotherapy added on to the regime. It's like similar if you have a cancer therapy, you put them on a maintenance therapy after your initial cycles of chemotherapy, and you find that the benefit in terms of recurrence rates tend to go down. So similarly, weight regain rates would probably be benefited if you can follow up a post-bariatric surgery with a pharmacotherapy. Now, what are the guidelines to integrate? I hope I have some time. Yeah, okay. To integrate available treatment options. And we can see here that the patients with obesity can be very diverse in terms of their age, race, sex, ethnicity, genetics, complications, and so forth. And there is a lot of heterogeneity of treatment effects. So there will be a great variation in weight loss responses. So each individual tend to respond variably. They may have susceptible to adverse effects of treatment. So one patient may tolerate a particular therapy very easily, and another person may not be able to do that. So there's a difference in terms of the effects of the same treatment that you give to two different individuals. And of course, some treatments may have weight loss independent health benefits that thus some patients may achieve additional health benefits. So obviously it means that treatments have to be individual, and you need to have teams which can monitor. It's just no point in giving a particular therapy unmonitored. It's as good as not giving it, and you may probably not get the benefit, and it'll probably set back the patient in thinking that nothing is achievable. It may have a negative impact value. So you need to have trained teams which can counsel, look at their nutrition. You need to have a psychologist on board, an exercise physiologist, and somebody who can do a follow-up with the patient in terms of seeing where the patient is heading. Now, this is just a very, very crude algorithm where we look at the staging through BMI and anthropometric measures, and then you've got three-tier, treatment pathways in terms of diet, exercise, pharmacotherapy, and surgery, and these are the various guidelines. And the earlier guidelines were more BMI-centric, but now we tend to think that they should be more complication-centric. And look at the number of guidelines that have come from 2014 all the way up to 2020, and we're looking at now a changing shift about how we need to treat patients with obesity. We have, of course, scaled down our cutoff points for the Indian population. So our BMI cutoff now is 25 versus 27, which was for the Western population. And we now take a waist circumference of 10 centimeters more than the upper limit of gender-specific normal for adult Asian Indians. All right. Can I just take 1 minute more of time, if it's okay? All right. Right. So this is the algorithm, and I don't think it's really too much of to understand out here as to where each of these agents tend to work, right? So you have patients with BMI more than 30 or versus 27 with comorbidity, and you look at what are the comorbidities. So if the patient has diabetes, prediabetes, hypertension, OSAs, or PCOS, liraglutide may be the first choice, and this is based on the level of evidence, followed by naltrexone, bupropion, and then orlistat. And you can, of course, if one treatment fails, you can always switch to the other treatment. And when it comes to more of a mental factors in terms of craving, depression, or smoking, then perhaps naltrexone, bupropion may be the first choice, followed by liraglutide and orlistat. And then, of course, you need to sort of add on to all the other measures of weight management. These are the different obesity guidelines in terms of summary. So overweight and obesity are generally defined as patients with BMI of more than or equal to 25 and 30 respectively. With complications, frequently they're used to determine obesity severity. Most expert panel consensus guidelines recommend that following treatment with patients with overweight and obesity, lifestyle management is the way to go. And then, of course, there is a growing role of pharmacotherapy, and then select patients with morbid obesity with multiple comorbidities, then bariatric surgery may be the way to go. And all obesity patients should be used in, treatment should be used in combination with diet and exercise. For want of time, I just want to sort of take you to one slide, which I think is very important. That is the Edmonton obesity staging system. And now we have a proper staging system where we look at stage 0, we look at medical, mental, and functional factors, and we stage them from 0, 1, 2, 3, and 4. And this is how we look at it. So stage 0 is no sign of obesity-related risk factors, no physical symptoms, no psychological symptoms, and no functional limitations. And stage 1 is, of course, patients with obesity-related subclinical risk factors or mild physical symptoms, or there may be mild obesity-related psychological symptoms or mild impairment of well-being. And then stage 2 is, of course, established obesity-related comorbidities. Moderate is obesity-related psychological symptoms and moderate functional limitations. And stage 3 is, of course, with all these graded upwards. And stage 4 is, of course, the severity is in terms of end organ failures. So I'll stop here, and I mean, we'll be happy to take any questions further. So I think that's the end of the talk. Thank you very much.
Thank you, Dr. Sanjay. And questions are invited. We have 3 to 4 minutes. So I guess there might be a lot of questions because this is one of the hot thing.
Yes. Yes, Dr. Ritin. Yes.
So my question is, how do you deal with social factors? When patient is 10 or 15% weight loss, then patient comes up with us that everyone relative is asking me, have you any cancer, or TB, any disease, are you in something problem, why have you so weight loss? So how you manage that social or mental stigma with patient?
You want scientific answer or a social answer for this?
Both.
Both. First, what do you want, scientific or social?
Social.
Social answer is very easy. आपको ना और हाँ दोनों बोलना सीखना है. Okay, when there is something which your doctor has discussed with you, which your dietitian has discussed with you, what you are not supposed to eat at that particular time, learn to say a no, which sir also told in his lecture. Learn to say a no when you do not want to eat something or when you've been told that you should not be eating. This is the answer no for social factor. Now, what is that yes? Tell your people, tell your patients that yes, tell other people around them, their family and friends, that yes, they are losing weight and it is not a crime to lose weight. And when we say lose weight, they are gaining health. तो हाँ, इंडिया में हमारे जो कल्चर है वहाँ पर सूज गया तो कोई नहीं बोलता है, लेकिन सूख गया तो लोग बोलते हैं बीमार है. They will make your patient believe that either he got TB or cancer or HIV. So teach them, you empower them to say that yes, you are on a weight loss regimen, you are on a weight loss therapy. Would you want to add, sir, anything to this?
So what is important is, if you look at two classes of patients, one who have done a very organic weight loss versus somebody who's not done a supervised weight loss, all right? So look at a person who goes on very crash diets and who tends to get fat and muscle loss. They look absolutely, painful and sick. And you see that happening very often. They go by, somebody will say, okay, just stop eating, right? And when they do that, they lose almost about 20 kilos of weight. But you have to remember that besides fat mass loss, they're also losing muscle mass. And you see everything just hanging around, and that looks very bad. That's when they look sick. But if you have a very supervised way of looking at it, where you're balancing your proteins, you're doing resistance exercises, and you're building up the muscle, those people lose weight, but they lose the fat mass, not the muscle mass, right? Those are the people who look healthy, and they get compliments versus the other people who then say that, are you looking sick? So it's a question of how you achieve your weight loss is equally important in terms of your appearances. So people who actually get a proper organic weight loss, they look actually better and more fitter, and they become a brand ambassadors for actually weight loss.
So I mean, physiotherapy is too much important.
Absolutely. More important than your brushing your teeth daily in the morning. So that was a social answer. Scientific answer is that we live in an obesogenic environment. We need to change our genes, which we cannot, but remember there is epigenetics which works on this. Again, there's data to see that why we are gaining weight. So be careful about these two things. Thanks.
Yeah, please. Sir. Yeah.
Yeah. Yes, well taken point.
Sir, this is about pharmacotherapy of non-diabetic patients, obesity. So practically, have you used either dulaglutide or oral semaglutide for non-diabetic obesity patients?
Okay, so I have been part of all the trials with dulaglutide, with semaglutide, with tirzepatide, and now we're doing the Cargi-Sema. So our centers have been doing the trials for all these drugs. So let me get on to dulaglutide as well as oral semaglutide. It gives you a modest weight loss. I mean, I've not seen very great weight loss, but yes, it does cause a weight loss to happen. We did the tirzepatide trials, which is once a week tirzepatide injectables that we gave. And you could easily, because that was non-blinded actually, because there was no way that you could do people could make out. When we gave them tirzepatides, there was a drastic weight loss that happened in these people. A major limiting factor these people was, of course, tolerance and GI intolerance. A lot of people did complain of GI intolerance. You had to treat them symptomatically. Some of them you had to discontinue also and take them off the trial. But there was an incredible amount of weight loss then they got. Cargi-Sema, I have looked at the data, but we are going to start the trials now in November onwards, and the trials look excellent in terms of their weight management. So hopefully that's going to be a big game changer for the future. But I think there is a whole promise that is there in terms of pharmacotherapy. The question is, of course, choosing the right patient for it. Otherwise, it will fall into a discredit.
As sir mentioned, obese non-diabetic patients and various cardiac complications. So oral semaglutide can be given off-label in India.
No. See, with oral semaglutide, don't expect a very drastic weight loss. It's not. It's the injectable 2.4 that's actually given a 15% of weight loss. With oral semaglutide, you get a very, very mild to modest weight loss. So it's not like a therapy that you would use for obesity in non-diabetic population. That doesn't work very well, and it's right now not even a recommendation. Even the company itself does not recommend it. So the oral, not the oral, but the injectable 2.4 is the one which is going to be more. or liraglutide 3 milligram, that's Saxenda, which we don't have it over here right now, but that's been used. So same thing with liraglutide, when you give it at 1.8, you don't get a very great weight change that happens. But 3 milligram is going to be the game changer. So you're going to look at 3 milligram liraglutide, you're going to look at 2.4 milligram of semaglutide, tirzepatide, and then Kagisema. That's going to be a game changer.
And if you're looking for an oral therapy itself, then your oral sema and your canagliflozin 300 in a rightfully selected patient will do a very good job for weight loss.
No data.
Pre-diabetes, yes, you have the chance. Any complication in obesity like heart failure or an MI, you have a chance to use SGLT2 inhibitors. Diabetes, lost weight, in remission, either cardiac or a renal complication, continue SGLT2 inhibitors, not for the benefit of weight loss, but for the benefit of organ protection for a future attack.
Yes, sir. Any Panirna Phool in Gujarat, Panirna Phool is very famous, used by patients for weight loss. Is there any scientific evidence?
I'm not aware about
What is that?
What is that? Can you tell me the scientific name behind it?
Any scientific?
Padrina Phool, what is that? Paneer, P-N-I-N-E-R. Okay, what does it contain? Anybody?
So you've got to be very careful with all these herbal treatments that are there because, people make a lot of claims, but these are all sort of claims and we don't know really whether it works and what is the mechanism of action. So, it's probably unscientific to really speak about it over here.
So what he's trying to say is this is paneer ka phool. So I know what you said. So I think patients in Mumbai talk some other name they talk. But I mean, these are anecdotal. It may have an effect, but these are not foolproof with which. So it's same like a patient of blood glucose value 500. Would you give jamun ka bij and would you give karela to them? No. So this is where this goes out. So they may not be even at this stage. In between we had CBD gummies coming as remission for diabetes. So it's of course, it is not at all scientific. But it is there in media, it is there overall. So I think we are entering social media and diabetes. So I would suggest let's not open that. But absolutely evidence-based medicine should be practiced and do not enter with a drug for a non-indicated use. Be very careful with that. Thanks.
I guess we end the session and we eat one gulab jambu less today because
special thanks to our speaker Sanjay Agarwal sir and Ultimate Side for wonderful talk as usual. Thank you so much, sir.
With the second talk, right? Okay. Can somebody call from the diag?
Hello, can you hear me, sir? Welcome to the post-lunch session of Diacare Con. First of all, let me thank Dr. Bansi Sabu and Diacare team for arranging this very, very good meeting. And we are starting with the post-lunch session. First speaker, Dr. Faraj, is not available, so we will start with the second speaker. Second speaker is Dr. Rahul Bakshi. He is a consultant diabetologist attached to Bombay Hospital and Medical Research Center, Mumbai. He is a postdoctoral fellow from CMC Vellore, former assistant professor in medicine at TN Medical College and Nair Hospital. He has worked as Nuji Singapore for 7 years. He has keen interest in prevention and management of type 2 diabetes. He will be deliberating on busting insulin myths, how to bridge the gap between patients and doctors. Over to you, Dr. Rahul Bakshi.
Thank you. Thank you, sir. Can I have the pointer, please?
Somebody from the team, sir, wants pointer.
Okay. Good afternoon, everyone. Thank you for joining. So I'll be talking about busting insulin myths, how to bridge the gap between patients and doctors. So this is a very practical session, very clinical. Basically, I'll be talking how I deal with my patients. When a patient is in front of you, you want to initiate insulin, what are the issues that go through the patient's mind and how we should try and handle them. Yeah, so outline of my talk. So we'll look at some myths and facts about insulin. We'll look at some patient factors. Look at patient and physician factors, and then we'll look at what advantage can early and timely insulin initiation can do in a practice. Doctor, I don't want to start insulin now. So not an uncommon statement which we hear whenever we see a patient who's on oral agents. Patient may be newly diagnosed diabetes with glucose levels of 300, 400, 500 with an A1C of 11, 12, 14. Or patient may have diabetes for years, uncontrolled diabetes, 8 to 9% A1C on 3, 4 or 5 oral agents. But, when you talk about insulin, this will be a very common Thank you. This will be a very, very common statement which we hear from our patients. So how do we do it? So basically, before going into all that, I want to just impress with this one slide that diet and lifestyle measures like walking, exercise, yoga who can do are the most important part of type 2 diabetes management. And without this, whatever oral agents you give, whatever insulin you give, whichever dose you give, it is not going to work on a sustainable level. You might get good A1C or good glucose levels next time, but when you talk about 5 years, 10 years, 20 years control, the importance of diet and lifestyle measures is very, very understated. And that can never be replaced by medications.
So what are the challenges of managing diabetes in India? So Indian realities of diabetes management, high carb diet. Of course, we all know the kind of diet we have, starting from breakfast, whichever region you go. I'm from Mumbai, western, of course, Gujarat also in the west. You go south, look at the kind of breakfast we have. You go north, parathas and all that. So whichever region you go in the east, the amount of rice we eat there. So, it's important to understand the cultural background of our patients, go through their diet part also. Of course, we refer to dietitian many times, but when as a doctor or as a physician, we talk to the patient, I feel that has a different impact on the patient. Dietitian might see the patient for 30 minutes, give them a diet chart, tick, breakfast mein ye khana hai, lunch mein ye, but 5 or 6 things if I tell the patient, that can have a very, very important impact, and I feel, patient will take that home in a much better manner. ठीक है, जैसे breakfast में, in Mumbai, many people are into quick meals. जैसे breakfast में क्या लेते हैं? सर 3 bread खाता हूँ और 2 biscuit खाता हूँ और चाय पीता हूँ. Now bread and biscuit, which has refined flour, with sugar and with palm oil and all that cannot be your breakfast. So many patients don't know that is unhealthy. So you tell them this one thing, that avoid that, and then give them an option कि इसके जगह क्या खाना है. So these small changes go a long way, I feel. शाम को भूख लगती है, मुंबई, वड़ा पाव है, या बाहर जाके सैंडविच खा लिया, या something like समोसा खा लिया, कचौरी. यहाँ पे भी मैं देख रहा हूँ, खमन ढोकला, जलेबी. Even I had jalebi yesterday, I was out. So once in a while it's okay, but on a regular basis, what our patients eat is very, very important, because high carb diet will affect the post-prandial glucose levels much more in our Asian patients compared to the Western population. So this is very, very important. Patients uncontrolled on multiple oral agents. I was attending some sessions before lunch in the next hall, and they were showing how multiple oral agents, patients on 3 drugs, 4 drugs, 5 drugs, and not started on insulin, inertia of 5 years, 7 years, and so on. When insulin is indicated, but because of inertia, patient inertia as well as doctor's inertia, we don't start insulin on time, and patient's A1C keeps staying high, and the complications that can include micro as well as macrovascular. Limited consultation time, this is very, very important, and I understand the number of patients some of us see in a day. So in Mumbai, I know doctors who see 100 patients in a day in diabetes OPD, specialists, 80 patients, 100 patients. I see 14, 15 patients, and that's all. I give my time slots that way, and I don't see more than that. If no, then no. So that amount of time you can give to the patient. Talk to the patient, as I said, understand about the cultural background, where they are from, who cooks the food, where do they get their breakfast from, lunch, what is snacking in between. ये सब चीज़ें जब पहली बार discuss अपन अगर अच्छे से करें, that can have a very long-standing effect and very important to get results. So giving time to patients, especially in a chronic disease like diabetes, addressing the social, cultural issues. Are they walking? Are they exercising? If not, then what are the issues? Do they have other difficulties? Economical issues as well. Like we are coming out of COVID pandemic. A lot of patients have issues. You see a patient who's unemployed and he's on a drug which costs 50 rupees per day, and कि उसका एक generic version भी आ गया है जो 8 रुपए या 10 रुपए का है. तो patient को लिखा है किसी डॉक्टर ने, तो चालू है, patient लेता रहेगा. But it is our job to look into the cost factor also for our patients. Those who can afford, good, of course we write. But those who cannot, changing them to cheaper drugs, which we are so fortunate in India. I've worked in Singapore for 7 years. I'm working in India since 2019. Drugs there are very, very expensive. So, a drug like any gliptin or any SGLT2 inhibitor for that matter, that costs around $3 in Singapore, which converted to Indian rupees is around 165 rupees. So, कोई भी gliflozin देंगे या कोई भी gliptin देंगे, 155 rupees in terms of dollars. So, वहाँ पे if I want to start that drug to a taxi driver, for example, I used to see these patients there in Singapore. They say, no, you cannot start, I cannot pay for this. जो government से subsidized है वो दीजिए. In India, if अगर हाथ गाड़ी वाला भी आता है, उसको बोलने की 10 रुपए का एक दवाई है जो आपको फायदा देगा, जिससे आपका वजन कम होगा और आप ये लीजिए, he will agree. So we are very, very fortunate to get these drugs at much cheaper cost, and the cardiac benefit, the weight and other things. So it's important to understand the background and then start or even stop certain drugs, which goes a long way. Need for convenience, of course, when we talk about insulin, convenience is a major factor. So we have to understand about that as well कि patient क्या time पे insulin लगाएंगे, दिन में 1 बार या 2 बार या 3 बार दे सकते हैं कि नहीं, रात को देना है, patient का night duty है तो कब देना है. Previously patient already on insulin, when is the hypo happening, and adjust the time that way. So we look at few myths. Doctor, starting insulin means I'm a failure. Patient को जैसे ही अपन ने insulin के बारे में बताया, we talk about insulin, patient के मन में एक बात आती है कि it's the last stage of insulin. Insulin आया मतलब अब I'm a failure, मैंने कुछ गलत किया है या नहीं कर पाया इसलिए. So we have to explain to the patient that this is type 2 diabetes, what is its natural history, how does it work, and it's not that patient has failed or something has failed. Many patients who have diabetes for 5, 7, 8, 10 years, they have something called as secondary sulfonylurea failure, which means they've been on sulfonylureas, wonderful drugs for a long period of time, but now somehow these drugs are not working, which is called as secondary sulfonylurea because the beta cells have exhausted and talk about glucotoxicity. So many a times, we don't need to give insulin for a long period. Patients with high glucose levels where 4-5 agents are not working, oral agents, you give them insulin for a short period and you find that suddenly the glucose levels come down, and then you may be able to cut down and even stop insulin in many patients. So explain to them about glucotoxicity. When you explain them these simple, in simple terms, 2-5 minute ही लगता है, but then patient is more acceptable कि भाई क्यों दे रहे हैं insulin and कब तक देना है और क्या करना है. कुछ पेशेंट्स सोचते हैं कि इंसुलिन डज नॉट वर्क, कि नहीं सर इंसुलिन से तो काम नहीं होता है, आप टैबलेट ही दो मेरे को. सो वी हैव टू एक्सप्लेन टू देम कि दिस मिथ कम्स फ्रॉम पेशेंट्स हु डोंट फॉलो प्रॉपर टाइमिंग्स एंड डोसेज. उन्होंने सुना होगा कि नहीं मेरे फ्रेंड को चालू किया लेकिन काम नहीं हुआ, बाद में किडनी फेल हो गया या कुछ भी. सो दोज मिथ्स आर फ्लोटिंग अराउंड अ लॉट. सो यू हैव टू एक्सप्लेन टू देम. एंड डायबिटीज इज मोर ऑफ एन इंसुलिन प्रॉब्लम. इंसुलिन इज अ हार्मोन विच आवर बॉडी प्रोड्यूसेस. सो पेशेंट को बताना है कि बाहर से इंजेक्शन से दे रहे हैं बट ये आपके बॉडी में ही बनता है, बट एज ऑफ नाउ इट इज नॉट वर्किंग वेल और देर इज इंसुलिन रेजिस्टेंस, एंड दैट इज वाई वी नीड टू स्टार्ट समथिंग लाइक दिस. And of course, there's no question insulin is one of the most effective therapies for lowering blood glucose levels. Something about insulin physiology in simple terms, I'm talking from the patient perspective. So tell them ki how our own insulin works, as basal and bolus. So normally secreted basal between meals and at night times, and the meal related peaks whenever we eat, how our body secretes insulin. Looking in terms of A1C reduction, we all know insulin is the most potent and most effective drug we have, can give us an A1C reduction of almost 3.5% by itself, and the other oral agents and lifestyle, of course, more than 2%. So combining lifestyle, combining metformin and insulin, you add them up, so becomes 2 plus 2, 4 and 7. So 14 से 7 कैसे आता है? That is how it comes. आप सिर्फ lifestyle, metformin और insulin चालू करेंगे, A1C 14 है, within 2 to 3 months or 4 months, 5 months, you can get it down to 7% or even lower, because lifestyle and metformin in a newly diagnosed diabetes I'm talking about, these drugs work very, very well. Of course, now we have some wonderful oral agents which we are not discussing in this session, but of course they have a very important role as well. Insulin causes kidney failure. This is again a very, very important myth what patients think. And how that comes is, I've thought a lot. I asked the patients कि नहीं क्यों आपको ऐसा लगता है, तो many times their reasoning is कि सर वो मेरे friend को diabetes था 10 साल से, उसको 10 साल तक इंसुलिन उसने चालू नहीं किया, बट जैसे ही चालू किया 6 महीने में उसका डायलिसिस चालू हो गया. तो नाउ वी ऑल नो द रीजन कि 10 साल से डायबिटीज था, A1C was 8, 9, 10. Doctors are telling him start insulin, start, he doesn't start, and then he starts, creat is rising, then he starts, and of course CKD is going to happen. So patients को लगता है कि नहीं इंसुलिन से CKD हो गया या डायलिसिस हो गया या MI हो गया. That is not the case. So we have to explain to them insulin is so safe. In fact, that's the high glucose which is causing CKD or renal disease, and not insulin by itself. So dialysis is what patients के mind पे it plays. So explaining them helps, and insulin is absolutely safe. Insulin causes weight gain. So this is not myth as such. We all know different insulins we have. Most of them will lead to some weight gain. Newer generation basal insulins will cause lesser weight gain. And hypoglycemia also is an important factor. So weight gain has relation to hypoglycemia. Many patients, you write down a dose, call them after 15 days. Sugar was 200, it comes down to 60, 70, 80. Patient continues to inject that dose, and then hypo hota hai, then they end up eating sweet or sugar, or so that also can lead to weight gain. So it's important to adjust the dose, explain to them about hypoglycemia, explain to them about dose titration. कि आपका अगर इतना sugar आ गया, तो we have to cut down the dose, because many times we see with diet, lifestyle, and some of these drugs, patient will get very good glucose levels very fast. So cutting down the dose will not cause hypo, so patient will not feel that hungry, and that can help us control the weight. And of course, on insulin, role of diet and exercise becomes even more important. The timing, I have a girl, of course she's type 1, but again on insulin. So she, she does those, some ballet or some dancing and all, and she has hypo during the episode. So, I have explained to her that she has to check her glucose level before starting that exercise or dancing, and also sometimes mid-exercise, even in between, and take a snack depending on her glucose level. Because if she has hypo, then she ends up eating a sweetened drink, and that can affect. So these things we have to explain to the patients who are on insulin, even during exercise, when they're going for a run, keeping something sweet with them when they're out, so that hypoglycemia can be avoided or treated. Insulin injections are painful and difficult. So, I always keep insulin devices with me, 2 or 3 pens and even the syringes, so that when the patient is there, I show them what kind of devices we have, how small the needles are, so that they understand they are small, and, it gives them more confidence. And in fact, patients also tell me, no, finger prick is more painful than injecting insulin, nowadays. So, patient can think it is complicated, time consuming. We are talking about the vial and syringe, but now with the modern delivery devices, it has become so easy, and patients can use them more comfortably. So, earlier it used to take a lot of time and effort to convince patients, but now, as we have discussed in the previous slides, insulin physiology we can explain to the patients, efficacy, safety, and with the pens, easy administration also can be explained. So some other myths, patients would think that, no, insulin to nahi le sakte, I am a working personnel or I travel and it can make, the timings can be rigid. So now with the basal insulins, especially the newer ones, timings can be very flexible. You know, we now understand the newer basal insulins, we can give them plus minus 3 to 4 hours here and there. So, you know, if you fix the timing as bedtime or pre-dinner, you know, pre-dinner insulin, patient has gone out for a party, he can come back and inject that at 12 midnight also after coming back. Or before going, he can inject at 5 p.m. So that flexibility these insulins give. Diet gets stricter, that is also not true. Of course, appropriate diet is important, but that's not so true. And exercise to be regulated also is not true. In fact, we will regulate the dose according to the patient's activity. Many patients, you know, they keep the same dose, but then adjust their activity or stop exercising. Exercise se hypo ho jata hai. So, you know, so those things also we have to explain to the patient. That goes a long way and help address the barriers for insulin treatment. Risk of hypoglycemia is real, but again, less with newer agents. We have to teach the symptoms, signs, prevention and treatment to all our diabetes patients, whether oral agents or insulin, and that's where the time plays a role, the time we give to the patient. Once started insulin, I have to take lifelong. So again, it might be their experience with family member. मेरे घर में एक uncle हैं, वो तो 20 साल से ले रहे हैं, 15 साल से ले रहे हैं. So patient who has A1C of 14, he will be resistant to insulin. So you know, you talk to him, it's not like that. Let me start it for a few months, get your A1C down, and you know, when you address diet, exercise, and everything, we will be surprised at how many patients we can stop insulin very, very soon. We're talking about type 2 diabetes, early patients. You know, those whose diet and exercise is not controlled. So you know, it can be surprising sometimes for us also. Timely initiation is the key. You know, you delay. Patient will say कि सर इस बार तो अभी you know गणपति था या अभी दिवाली था or I was traveling for 7 days या एक महीने गाँव था. They will have reasons every month. But you know, we need to address that and you know, starting it, getting the A1C down and getting the oral agents back again or adjusting them. You know, we are able to stop insulin. A lot of patients when started at the right time in the right patient. Diet and lifestyle, as I mentioned. Weight reduction is very, very important. Nowadays, we talk about diabetes remission, which comes from weight reduction. So, you know, depending on the obesity or, you know, weight of the patient or overweight, working on weight reduction with drugs, with exercise can go a long way in helping us stop the insulin. Cost, of course, diabetes is an expensive disease to treat with medicines. We must explain it's a lifestyle disease. But then when cost of insulin comes into play, you know, we have multiple insulins. We have cheap insulin also. As I said, we are very lucky in India to have a variety of choices which we can choose from. So, but then you have to explain to the patient cost of complications versus uncontrolled diabetes. You know, simple thing what I'll tell the patient whose A1C is high and who has cardiovascular risk factors, just ask them what is the cost of putting 2 stents in a cardiology unit when he has an MI at 2 a.m. at night. You know, patients know, patients को सब cost मालूम है, you know, तो immediately strikes them, you know, cost of MI versus cost of insulin or cost of managing diabetes. They will understand much better. You know, cost of dialysis, apart from the suffering, you know, the cost is also an important factor, so explaining that helps us a lot. And then, of course, it's important to choose insulin based on patient affordability. You start an insulin costing 2,500 rupees in someone who cannot afford it is wrong. You know, patient will not come back to you or stop the insulin. We have insulin pens of 400, 500 rupees also, or insulin vial of 200 rupees also. So, you know, choose the insulin perfectly. Insulin means my life will change, patients think. Patients think they cannot travel, they cannot live alone, they cannot eat out. It's not true also. You know, life does change, but I feel it changes for the better. So these are a few patient cited issues with insulin, that diabetes will control their life. In fact, not true. Insulin regimen can be restrictive also, we have discussed. Hard to live normal life, no. With your appropriate control, you can live normal life. You know, number of daily injections we can always adjust and titrate. And taking insulin at prescribed times or meals, we can be flexible with that also. So these are a few patient and physician barriers. So patient barriers, fear of injections, fear of needles, we try to address negative misconceptions about initiating insulin, inconvenience, and you know, fear of hypoglycemia is a factor which is common to both patient and us doctors also. I'm always afraid of hypoglycemia when I start insulin to any of my patients. So I'll explain to them the symptoms. I will ask them to keep something sweet or, you know, some tablets or biscuit or something with them if they have hypo on the train or in the bus or while driving. You know, so those things are important. And time constraints, as I said, to give time to the patient for the first time when you talk about drugs is very, very important. And hypoglycemia, as I said, you know, continues to be the main obstacle. But then we should understand, as long as it is explained to the patients, it is covered. You tell them the symptoms or relatives, you know, it's not that serious an event. And some patients might miss doses, so we need to find out why they are missing doses, like traveling, busy, you know, challenging to take at the same time and so on, and then address that. And so reluctance from the healthcare practitioners, so explaining that insulin can help control diabetes, demonstrating them the process, establishing trust with the patient. So by talking, by giving them time, you establish a rapport, which helps and goes a long way, being available for support or questions, and explaining that insulin injection is easy. So rationale for early initiation of insulin, overcoming glucotoxicity, facilitating beta cell rest, preserving beta cell mass, and improving insulin sensitivity. So these are a few technical things which help in the early initiation. And apart from that, insulin has anti-inflammatory and antioxidant properties and may protect against endothelial dysfunction. And what is the evidence for early glycemic control? So we know glucotoxicity, beta cell dysfunction, and insulin resistance. And last couple of slides. So just ending by showing the UKPDS. We all know about this, but 5,000 patients newly diagnosed type 2 diabetes, 10 years follow-up. Starting A1C 9.1, and after 10 years when they compared the intensive versus the control group, 7.9 versus 7, what basically we found is poor control in earlier stages of diabetes can lead to complications later, even if glucose control is improved later. So basically, we talk about early initiation, early control, legacy effect of metabolic memory. This is so important because of the, microvascular and macrovascular reduction. We've heard these figures each time. So early control is so important so that, later on patient gets the benefit. And so take-home messages: achieving target A1C is global unmet need. Type 2 diabetes is a progressive disease. Timely insulin initiation and demystifying all myths and spending time with patients. Thank you.
Thank you so much, sir. It was wonderful to hear from you. Particularly the challenges which are there in India to treat patients of diabetes are multifactorial from patient side and from the doctor side also. Before I proceed further, I request the team DiaCare people that if we have our next speaker ready, we'll be going for the lecture first. If Dr. Sunil or Dr. Faraz is not available, we'll be going for question and answer session first. Okay, Dr. Faraz is there. Fine. Please, sir. Please, sir. Okay, so the next talk will be delivered by Dr. Faraz Farishta. He's Director of FS Endocrine and Diabetes Center, Consultant Care Hospital, Professor, Medicity Institute of Medical Sciences. He's Investigator Council, Chair for Indian Society of Clinical Research, the Course Director for Fellowship in Geriatrics by IMA Academy of Medical Specialty, Telangana State, Fellow of American Academy of Clinical Endocrinology, is member of RSSD National Task Force, President of Diabetes Awareness Foundation, Member Scientific Committee of IMA Hyderabad City Journal, and Executive Committee Member of Indian Medical Association Hyderabad, with Branch Program Chair for Masters in Diabetes and Endocrinology by Texas American University. So he is going to deliver a talk on new generations of insulin, staying updated. Over to you, sir.
So thank you very much for that warm introduction, respected chair. And then I've always been very influenced by one person, Mr. Abdul Kalam Saab. So I have always followed his one line, which is, I would say, that's been my statement forever. Dream is not what you see in sleep. Dream is that which does not let you sleep. So I think now I see that Dr. Bansi Saab's dream, what probably he had 10 years back, of taking this whole DiaCare to that level where it is not only the updates and subject, the technology, but also socialization, and then there's so much amount of interaction professionally also what we see. So kudos to the entire team here. So to start quickly on my talk, which I'm going to talk about a new generation insulins. So we all love technology. See, things have changed tremendously and it will keep on changing tremendously. So any one of you love cars here? I think most of us love cars. So can anybody tell me which is this car? It's a difficult one, but somebody who loves can go a while. Maybe chair, if you want to take a guess of the car. Yeah. So the whole idea is the journey, 100 years of journey of Chevy. So you will see the 100 years of journey of Chevy, how it has moved on, and now what we have this year, the EV and the latest. The same way, this is what 100 years of journey insulin has done. So we all know, and then I would say we are privileged generation to be a part of this completion of 100 years of insulin journey, the lovely journey. So this is the first time you will see the insulin which was used, so that, and then now till the latest pens what we have. to the latest innovation. So this is the latest innovation which just got approved. It's gonna get released in November. So this is a device which will be kept on any of the insulin pens. So it is a single unit add-on device which can be added. The beauty of this is it will capture the dose value dialed, the injection event, the time, the temperature, and the mounting and the unmounting events. So this looks very promising. Again, I think we all will have a lot of debate that will it work in India, will it not, and all. I think that is a separate question. But to now, this is how 100 years looks like. So today, I'm just gonna talk on two important studies from India. So that is the updates on the co-formulation, that is the Rhizodec, which is the SMART study, and the updates on the ultra-long basal, that is the TRUST study, and the in-range RCTs. So both of them have been done, I would say, by my senior colleague and good friends. So this is the SMART study, that is the safety of insulin degludec and aspart. So we are talking about, basically, to make it very simple, insulin Rhizodec in patients with diabetes over a period of 1 year, routine clinical care in India. So that is a SMART study, Indian, and then that got published very recently. So it's like just December last year where it got published. It had good amount of patients. So there are patients, you will see around 1,000 odd patients which were there in the patients study who received the injection Rhizodec. And the data were collected at 0, 3, 6, and 12 months. It is a multi-strand trick. I think that is where it becomes very important that whenever you're doing a clinical trial, it becomes very important that you get the data from different centers, probably different ethnicities, where it makes it more interesting and you get the real value of the study. A prospective and a single arm observational. The key inclusion were men and women, diabetes more than 18 years, scheduled to start on treatment with Rhizodec. So you will see the reasons for starting Rhizodec treatment. So these were divided, and then these were the reasons. The first reason I think all of us would agree is the improvement in the A1C, improvement in the postprandial. So we always felt that yes, it has a short-acting and a long-acting component. So PPG, improvement in the fasting, I think this is where our thoughts again have to change, that this is what they claim it as a total control. So this has both, so yes, it gives you a fasting and a postprandial control. Reduce risk of hypoglycemia and need for flexibility as well. Change in the baseline A1C, you will see the change in baseline A1C was around 1.8% in the insulin treated arm and in the OAD arm. So patients who were on the OADs where this was started, you will see it was around 1.7%. Changing the fasting, so it's not the postprandial, but there was a significant reduction in fasting. You will see a 50 milligram per deciliter reduction in fasting, 82.5 milligram reduction in the postprandial. So this is also a very important figure. What are the major concepts? I think my just fellow colleague was talking about the GAP study where the prescription pattern and how's the usage of insulin. I think we still feel two things come to our mind when we want to give insulin therapy. First is, of course, I would still say the needle fill prick fear. I think all of us would agree is still there. Whatever said and done, if you are practicing, you will agree with that. And then second is the risk of hypoglycemia. And third would be the weight gain. I think this is how we see generally in practice, whatever clinical practice we do. So coming to the important part of hypoglycemia. So here you will see the number of hypoglycemic events. So before the study, when the patients were taken into the study, you will see at visit 1 baseline were 176, and once the study was started, these patients were started on Rhizodec, it significantly came down. So it is not only the confirmed hypoglycemia, but the severe hypoglycemia as well. So to summarize that, it says it gives you a better, good A1C reduction of around 1.8%, controls the fasting and the postprandial, effective fasting blood glucose control, and improve safety. So when we are talking about insulin, yes, We need an insulin where we can start it easily, intensify the therapy, and see that patient does not land into hypoglycemia, and over a period of time you do not want your patients to have that weight gain as well. Coming to the next, so this is 1 year safety and effectiveness of insulin degludec in patients with diabetes. Again, done in India. This is the TRUST. So this is the Tresiba real world use study data, where patients here included were both type 1 and type 2 diabetic patients, around 1,000 odd patients. This is again a prospective non-interventional post-authorization safety study. So insulin degludec was added to the routine clinical practice, and then they were monitored for a period of 1 year. I will not go into the endpoints and the secondary endpoints. The incidence of adverse events, you will see again, it is almost similar when you compare it with the placebo. The A1Cs, I think effectiveness, whenever we talk about insulin, first thing what we want is the reduction in the sugars, why we are starting insulin therapy. So change from baseline at 1 year in overall population, you will see is around 1.8%. In insulin naive patients, it is around 1.9%, and patients who were already on insulin before, it's around 1.6%. Change in the fasting is around 64.7 milligram in overall. So roughly 65 to 70 is where the fasting blood sugars came down. Coming to the other aspect, the risk of hypoglycemia, so no episodes of severe hypoglycemia were reported again. So it is not only the effectiveness, but the hypoglycemic risk as well. And the dose. So whenever we want to give an insulin therapy, it is very important to calculate the dose, and that we do that. So you will see the mean starting dose of insulin degludec in insulin experienced patient was somewhere around 18 units, and insulin naive patients were around 13 units. Estimated change in the mean daily insulin dose in baseline was around 14, and then most of them at the end of 1 year did very good at 18 units. So that's a very fair number. So to conclude, the real world evidence study in Indian patients with diabetes receiving insulin degludec confirms its safety. So we've seen the A1C reduction, we've seen the safety profile. So insulin degludec helped in reduction in the fasting, A1C, and then yes, there was, they say it also helped in postprandial reduction as well. But I think per se, when we talk about a basal insulin, all of us know that yes, when we talk about basal insulin, it is the fasting what we are talking about. And I think it all started probably 15, 16 years before, where we started with the thought, treat to reach the fasting first. So that is where it all started, target to reach the fasting first, where we all were obsessed, I will say, to reach the fasting first and then control the postprandial hyperglycemia. I think, but now we have moved away from the glycemic triad. So we always believed, as a postgraduate student from a government medical college, I think what my professors used to tell me was fasting, postprandial, and A1C. I think we did practice it for a longer period. But in the last, I would say, a little more than a decade, we've seen that we moved from the glycemic triad to the glycemic pentad, where the quality of life and glycemic variability, I think these two have made a lot of difference. And we have seen that it is not only the fasting sugars, but it is the postprandial hyperglycemia. Especially in a country like India, I think feasting and fasting is what we all do. We have just done that with our lunches. We're going to do that again in the evenings. I can see a few smiles there. So that is how it is. So you have to practice what you preach. So it is not that you control your fasting today, give the patient 3 months or 6 months of time, take care of the postprandial later, wait for all that end organ damage, and then start something which is not going to help your patient. So it is from day one, you start something which takes control of both fasting and postprandial, so that GV is also controlled. I think in years to come now, we're going to talk more and more about MAGE, more and more about CGMS, more and more about GV. I think that is how we're going to look at drugs which helps you to not only control your sugars, but we will also look at this parameter of GV, that is the glycemic variability, which is going to change the way how we are looking at treating our diabetic patients. So this is I would say just couple of slides before I end. This is an in-range study again, which was done with degludec versus glargine 300. So I think these are the two real basal insulins if I have to talk about what we have now. So here again, the patients were divided equally between the two arms. One arm, the patient was started on glargine 300 IU. Another arm, the patient was started on insulin degludec, and then they were followed up for a period of 1 year. So what I was talking about is the CGMS. So you will see the data. So these patients were put on CGMS 44 minutes more in the time in range. So this is where whenever we are starting a CGMS, the best what we want is at least 70% of the day your patient should spend in that TIR range in that 24 hours. So 44 minutes more the patient spent, and 44.94 minutes lesser time above the range. So that is also very important. It is not only within the range, it is TAR and TBR also. Here probably because it was a basal insulin, so risk of hypoglycemia was not there. So TBR is not calculated here, but it is the TIR and the TAR. So with two same insulins, getting the same result, but you will see the differences in the GV. So yes, when both were used head to head, you will see improved TIR, lower TIR, comparable time below range, and lowers A1C. So I would just end it with saying it's a wonderful scientific conference. So what is science? Science is the process that takes us from confusion to understanding. Thank you so much for your patient listening.
Thank you, Dr. Faraz, for giving a very illuminating talk. It was very interesting, and I think we will have question answer after the third speaker. Now I have a pleasant duty to introduce Dr. Sunil Gupta. All of us know him very well, but it is my duty to introduce him. So, Dr. Sunil Gupta is MD, FACA, FRCP, Glasgow and Edinburgh, FACP, FICP, FIMS, FIACM, FDI, and FRSSDI. He is a diabetologist, CEO and MD, Sunil's Diabetic Care and Research Center, Private Limited, Nagpur. He is a National President of Diabetes and Pregnancy Study Group India, DIPSI, that is 2021 to 2022, National Treasurer of RSSDI, 2019 to 2022. He has been rewarded with, he has 19 oration, 15 national and 4 presidential, 6 international and national fellowship. And he has many awards actually, and I will pass it. And because all of us know him very well, so he will be deliberating on insulin injection techniques, adverse effect of incorrect insulin administration. Over to Dr. Gupta.
Thank you very much, Chairperson. At the outset, let me convey my profuse thanks to Bansi Bhai, Diacare team, the whole team of Gujarat for this honor. It's one of the very prestigious meeting and prestigious conference which we actually every year wait for. I'll be very brief in this very practical talk. You already have two wonderful talks from Fiyaz and the earlier speaker, and it was very very, you know, some points which are very clinical, very much relevant to your clinical practice. And this particular talk of mine is going to be on the errors which we come across while giving insulin injections. Unfortunately, the injection technique guidelines are not being highlighted at most of the platforms. And though we all talk of insulin, though we talk about a GLP-1 analog across the globe rather nowadays, after you have so many of newer molecules coming in, especially in insulin and injectable GLP-1, but still we are lagging behind as far as bringing up awareness of injection technique, and that too not only for the clinicians. And that's why there are occasions that many of the physicians don't have confidence of writing insulin because they are not aware of the recent guidelines. And I'll share you some of the good personal experiences on these lines. So adverse effects of incorrect insulin administration, we will have two topic has been divided into two local reactions, that is maybe pain, bleeding, bruising and lipodystrophy, and lipohypertrophy, which is another very important area of our own original research, which I'll be sharing it, which is actually which is going to be a case-based data. And we'll talk about the management and the self-insulin injection site examination and the prevention. So local site reactions. Now pain is one thing, the insulin, the moment you advise insulin, the first answer from the patient is no, which is almost in 90% of type 2 diabetes. I'm not talking about type 1 diabetes here, I'm talking type 2. The 90% time they say, and type 1 when being diagnosed, they will come to you first time, they'll say, sir, koi tablet hai to wo de do na, insulin kai ke liye deta hai. I'm sorry, I'm not good in Gujarati. I would have given a Gujarati dialogue here, but then that's obvious. Even if it is you, when you become a patient, you also possibly will behave. It's a human nature that no one wants injections, and unfortunately, injection has been shown in our movies in such a bad manner that injection is the worst thing. It's one of the punishment. You presume that patient presume that it's going to be, and all those old days, if you see the doctor is is on this big screen with so much of big needle and is trying to poke and everything. So psychologically, since childhood, we are being made that injection is bad, and that is one of the biggest limitation of initiating insulin therapy. That's what I perceive. But when it comes to pain with insulin, I don't think that's a big issue. Every one of us are aware that the pen needle now, we have 4 mm needle, 32 gauge pen needle is absolutely painless. And that's why our educators, they prick themselves and they show, see, is it any pain? The patient say, Miss, I'm not getting a pain. Did you get the pain? You prick it yourself. If you ask them to prick the insulin, the first prick to the patient in front of you, I feel the 90% of your job is done. So pain doesn't remain as a barrier, in my opinion, once you ask the patient to do it in front of you. Not necessarily a doctor, because we know Dr. Mathur is too much busy and he will not be able to give time. See, but you have a good team of educators around which can be properly utilized. And that is why training of these educators is important. So pain I don't think is a important barrier here. And there might be many other causes of pain also. Someone is already taking insulin, suddenly stops insulin, you have to find out the reason why he stopped it. If he says the reason is pain, then there could be other reasons. If you reuse the needle multiple times, it will become blunt, it will cause pain. If you apply the alcohol on the needle, and there are many people, because they have seen in the movie, and when you are go to a general practitioner, you have seen that people are, wiping out the needle with alcohol stuff, and with that concept, they wipe it out. It has a silicone covering which gets destroyed, and that's why it becomes blunt, and it causes you pain. Then you have, I don't know, is it working? Usually it doesn't work. I don't think it's not. So using insulin, immediately removing from the fridge. So suppose you are removing the insulin from the fridge, if it is cold versus one which is of room temperature, the cold version of the insulin going inside, that's called as cryotrauma. It's called as cryotrauma. So that also causes pain. So you should allow the insulin to come to the room temperature and then should be given. And then injecting on the wet surface, which is already cleaned by alcohol. Suppose you have put alcohol here. Before it gets evaporated and it becomes dry, you prick the person with, and then micro drops of alcohol will cause you burning there. And there can be local reactions. So these are some important causes of pain which need to be evaluated. Earlier, their recommendation from Mayo Clinic was we had 6 mm for children and 8 mm for adult, which has been changed to 4 mm in pen and 6 mm in syringes. So this is a new thing and our people should know. Bleeding, bruising is again occasionally caused by injections, but it does not actually affect any glycemic control of a patient, and it is not troublesome. Less frequent bleeding and bruising incidents with the shorter needle. So if you use shorter needle now, everyone knows that the skin thickness of human being, irrespective of the race, irrespective of you're a Caucasian or you're Asian, irrespective of a male or female, irrespective of obese or non-obese, irrespective whether a child or an adult or elderly person, the skin thickness remains around 2.5 millimeter. And anything below, above this, that's 4 millimeter needle which has been recommended, is not going to go to intramuscular at all. And that is why 4 mm needle is acceptable. But if you take bigger needle, certainly in thin walled patient, it is likely to go to intramuscular compartment. And that's why we should be trying to use this needle, which is quite safe and don't need to go for 90 degree. Usually we have taught earlier when we are at 90 degree, but here you can go directly, so the 45 degree. Now here we can go for 90 degree directly. So reuse of the needle is again a controversial thing which can be discussed at the time of panel. So this is a new needle. I don't know whether you are able to see the pen. I'll put it like this. Yeah, laser pointer here. Yeah. So this is a new needle. And then this is the needle after first use. You can see the little curve here, and then you can see the blunting here of the second use. And when you use it for the 6th time, the electron microscope, which is 370 times magnified, needle becomes like this. And you can now imagine how much painful this needle will be once you prick it after 5 or 6 times. And these are some of the pictures of bruising, and this is on the right, the same patient is lipohypertrophy, and this is not uncommon. Because we never see it, that's why we never realize it. So we have to now make it a practice that every individual who's on insulin therapy, irrespective type 1 or type 2, at least once in recommendation, once in 3 months, they say 6 months, but at least once in a year you see for it, at least, because it's important. And this is another example of bruit. This is a third patient, is again on thighs and some local lipo. And this is a patient, I don't think it's the same patient, but there is one story which I still remember. Almost 20 years ago, a type 2 diabetes male patient came to me, and he was on with twice a day insulin therapy. That time there were no fit guidelines, there were no technologically we are not sound enough. And the dictum was that every patient is to be taught that if you are taking insulin, you can discard the insulin once it starts causing you pain. Now it could be pain perception with one or 2 pricks, you can throw it away. But if you can tolerate, you can throw it away once you start getting pain. That was the recommendation. Dr. Mathur will agree with me. That was the first thing in our residency. That's what. So early days of my practice in 1990s and before 2000 or so, we were doing like this. Now this patient was put on insulin, was told, okay, जब तक ये दर्द नहीं होता तब तक के लगाते रहो. And that patient came back to me after 9 months. In between, he was transferred to Pune. He said, I'm unable to go to any doctor in Pune. And because I was your patient, so today I come to Nagpur. So I just saw, and so I saw, how are you and everything. I just saw, can I see your site taking insulin properly? It was showing lipohypertrophy as well as some of the local reaction. I said, how are you taking insulin? Have you changed the needle? He said, no, sir, you told me till it causes pain, you continue. I am not getting pain even after using it for 9 months. So, it all depends on your perception. Lipohypertrophy. Lipohypertrophy is lipodystrophy is an umbrella term. So you have a lipodystrophy where you have 2 things, lipoatrophy and lipohypertrophy. Atrophy is now very much uncommon, less than 1%. Lipoatrophy is basically a local immune reaction of the insulin. So when we were using bovine insulin, porcine insulin, even humanized bovine insulin, porcine, it was little common. But because of the human insulins now, the antigenicity part is much less, and we are not seeing lipohypertrophy. But in our early days, certainly we have seen this, lot many. And hypertrophy is a local reaction. Insulin is a lipogenic hormone. So when you take insulin repeatedly at the same site, it is likely that there will be a fat swelling, the adipose tissue swelling. We have a king person here talking on adipose tissue. मेरे को adipose बोलने को भी डर लगता है उनके सामने. So sir, this is a thick, firm raised swelling, rubbery swelling, which is because of taking insulin at the same site. And there are some risk factors which I'll be showing you. We'll show you our Indian patients. So this is another patient where you have lipohypertrophy on the thighs. This is another girl on both the thighs is such big lipose, which was around 6 by 3 centimeters on one side and maybe around 4 by 3 centimeters on the left side. There's another lady, type 2 diabetes, who had one-sided lipohypertrophy on the other side. This is the same patient which I showed you, and this one side the bruit also and some local reaction, and then you have the lipo on the other side. This is a rare case of gluteal lipohypertrophy. A young girl was given insulin in the gluteal region, small girl, repeatedly at the same side, and they had gluteal lipohypertrophy. And this is a patient who was never told which side of he should be taking. Arm was his favorite side, and he has got lipo on both the arms. And this again, this patient came to me for the first time, and he told us that he's taking insulin in the forearms continuously since 7 years. And this was a lipohypertrophy on his forearm. So they're rare things. Now, insulin-induced ischemic lipohypertrophy in type 2 diabetes, it has also shown, this data is recently published in 2020, that cryotrauma is again a risk factor from the ice-cold insulin injections. So if you use ice-cold or cold insulin, then it can cause increase the risk of having lipohypertrophy because of the cryotrauma. Even in elderly patients, good data coming, again at this year's data, 2021, strong association between LH rate when the hypoglycemic event plus glycemic variability in elderly patient. We never thought the lipohypertrophy in type 2 diabetes elderly patient can be an unexplained hypoglycemia in elderly patients, and glycemic variability can be a big risk factor for any cardiovascular event. And these are the diagrams. We have younger patients. Again, abdomen becomes a site which is more common in elderly versus the younger people. So if you see the epidemiologically, most of the studies says around 30 to 70% is the risk. This is a case report around 82 years patient, again a Western patient, but we have already seen many Indian patients, and she actually has HbA1c 8.3, and she has soft painless swelling on each side of the abdomen, and these are those swellings. Now, it was diagnosed that is a lipohypertrophy. Then they have got their surgical resection done, and they have shown that that the whole specimen, they have two masses which have composed of yellowish fatty tissues, which were not capsulated with the fibrous tissue, which means it was a local action of the insulin. The lesion were composed of entirely yellowish material, which was not capsulated. The gross findings were compatible with the benign. Further, the electron microscopy were carried out, and they have shown the fat infiltration was seen in the dermis, and then there was some. Now, what they have shown is, I will not go into too much detail of the histopathology, but what they have shown in the slides, that the histopath has shown that it is not only adipocyte but the pre-adipocytes. So insulin is going to have increased proliferation and in the pre-adipocytes as well as adipocytes, and that's why there is increased growth. And this is scanning electron microscopic data of multiple, of course, visions you have. And they have shown that a minor population of small adipocytes have been shown, which is suggestive of the pre-adipocyte proliferation. So this is our own data in IDF Vancouver, which we presented as a poster discussion. Type 1 diabetes, we found it 77%, and type 2 diabetes, 36%, those who are on insulin therapy. Then we have come across that, because this was a small data, we have come out with this publication DTT, that in type 1 diabetes, lipohypertrophy, and this paper is one of the unique paper because we have also shown glycemic variability by injecting 7 days in the lipocyte and having a very high level of glycemic variability versus another 7 days, it is the normal tissue. And you could document, and this is possibly the first paper in the world where we have shown lipo versus normal tissue glycemic variability. Prevalence, as I told you, here was shown to be 70%, around 100 patients, and it was again according to the incorrect rotation of was one of the culprit. Then you had risk factors: reuse of the needle, incorrect rotation, reuse of the insulin syringes were the significant risk factors. Glycemic variability, LH, it was much higher versus those who did not had LH, and unexplained hypoglycemia was also very much common in patients who were were taking insulin at lipocyte versus on the normal tissue. So reuse of the needle, incorrect rotation, and longer duration of insulin therapy was the cause, though the longer duration of diabetes and insulin therapy and even the dose of insulin could not be correlated from our data. So impact of lipo is around 0.55% higher. HbA1c mean dose requirement 10 units higher rate of unexplained hypoglycemia, glycemic variability, and more frequent diabetic ketoacidosis. There's 21% lower insulin exposure, and there's a CLAMP study where they have shown that if you have a normal tissue versus the lipocyte, you have an exposure of insulin in normal tissue is higher, that means higher insulin exposure is higher if you take a normal tissue. And there's 70% higher blood glucose in patient who were given insulin at the lipo side versus the normal side. So if you use insulin needle or the syringe for twice, 3 times, or more than 6 times, the risk of lipohypertrophy increases from 50% to almost 80%. And the recommendation is insulin to be used only once, and needle to be used only once. So injection sites should be examined by every 3 months. That's a global recommendation. It is easier to palpate lipo, and you can go to the stall of BD. Though I am not from BD, don't worry about it, but there is a disclosure. This particular session is sponsored by BD. But what is important in science is you should not miss out this opportunity to see the model which is kept there, and you can feel it, how the lipo looks like, and how you can inspect it and how you can feel it. Lubricate gel which can be used to examine it. And what is the solution is not to allow to take, repeat this sentence, not to allow to take insulin at the lipo site for at least 1 year. And start rotating the site properly, that's the treatment. There is self-examination which you can learn from there. Education is important for creating educators, getting ourselves educated, and inspection of the site is important. Last slide is 7 golden rules for injection technique. Always inject in the healthy fat layer under the skin. 4 mm pen needle and 6 mm syringes should be used. For children less than 6 years, very thin adult may inject perpendicular into or you can just have a fold also. Recommended sites are abdomen, upper thighs, and upper arm, and the upper buttocks. Sorry, your time is up. Just I feel this is the last slide. Can I just, yeah. Self-injection technique has to be told to them. Try to see lipo on a regular visit. Rotation of the site and the pen and needle syringes not to be used for more than once ideally. And safe disposal of needle is important. So start thinking lipo. So the new slogan for all of you is now, think lipo. If you think lipo, you will be able to detect it. If never think it, you will never be able to see it. Thank you very much for patience.
Thank you so much, sir. It was a really wonderful presentation. It's always nice to hear from you. Please, sir, please.
Sunil, I think very interesting talk. So many practical points. Many were we also forget. So very good talk.
Sir.
You mentioned that lipohypertrophy, there was so many small pre-adipocytes. That can lead to big signs, because so far in adipose biology we understand action of insulin, basically lipoprotein lipase, and reduction in free fatty acid flux. If it enhances beta cell proliferation, because that is not much known in the literature actually, that can lead to big signs. So compliment for introducing this article to me.
Thank you very much. Thank you.
Thank you so much, sir. We will go for the question answer of the audience. There is one little question from my end, sir. Basically, insulin technique, I believe that in Indian scenario, perhaps in the postgraduate students also, I think in the residency days also it is not properly taught. So I really believe that there has to be some initiative by Day-2 also, that some sort of basic education to because we see a lot of insulin sites which are absolutely wrong. So actually a doctor prescribes it, patient would never do it on its own. So I think there is a big responsibility of how to initiate insulin has to be properly taught also. So coming to the question now, that how many seconds ideally person should wait after plunger has been pushed?
Yeah, it's 10 seconds.
Yes, so I think that is one of the biggest.
And more important to that is once you push the insulin 10 seconds, before removing you have to wait for 10 seconds. Now, I am a very busy man, you are a very busy man, Dr. Mathur is also very busy, and this young man, what he will do is 1, 2, 3, 4, 5, 6, 10, and he will take out the needle. So that is not allowed. You are supposed to do it 10, 9, 8, 7, 6, 5, then it is 10 seconds. So go in a reverse order, that's what we have to teach. A very important point, very practical. Because no one is going to wait for 10 seconds, I'm sure about it.
So, sir, do you have a question to ask?
And as far as your comment on the guidelines, we already have FIT guidelines. We have FIT India guidelines also. FIT is Forum for Injection Technique, FITT. So if you just type FIT guidelines, you will get wonderful pictorial presentation with a slide set, with PPT. Everything is available in PDF format also, and I feel, and you can even download those guidelines. Yes.
Excellent 3 presentations and lot of carry home messages along with the right technique, how to initiate insulin and how to go about it and how to look for the complications. My question to all 3, I mean, it's a very practical thing. Nowadays, what we see is...
I request both of you to please
all the speakers request to be on.
Difficult question रहेगा तो
No, sir. It's a practical question. Nowadays, what we see is the Rhizodeg is being prescribed 3 times a day. Twice was common, but now it has come to 3 times a day. So my question to all 3 of you is ki, why don't we use basal bolus then?
Yes.
So please your comments.
Sir, Rhizodeg has not been tested even for twice a day. Whatever data we have is only up to once a day, and that too up to 40 units of insulin per day. And now it is our practicability that we are using it twice a day. Many of us are using twice a day. Once we start with once a day, if it's not getting control, using it, which doesn't seem to be logically too bad, because we have a data of Novomix, which is of 1, 2, and 3. If you see the trial 1, 2, 3 trial, but because it's a co-formulation, we should avoid using it for three times a day. I have not seen a single prescription of 3 times a day, but certainly rarest of rare we give twice a day. So
that's why we are asking you.
We should avoid using it 3 times a day, because no data is available. We have not done any PK/PD studies on these lines.
Can we use more than 40 units in a day?
We can use it. We can use it.
What level? Because up to 60 I have used.
Sir, again, there is no limitation of using it, but if your quantity of insulin is higher, then the absorption might get hampered, and that's why the recommendation, once you cross 40, you divide it into 2 pricks. That's
talking about 2 divided doses, 60 units.
30 each.
30 each.
That's okay to us. That's okay. Sorry.
Any questions from audience?
Anybody from the audience have a question?
I will just add on to what sir very nicely said, and then your question. Generally, the rule of thumb is if somebody is requiring more than 0.5 units per kg per day, at least that is what we all learned for basal insulin. That is where the patient is having insulin resistance. So it is always a better thought, maybe as you rightly said, sir said, ki above 60 units, there's no point in further escalating. Probably add some insulin sensitizers. Or there have been times, I would say, I was very inspired by his talk, I always am, where he clinically showed that with our busy practice, the only thing what we know is escalate the dose. We never go, we never see the patient, we never talk to our patient. And I will just share my experience of 2 minutes. Being a professor myself, I got a call from casualty. Since you said this has to be done something at the doctor's level, I'll tell you what is happening with the postgraduates. The amount of unawareness they have, it's not this and the insulin pens. So I got a call from my casualty that a patient has come and he's got some insulin and a refill. The sister is not able to change the refill. So I said, okay, if the sister is not able to do it, probably she might be the new one. I said, one of the residents will be there, tell them to do it. So these are critical care residents. So, critical care residents are into that frame of mind. They tried their level best, they were not. So again I got a call saying, sir, inse bhi nahi ho raha hai. I said, ek kaam karo, sabko leke upar aao. Get the patient and my residents, critical care guys, get them all up. When they came to my room, what they were, I think he already has the answer. So I was surprised, they do not know the difference between a permanent pen and a dispo pen. So they were trying to open a dispo pen. So this is what, I keep on sharing this. Probably it's an eye-opener. I will not say it is a shame. Probably we also did not learn it. But it is, these small things make a lot of difference. So how do you expect your patient to do it? You write dispo pen, you write flexi pen, you write this pen, that pen. So I think there also the educators play a lot of role.
Actually, sir, a lot of doctors who have some inclination towards one or few brands of prescription, not by any ways I'm saying, but Ideally, every doctor should learn what companies are available in India, what brands are available in India, what amount of vial. Because if you prescribe, say for example, 10 ml vial of an insulin, who is taking just 8 or 9 units per day to save the cost, I think it is not going to benefit. Ultimately, after 30 days or 45 days, when the half-life is over, the shelf life is over, he will be uncontrolled. You will increase the dose on follow-up, and when he will come back again with a new vial, he will have hypos. Same way, travel guidelines are also not very much aware of. People are not aware of how to manage patients on travel. Lot of controversies are there that high altitude travel. One of my patients of type 1 diabetes, she used to carry her insulin cartridges in the ice packs during travel with her. And whenever she used to come from Thailand to here in Ahmedabad, she used to be in decay. So ultimately, we found a solution that you keep your travel medications away from you once you travel. We really don't know what has actually happened, that the temperature fluxes were responsible or high altitude insulin damage was responsible. But just changing that you take a new vial, they were affording fortunately, so they could do it. So once they travel, they come back, they change the cartridge and they are done. So decay was stopped. So something which is really very strange and not debated across.
I feel even such thing, I'll just take 30 seconds. I'm sorry, the time is already over. But then if you have the 100 IU versus 40 IU syringes, that's one of the biggest locha I am telling you, biggest one. The most common, disposable is there, but most common mistake, almost every alternate, every third day is find, mera insulin ka pain kharab ho gaya. So what I did, I went to a shop, I said, mera pain kharab ho gaya, can you give me the something else? He said, pain is not there, so he'll give you a needle, which will be 40 IU. The cartridge insulin being taken of 40 IU, and patient is started landing up into hypoglycemia, because insulin, if you take 100 IU insulin to 40 IU syringe, you will end up with giving 2.5 times higher dose. And one of the lady got admitted with 27 blood sugar recently, hardly a month back. Practically, we could save her, she could not get deteriorated, but once we lipohypertrophy is one thing, small thing, and you have to teach them. So what we need at the end is education. So education, and education, not only for doctors, and also create educators, and diabetes educators more across you.
Came to me, sir, even if I take 1 or 2 units of insulin, I get hypoglycemia. I look for every possible point, from adrenal function to renal function and GI function, everything, even abnormal being everything. Then I asked, कि 1 unit आप लेते कैसे हो? So she was reading 10 units as one unit. You know, these small things matters a lot in your practice.
Yes,
so I think it's a wonderful presentation and discussion.
Thank you very much.
Thank you all the speakers. It was a wonderful symposium or workshop of insulin, and I believe that after this session, perhaps a lot of doctors would be aware of the insulin techniques.
So next time when you plan a workshop, give it to us. You should have a workshop, like you should have an insulin tray here.
We should have
you
insulin
a
pan
syringe,
for
you should have pain, then it is a workshop. So BD, when you do like this, should try to keep everything here. You are there that, what do you call it as? Lipo ka wo jo putla banaya na, wo idhar hona chahiye. Then people would have come, would have palpated it. That should have been done. Hai na? Yeah. Instead of in the stall. Thank you very much.
Thank you so much, sir. And I call upon our next back-to-bench sessions chairpersons. Do we have Dr. Apurva Parekh, sir, with us? Yes, sir. And Dr. Prabhat Agrawal, sir? Yeah. So I call both the respected chairpersons to proceed for the further session.
Good evening to all of you. We are moving to the next session, that is a back to benches. We have 3 speakers, learned speaker for this session. The first speaker is Dr. Sandeep Mathur. And we know currently he is having professor and head of the Department of Endocrinology at SMS Medical College. His current area of interest are the molecular genetics of hormone and metabolic disorders. He is a recipient of Commonwealth Academic Staff Fellowship in 2003. He's also having Travel Grant Award by ACE USA, Merit Award by Government of Rajasthan. He has several awards to his credit. He has more than 50 publications to his credits in reputed various journals, even the Frontiers, PLOS, Journal of Endocrinology Society. So session is now over to Dr. Mathur, sir.
Thank you very much. Thanks to organizers and my colleagues who are present here to be here. Actually, I am talking of basic science, but I want to bring basic science to your clinical practice. Actually, my practice, there will be, my presentation, there will be two themes. First, I want to focus that beta cell preservation should be an important objective of diabetes management, because we see a patient in a clinic and we take care of glycemic control at that time or cardiovascular risk control at that time. We don't see his life after 20 years. You know, a patient with 30 years come with diabetes mellitus. I say, yeah, I want to see your life after 30 years. Would you take insulin or something else? Would you like to be on insulin for after 5 years? He say, no, sir, I want to be on oral. So let us have a long-term planning. So long-term planning in diabetes, not only cardiovascular, microvascular risk reduction, but beta cell preservation. Secondly, my own work has come to a conclusion, and data is emerging from other publishers, public investigators, that your beta cell dysfunction is mirror image your adipose tissue dysfunction. So while treating patient for beta cell preservation, consider preservation of your adipose tissue function. That's why I'm very much interested, and thank you, Dr. Sunil, for your talk preceding me, that insulin can cause pre-adipocyte generation that can lead to big science. Anyway, so beta cell dysfunction, nothing but adipose tissue dysfunctions, mirror image. If that is in your mind, your diabetes management criteria, objectives, strategies will change, and your patient will after 10 years and say, many patients come to me. I know one patient whom I prescribed pioglitazone somewhere in 99 or 2000. He became Supreme Court judge and then big shot and everything. And he still control on only 2 or 3 oral medicine after 25 years. He had CAD, triple vessel disease, bypass done in 99. Still he is alive. So paying attention of these biological of disease is very important. Anyway, let me go fast now. Where to scroll here? Yeah. My agenda is the role of beta cell dysfunction in diabetes, pathobiology of beta cell dysfunction, effect of current anti-diabetic therapies, clinical trial evidence. Ray hope some drugs are in pipeline which will regenerate beta cells. You know, what is the role of beta cell dysfunction in diabetes mellitus? I want to tell you, a patient come to your clinic, you know, वो झूला झूल रहा है between dysfunctional beta cell and good functioning beta cell. Because beta cell mass is different thing, beta cell function is different things. If patient is gaining weight because of lifestyle factor, he is lucky he may have good beta cell function and beta cell mass, he may not develop diabetes. Once he go down in this graph and he is getting declining beta cell mass and function, he become diabetic. So this switch between beta cell function is very important component of your treatment. Now natural history of diabetes, we always talk in terms of rising glucose and rising insulin resistance and rising insulin levels and declining insulin levels. But what more important I want to point out here is there is a decline in beta cell function which starts many years before your diabetes is diagnosed. So differentiate between these three things. Insulin secretion is different thing. Your beta cell mass is a different thing and beta cell function is a different thing. Because beta cell function has its own biology and that you need to understand and treat accordingly, and your therapy should be directed towards that. Now pathophysiology of beta cell at genetic level. You know, diabetes is a genetic disease. We believe insulin resistance is primarily come and then beta cell dysfunction come. But we generated, you know, we did Jivas for diabetes. We discovered genes for diabetes. We look for that network. Actually, our strategy is to look for gene network. When I look through the gene network of your diabetes mellitus, I find that most of them were expressed in your adipose tissue. This paper published in 2013 and rated as one of the top 5 paper from India by the American Association Advanced in Science Media Head. And that they realized that time, and now I realize my own work that genes showing association with beta cell functions are the genes, they are functional, they are active, they are enriching the pathways of adipose tissue dysfunction. That's why I say preservation of beta cell is basically preservation on improvement and enhancement of adipose tissue dysfunction. I will not detail of this paper because this is complex science biomolecule paper published from my own group, my own paper. But remember, beta cell dysfunction nothing but adipose dysfunctions mirror image. Now pathophysiologic beta cell dysfunction at physiologic level, you know, it is basically free fatty acids and glucose. They are the detrimental molecule for your beta cell damage. If you understand this, all your strategy should be directed on not only glucose but free fatty acid also. Unfortunately, we miss this point. inflammatory mediators, they are damaging your beta cell. GLP is one of the mechanisms, prostaglandin another mechanism, and beta cell final destruction or final dysfunction pathway include inflammation, endoreticulum stress, metabolic oxidative stress, mitochondrial dysfunction, amyloid, and all these things are there. But they're all basically consequence to hyperglycemia, high free fatty acidemia, and adipose tissue inflammation. So these are the pathways, and GLP is one of the modulator of this mechanism. This is not very important. What more important is your free fatty acid, which is around your beta cell, and your glucose around your beta cell. So one more point I want to point out. If you go to cell biology, beta cell dysfunction doesn't mean it is dead. Very important. Insulin is being secreted in a good amount doesn't mean your beta cell is normal. Your beta cell may be dysfunctional. It is stressed and secreting more insulin to take care of insulin resistance. And in the patient who requires insulin, don't believe all cells are gone. There may be beta cells are dysfunction. Last are very important. Your beta cell may be transdifferentiated into your alpha cell. It is having a detrimental role. So your therapeutic strategy should be to redifferentiate to beta cell, and strategies are being developed to that. And same time, you have to make it functional by some strategies. I will talk about that in next few slides. Early intensive metabolic control and beta cell preservation. I think there are so many evidences in literature. In vitro, take beta cell out of glucose and fatty acid, they become normal in a diabetic patient. Similarly, fatty acid control by any means, that beta cell become normally functioning. There are so many trial evidences. Even bariatric surgery, what it does, it reduces your free fatty acid flux. Your ACP max, that reduces free fatty acid flux. Even your intensive glycemic control with insulin, they all actually enhance beta cell function. So never presume that patient who is requiring insulin, the beta cells are dead. They can be revived, and that should be an important component of your treatment. Now, intensive insulin therapy, intensive lifestyle management, and intensive exercise. I can go through these slides a little fast. 10% weight loss, beta cell function will enhance like anything. Your intensive physical activity, that will enhance beta cell function. So always keep in mind, even patient who is on insulin, oh, I want to improve your beta cell function. Okay, sir, मेरे तो है ही नहीं insulin लगा रहा हूँ बाहर से. No, I will improve it. You will be having better glycemic control because your natural beta cell will supplement your external insulin. We have a discussion regarding in the previous discussion that this insulin better what. No, everyone is unique. And everyone changes every moment of time in his life. And that should be a very important component of your thinking while managing a patient. So early intensive metabolic control, there are cell biology evidences, there are clinical trial evidences that early initiation of insulin for 2 weeks. This is a very important message. If somebody comes to a diabetes newly diagnosed with and say, doctor, I want the best treatment. Or do you say, person XYZ, I will treat you with insulin for 2 weeks, intensive control. You may not require insulin throughout your life. Or you will require it after 5-10 years of when otherwise expected. Insulin is the best molecule after lifestyle intervention to enhance your beta cell function. And that should be an important part of your prescription. Only 2 weeks of insulin, not throughout the life, will protect the patient from insulin therapy for the life. Similarly, I think I can omit these slides. Yeah. Now coming to what are the effect of other drugs we used in the management of diabetes on beta cell function, beta cell biology. I am not saying secretion. Here it is very interesting to note that beta cell apoptosis is best prevented by metformin. We always think metformin is insulin resistant drug. It acts on the biology of beta cell. It reduces ER stress. It actually desensitizes human pancreatic by high glucose, desensitization done by this medicine, and ADP-ATP ratio are changed, and beta cell biology improve with metformin. Lipotoxicity is taken care by metformin, and metformin acts on beta cell directly, and all pathogenic mechanisms are plugged by metformin. So metformin we give not only for the purpose of insufficient, but for the purpose of beta cell biology improvement, and that should be very important component of your or strategy of your treatment. And unfortunately, sulfonylureas enhances beta cell apoptosis. The common general practice newly diagnosed diabetes, start glimepiride metformin. I think that is killing the beta cell of all our patients. So my suggestion in general practice is, please don't start with sulfonylurea at the diagnosis of diabetes or as a second line medicine, even if it's cheap or not. There are other options. On the contrary, your pioglitazone enhances beta cell function. And that is a very good medicine for that purpose. I can ignore these slides. And you have this, adopt and study data also there. Now GLP-1 analogs and DP4 inhibitors, there are so many mechanisms are there, and there are so many studies in literature, they say that insulin secretion. I am not worried about insulin secretion in my patient, that is always there. But I am worried about beta cell biology and beta cell functional cell biological preservation. Beta cells should be stress-free, should be free from apoptosis processes, as well as your ER stress and oxidative stress and all these things, fatty acid damage. So there is a hype of GLP-1 analogs and these for beta cell preservation, no, that is not true. And in fact, whatever improvement with your incretin-based therapy, it is temporary, it is not permanent. And I will tell you that does not improve beta cell biology. That's why I am coming to the point that can deteriorative beta cell function be naturally diet to be halted? Current therapies, individual high risk of diabetes, metformin, pioglitazone, GLP-1 receptor agonist, DP4 inhibitors usefully improve beta cell function, halt the delay of T2 development, even though most studies effect appear to subside when these drugs are withdrawn. We say it enhancing beta cell function because it enhances insulin secretion. This is wrong. This is a temporary phenomena because the beta cell has some capacity, you are taking more insulin out of it. You are putting more stress on that. Only ACT now data have shown that beneficial effect of beta cell response are high, largely dissipated 1 year after withdrawal of pioglitazone, but net diabetes prevention effect persists. So pioglitazone is the only medicine after insulin, which effect of which on after metformin persist when these drugs are withdrawn, not for incretin-based therapies. Similarly, early diabetes. It is basically insulin that is the most important. It is metformin, it is your pioglitazone. If whatever positive effect of incretin-based therapy, it is temporary. So early diabetes, your focus should be beta cell insulin resistance preservation, focus should be metformin, pio and insulin. Short-term insulin, not permanent insulin, of course short-term insulin. And even patient who had improvement with ITT, improvement was enhanced by metformin. So metformin, insulin and pioglitazone are the best medicine for enhancement of beta cell biology and function. Now long-standing diabetes. In long-standing diabetes, metformin and insulin still works to enhance beta cell function. Sometimes you are very careful, your long-standing diabetes, you can bring back off insulin and this is my practice, though after all I am also a practitioner in evening. So, when patient long-standing diabetes, uncontrolled sugar regarding 40-60 units of insulin, all these things are there, I intensely focus on adipocentric therapies. Pioglitazone, metformin, intensive lifestyle modification, and gradually reducing the insulin doses. And I am telling you, many patients insulin was stopped and they are healthy. Of course, SGLT2 inhibitor doesn't work on beta cell function, but they enhance by reducing their weight. They are also working. And I am telling you now one more experience of my own. If I compare pioglitazone with your SGLT2 inhibitors, weight gain in one, the loss in another, your beta cell preservation is better with your pioglitazone. So these are very important practical points. Canagliflozin, of course, as a therapeutic option, has some impact on beta. It can be given to irrespective of beta cell function. There is some data. Improvement in beta cell function was seen with this, your canagliflozin. And adding canagliflozin to triple therapy improved beta cell function by 18%, but did not reach significant. So canagliflozin doesn't enhance beta cell function. That is very important. Now coming to ray of the hope. Because type 2 diabetes, I told you, it is basically beta cell function mirror the adipose tissue dysfunction. If patients' beta cell are not functioning properly, they might be dysfunctional rather than dead. Even the beta cells are dead. When a patient with long-standing diabetes doesn't respond at all to whatever strategy we presume, the beta cell mass has been drastically reduced, or it cannot be de-differentiated back to beta cell from alpha cell. What is the ray of hope? Can we regenerate? Can beta cell be proliferated? insulinoma benign tumor, and lot many biological studies on insulinoma cells and cell lines, and that raised a ray of hope for therapies for regeneration of beta cells. New beta cell will grow itself within the pancreas. This is the one of the reason I never venture for your islet cell transplantation. I venture in field of biology, cell biology, molecular biology. Never venture in this 10 years ago in your islet cell transplant. I know there are different stories are coming up, and not only so many drugs in pipeline that enhance your beta cell function. The prostaglandin receptors modulation is very important component of beta cell modulation. DYRK1A inhibitors induce adult beta cell replication. They will change the scenario in future, because if you take care of insulin resistance or adipose dysfunction by your glitazone-like medicine, diet control, exercise, and your SGLT2, whatever therapy you do it, if you can regenerate your beta cells, and there is a very good animal model data. Beta cells, new cells are coming up, they are growing in number, they are secreting insulin, they are responding glucose. So this is the future. So conclusion is that, hopefully I am on time, true anti-diabetic drugs should be able to halt or restore beta cell function. That should be very important objective of your treatment, because you want patient to come after 5 years, 10 years also, because these patients make you popular also. So I consulted an ex-doctor 10 years ago, he said ki you will not require insulin next 10 years because I am planning in such a way, and he said 10 patients, after Mathu's treatment helped me a lot. Insulin, metformin, pioglitazone, GLP agonist, DPO inhibitor exert benefit on human beta cell in vitro. Beta cell pro-survival effects in vitro are not mirrored by durable drug action in vivo, excepting for pio and to some extent metformin and your insulin. In pre-diabetic, newly diagnosed diabetes, beta cell function is restorable with intensive therapies, particularly insulin, GLP-1 analog receptor agonist, but not sustained with GLP-1 receptor agonist or DP4 inhibitors. So, your early initiation of insulin for 2 weeks, that is a wonderful strategy for the life of patient after 20 years. Ray of hope, drugs are in pipeline that can regenerate beta cell. Thank you very much.
Wonderful talk.
5-second question. The duration of insulin therapy, is there any good study on these lines? I usually use for 4 to 6 weeks. You just said 2 weeks is also sufficient.
Yeah,
so do we have that data somewhere?
Yeah, trials. There are two study I quoted here. Two randomized controlled trials. Most of them use for 4 to 6 weeks. But there are few reports they use only for 2 weeks, and that was good enough. So minimum is 2 weeks. Yeah. Sometimes you start, it takes 1 week to glucose to come under control. That's why you have to increase this to 3 weeks.
Congratulations. Wonderful deliberation once again.
Thank you.
Any questions? Yes.
Yeah, I think really it was very illuminating talk and very energetic talk. But one point you mentioned that sulfonylurea is killing the beta cell. Is it true to today?
Yes.
I don't think so, because you saw the old paper and old research. But sulfonylurea is a beta cell poison. This was a theory that time. But today no one says that. Although whatever you told, that is, I agree, but even with this early insulin, which you thought for 2 or 4 weeks or whatever it may be, they do have some very strong evidence for that.
You see, I scanned the literature before this talk and beta cell biology, because my focus is on beta cell biology. Beta cell ER stress, ceremoid deposition, oxidative stress, fatty acid induced apoptosis. All those phenomena, we look for those biological phenomena. Sulfonylurea, whatever literature available, has a detrimental effect. It enhances apoptosis. It is little exaggeration that I said it is killing your beta cell, but it doesn't protect your beta cell biology. My word is beta cell biology. I told in advance, in the first slide, there are 3 different things. Insulin secretion by beta cell. Of course, you give it, insulin will be secreted. But beta cells' overall capacity to remain functional for next 10 years, 5 years, 20 years will deteriorate with sulfonylurea because it enhances apoptosis. And it has no effect on all these mechanisms. It has almost no effect on fatty acid flux. whatever effect on fatty acid flux is secondary to insulin secretion, but no direct effect on that. Definitely, it has some effect on beta cell function in the sense in your practice in your patient, because by enhancing insulin secretion, they also indirectly provide insulin. That could be their indirect mechanism. But apoptosis process is enhanced by them.
We have data also with the sulfonylurea where there is a durability for 4 or 5 years. So you have got enough data to reach there. So
But suppose your patient want to live for 30.
Anyway, in the way what was your talk and what was your topic, that's why you are right. But otherwise, in the clinical sense, most of our physicians, they start with the metformin and the sulfonylurea, and we have also experienced for 10 years, 20 years, they are doing wonderful.
But I have seen patients who have done for 30 years with pioglitazone metformin. That is important. Yeah. And secondly, there are inter-individual variations also there that we should take into account. But generalization, at least biology is concerned, sulfonylurea is exceptionally not good for beta cell biology.
Thank you, Mathu sir, for a nice and wonderful talk. Dr. Bansi wants to say something.
No, it's not. We'll be inviting everyone from our team. I'm sorry interrupting it in between, but I will just request all our DIACAT team members to come. Can I request everyone and start the audio? Neelam is there outside. Neelam? Neelam? नीलम ने कौन है ऑडियो चलाया? नीलम, start the audio.
जिंदाबाद रे जिंदाबाद रे अहमदाबाद रे शक्रो बाज रे शाही मिजाज रे अहमदाबाद ऊंची ऊंची मांडे छे आंख रे खोले पाख रे अहमदाबाद बाबा जोड़ा जे तूफानी रे के स्वाभिमानी रे
Hello.
Rajiv Kovil for giving the talk about
Thanks.
insulin signaling and insulin resistance newer understanding. Dr. Rajiv has done MBBS from Bombay and
Chairperson, we can
FRCP.
start. We are running late also.
Yeah,
Thank you
so
so much.
I invite to give his talk. Thank you.
So at the outset, let me thank Bansi for not only calling me, but almost 30 of my colleagues from UDF. Thank you so much. Thank you for that gesture. Gujarat and Mumbai will always be close. So I'm going to talk about something new, and it is new, so all my questions should be directed to the person who sent me the slide deck, that is Rucha Mehta. She's done a lot of research on this. So insulin signaling and insulin resistance are new understandings. So we had Dr. Mathur speak about how exercise can improve the beta cell function. I'm just going to give you a little bit thought process into what actually happens. And we have heard about the ominous octet. We have heard about how fat cell accelerated lipolysis, how GI and how paradoxical hyperglucagonemia is a defect in people with diabetes. What I'm going to talk about, that we heard about the legacy effect almost a decade and a half back, and we thought that probably it was related to the mitochondrial changes. Now, when we talk about mitochondria and diabetes, the first thought which comes into our mind is the mitochondrial DNA mutations. And there are 13 to 14 of them. And importantly, we know that there is MELAS, there's maternal inherited diabetes with deafness. But mitochondrial dysfunction seems to be the core problem in diabetes, and whether we can tweak this mitochondrial dysfunction to the benefit of people with type 2 diabetes is the basis of my talk. So I am not an expert in this. I'm trying to do my best to kind of make a complex pathophysiological defect in a much simpler manner. Insulin resistance and beta cell dysfunction leads to all the issues, whether it's hyperglycemia, endothelial dysfunction, enhanced lipolysis, the Randall cycles, enhanced hyperglucagonemia, increased hepatic gluconeogenesis, and the beta cell apoptosis, which we spoke about in the previous lecture. So all this go in sync, and chronic hyperglycemia sets in. Metabolic inflexibility and mitochondrial dysfunction seems to be at the root of all these problems. They could be genetic factors like the mitochondrial DNA mutations, common genetic variants, environmental factors, the intrauterine malnutrition, environment. I remember Dr. N.K. Singh speaking about environmental pollutants and beta cell dysfunctions related to the mitochondrial dysfunction. So what happens in the beta cell? You have beta cell failure, you have abnormal fusion, fission, and autophagy of the mitochondria, and you have increased insulin resistance, which finally leads to type 2 diabetes. Now, the heart of the matter is this beta cell dysfunction, where you have a reduced reuptake and you have increased hepatic gluconeogenesis, leading to what is called as beta cell dysfunction, and this seems to be coming out or born from the mitochondrial dysfunction and mitochondrial mitophagy, as it is called. So if I take you back to Dr. Sanjay Agarwal, you can enter. If I take you back to our glucose homeostasis, we know that aerobic glycolysis occurs, and then you enter the TCA cycle. You could also enter the TCA cycle through fatty acid oxidation, and then you have generation of ATP, ADP, which is the powerhouse or the energy of every cell. This occurs in every aerobic prokaryotic cells in our body, and this is the way that the mitochondrial functions. It provides energy to the cells. And then these NADH and FADH2 enters the electron transport chain. It goes through the complex 2 and complex 3. If it goes through complex 1, you have reactive oxygen species which is made. If it goes through 2 and 3 and 4, you have ATP generation, and that's how the energy occurs in a cell. So you can have energy being made. If you have abnormal metabolism, you can have reactive oxygen species which can call apoptosis. At the recent American Diabetes Association meeting, there was a fantastic Banting lecture which spoke about how the glucokinase gene can be tweaked into a counterintuitive gene. And we have always looked at glucokinase activators being treatment for diabetes. But this particular research for 40 years spoke about how chronic hyperglycemia can cause excess entry of glucose into the cell through the glucokinase gene, and that leads to glycogen deposition in the beta cell. As we had heard 5 years back that 1 gram of fat deposition in the beta cell can cause diabetes. Similarly, excess glucose influx can cause glycogen deposition leading to diabetes. Similarly, so if we can tweak the glucokinase gene, as we have glucokinase related monogenic diabetes, and that is the hypothesis, that if we can tweak the glucokinase gene into a counterintuitive gene which allows only that much of influx into the glucose in spite of chronic hyperglycemia, you will not have glycogen deposition in the beta cell, and your beta cell will not progress into apoptosis and into failure. So that's the basis of the metabolic inflexibility, which seems to be the heart of the matter. So mitochondrium is involved in all these processes. Metabolic inflexibility refers to the dysregulated energy substrate metabolism in the mitochondria. Healthy mitochondria allow efficient functioning of the hepatic, skeletal muscle, pancreas, and cardiac tissues. There needs to be an alternating switching of metabolic fuel, which is lost during chronic fat or carbohydrate feed, obesity, and type 2 diabetes. So the switching which needs to occur based on the availability of substrate seems to be the problem as such. So when you have fasting or feeding states, the glucose homeostasis is very well maintained by the glucose substrates or the free fatty acid substrates. And in a healthy individual, lean, non-insulin resistant individual, there's a continuous alternation of fuel which occurs. When we treat type 1 diabetes and who are into a lot of exercises, you may realize that there are so much X-carbs we need to add. There's a lot of sprint aerobic activities, which causes a lot of alternation of fuels, and that can cause, sometimes you may see that activity actually increases blood sugar and can cause ketosis. That's because of the inflexibility of our beta cells to change based on the substrate available. So in type 2 diabetes and obesity, the same thing occurs. You have increased free fatty acids, increased fuel substrate, which the electron transport chain goes into the complex 1, and you have increased reactive nitrogen stress, and that's why you get minimal mitophagy, and your decrease in ATP-ADP ratio, which results in decreased insulin sensitivity, and finally beta cell apoptosis. So this is what happens when you have reduction in mitochondrial pyruvate, which comes from lipid oxidation. You have decreased substrate utilization for ATP generation, reduced glucose entry, and endothelial dysfunction, which can lead to complications, hyperglycemia, dyslipidemia, and hypertension. So mitochondrial dysfunction seems to be the basis and accounts for both skeletal and muscle insulin resistance, and also to the impaired beta cell insulin secretion. So long-time exposure to glucose and free fatty acids surpasses this adaptive threshold of switching, because our pancreatic beta cells cannot switch, and leading to decrease in ATP and further vascular complications. So if you look at this is what happens in most of our organs, and mitochondrial dysfunction occurs across organ systems in people with diabetes. And what we are talking about is a new drug which comes to the face called Imeglim. It's got a dual action on insulin resistance and beta cell dysfunction. What it does is that it reduces the reactive oxygen species which can cause oxidative stress. It reduces the liver hepatic gluconeogenesis, and it increases the glucose-stimulated uptake in the skeletal muscle. So in short, it takes care of the core problems which are related to insulin secretory defect and improves insulin resistance and thus improve glucose homeostasis. So I'm not going into a lot of detail of how imeglium impacts insulin secretion, but it helps us to provide different substrates. This metabolic or mitochondrial dysflexibility which is there is changed because of imeglium, and it increases the ATP-ADP ratio. It changes the substrate which is available for going into the electron transport chain, and that's why a cation transport occurs through complement C and 2 and not through complement 1, because of which you have reduction in oxidative stress. So beta cell apoptosis or beta cell dysfunction is lesser. Your increased complement 3 activity, increased NAD, increased potassium ATP closure, increased calcium influx, and better insulin release from the beta cell. Similarly, it amplifies the cellular energetics pathway to improve insulin sensitivity. In the same way, you have increased glucose transport and increased insulin sensitivity. So this is how it occurs in all the cells, that there is mitochondria, all the prokaryotic cells which actually breathe. You have this occurring where it reduces the oxidative stress. It manages the equilibrium between energy and energetics, because it helps what is called as the mitochondrial bioenergetics. It improves the nutrient substrate utilization at complex 3. That's why you have reduction in oxidative stress. So if you look at the action, its main action is on better insulin release, gluconeogenesis, and also it also reduces oxidative stress. Now, whether it has an insulin independent action or the action on the periphery has a cause and effect on the beta cell, we still have to actually find that out. We still don't know exactly how the drug acts. But imeglium, if you compare it to metformin, that's where the comparison will come, and once I share the data, it has an impact on the mitochondrial electron transport chain. It has an impact on potassium ATP closure. It has an impact on insulin secretion, inhibition of the hepatic glucose output, and it improves insulin sensitivity. It also has a role to play in the bioenergetics, which metformin doesn't have. So again, it addresses both beta cell dysfunction and insulin resistance, unlike metformin. So your triple actions are that improved beta cell function, you have reduction in hepatic gluconeogenesis, and increased peripheral glucose uptake in the skeletal muscle. So mode of action is quite different from all other OADs for its effects. This is in comparison of imeglium to metformin, not getting into details of it. So you have some phase 3 studies which I'm going to show. Smaller studies, as you can see, 24, 52 weeks and 52 weeks, and a smaller number of subjects, totally around 1,200 people. If you look at HbA1c reduction, you can see anywhere between 0.4 to 0.87 reduction in this phase 3 randomized controlled trial. So if you look at TIMES-1, which is a phase 3 study in Japan, it's met its primary and key secondary endpoint. Phase 3 was a randomized double-blind placebo-controlled study to evaluate the efficacy and safety and tolerability of imeglium in patients. It is what it showed is that it showed a statistically significant reduction as monotherapy in 0.87% reduction in HbA1c in patients as compared to placebo at the end of 24 weeks, 1000 milligram BID. So if you look at baseline demographics, seems to be the same. So 0.87% reduction, and again was consistent with the phase 2b results. A lot of patients achieved their HbA1c, consistent across efficacy even in patients with chronic kidney disease up to 3A, that is up to 45 eGFR. Again, if you look at its phase 2 study, which was an open label Time-2 parallel group that assessed the long-term safety of imeglium in patients with type 2 diabetes. This was as an add-on to other therapy. So whether you add on to any other therapy, you see that it showed a good reduction in HbA1c from almost 0.56 to 0.92 with imeglium as an add-on to several existing oral hypoglycemic therapy. If you look at Times-3, which was again a 16-week double-blind placebo-controlled randomized trial in patients who were taking insulin and type 2 diabetes, it showed a 0.64 reduction at 36 weeks, 0.54 at the end of 52 weeks. So again, the HbA1c was statistically reduced in all three studies as monotherapy, as add-on to any other oral antidiabetic, and also add-on to insulin. Again, you have a meta-analysis which got published last year, and it again looks at it that imeglium kind of addresses both HbA1c and fasting plasma glucose in treatment-naive or uncontrolled patients. So imeglium has, again, very good safety profile. You have very little differences, very little adverse events, very minimal adverse events, and were similar between both the groups. If you look at comparison with major other therapeutic class, you will see that the HbA1c reduction is very close to a DPP-4 or a metformin, but the action profile seems to be very different for imeglium as such. So the highlights are that mitochondrial dysfunction seems to lead to beta cell dysfunction and insulin resistance. Mitochondrial dysfunction and insulin signaling defect leads to endothelial dysfunction. Mitochondrial dysfunction accounts for both skeletal muscle insulin resistance and impaired pancreatic cell insulin secretion. Imeglium improves insulin resistance and insulin secretory defect by modulation of mitochondrial function to improve glucose homeostasis. It amplifies the mitochondrial bioenergetics pathway to improve insulin sensitivity. It reduces the oxidative stress on the mitochondria. Hence, it's a potential drug for management of diabetes, and its role as monotherapy and combination is supported by RCTs. Thank you all for a patient hearing.
Thank you, Dr. Rajiv, for a wonderful talk. Can I have questions from the audience?
Yes, Dr. Singh.
Yeah, it was an excellent disposition, but only thing, my question is that the 2019, Diffranjo was presenting this paper at ESD, I was there, and maybe later on the ADA. So I think it is already 4 or 5 years. So till how this is a very exciting drug, no issue about that. But when do you think it will going to hit the market?
Good question, because this is also related to a lot of geographic from where it comes in, and where it comes from is not a very popular country for the Western market. But I believe there are 5 players going to hit in the next 1 or 2 months with imeglium. One of them is the session sponsor, but there are 4 others who are coming with him. But you are right. It's been 3-4 years we've been hearing about. Yes, Doctor. DCG has not yet approved the molecule, yes. That is why we are not talking about the molecule right away. Thank you so much.
Thank you, Dr. Rajiv. Next speaker is Dr. G. Vijay Kumar. So from Chennai, he is currently consultant at Apollo Specialty Hospital, Diabetes Medical Center. He has more than 40 publications to his credit. He is also having Dr. Kesar Ahmad, Madras University Diabetic Oration.
Sir, no problem.
Thank you, sir. And he is the organizing secretary of RSDI 2020. That is very important for us.
You made my job.
Yeah. So welcome, sir.
Thank you, respected chairpersons. And before I go ahead, you're all welcome for the RSSDI 2022 in Chennai between October 6th and 9th. And this is a very significant year in the history of RSSDI. And this is a golden jubilee year, actually. So you're welcome. We are there to help, to take care of you. Please come. We'll be there. Okay. Thank you, Dr. Banshi. Thank you, the chairpersons. So after hearing 2 lectures which are very molecule-based, I'm going to come to down-to-earth And what is it we have learned in the last 25 years with landmark trials that we can think about? Now, we know that about 30 years ago, when Hafner has said that mere presence of diabetes is equal to cardiovascular risk equivalent. Mere presence of diabetes. Either if you have cardiovascular disease without diabetes or diabetes without cardiovascular disease, the mortality is going to be the same. That's number one. Suppose if you have both together, and the problem is going to be multiplied. So this is how it said that, and then we started looking into what is going to happen actually. So if you look into the various studies that we had so far, and more to this actually, more to this were going to be there. How about benefit of glucose control in reducing macrovascular complications is a big question that we've been asking again and again. Now the first thing which comes to our mind is UKPDS. We know that it's about median follow-up of 10 years, and the whole study is extended up to 20 years till the end of it. But the median follow-up is going to be 10 years. If you look into the primary endpoint, is there any improvement in diabetes-related death? Is there a reduction in non-fatal myocardial infarction, heart failure and angina, non-fatal stroke, and so on, including microvascular complications as well? Now, if you look into that, in those days in UKPDS, it was only monotherapy. Only 240 patients out of 10,000 patients have been in a combination of sulfonylurea and metformin. Everything is only monotherapy. We didn't have the drugs like DPP-4, pioglitazone, and then we didn't have SGLT inhibitors at that time. Either they are on metformin, or they are on sulfonylurea, or on insulin. That's all monotherapy. And the effectiveness, if you see that at the end of 15 years, you could see that the difference between the conventional and intensive group is only 0.9%. It sounds very disappointing, but look at this. Just 0.9%, about 1% of HbA1c reduction was able to reduce diabetes-related deaths by 21%, the microvascular complications by 37%, heart attacks by 14%, and amputations by 43%, and stroke is 12%. So the only stroke did not get into statistical significance, but all the others you can see that just 0.9% reduction HbA1c has got so much of benefits, both micro and macrovascular complications. Now, it is also told us, it is such we have learned through this UKPDS that the beta cell function, at the time of diabetes detection, there is about 50% beta cell is lost. This is what we learned. And then it is also told that there is no point having monotherapy because every monotherapy that has been there over the years is going to fail. It's about 9 years. And that is the reason if you see that in UKPDS 53, it said that at the end of 7, 8, 9 years, about 68% of the people required insulin for control of diabetes. So monotherapy has got no, and we'll come back to that why we should change from monotherapy to combination therapy. Now, the most important thing is before UKPDS, we didn't have any targets to say, okay, you give the target this much and then you'll have a good results. Instead, what we had in those days is that symptom relief and quality of life improvement. That's the only thing that we had. But this is the first study which said that you have to have a target. Like, bring down the HbA1c less than 7, bring down the fasting blood to 110, postprandial to 160, then you will get the benefit. So this is what, any reduction in HbA1c is beneficial. That's what it said. This is what we learned. And then we started about 20 years ago, the targeted therapy. The targets for control so that we get the benefits. This is the first study. Now, it didn't stop there. After that, after the study is over, they followed it for the next 12 years, and then they found that, and these are all UKPDs are all newly detected diabetes and followed up. So what has happened is that during the follow-up, those who had 1% extra reduction of HbA1c, they did well even the study is over when both the HbA1cs, both the groups are the same. They did improve in the sense that there is a reduction in cardiovascular disease, there is a reduction in microvascular complications as well. And this is what is called as metabolic memory, which is nothing but intracellular hyperglycemia induces overproduction of the superoxide and reactive oxygen species at the mitochondrial level as a possible cause of metabolic memory of hyperglycemia stress after glucose numbering. So what we learned from this UKPD is that we should not wait for glycemic control. We should do it immediately so that the metabolic memory changes. even for the first 10 years, if it's a good control, or if even 5 years of good control, this is going to have a lasting effect in the next 10, 15 years in reduction of complications in spite of maybe not under very good control. So this is what is called as metabolic memory. The first 5 to 10 years is a very, very important aspect. That's what UKPDS we have learned. Then came the DCCT trial. This is basically in type 1 diabetics. And then it's a small study, about 1,400 type 1 diabetics are taken, and then 700 in each one. And then mean follow-up was 6.5 years. And what has happened was that between the difference is that we could see that in DCCT, in type 1 diabetics, the glycemic control has a benefit. That is 76% reduction in retinopathy, microalbuminuria by 34%, neuropathy by 6%. This seems to be extraordinary compared to what we have seen in UKPDS. This is more than what we have seen in UKPDS. I'll come back to that. What is it we can do further beyond UKPDS to get the same sort of results? Now, EDIC trial is what has happened was after that 6.5 years of follow-up, then when they ended the study, and you can see that next 7 years or so, both the groups had the same HbA1c. Now, you look at the results. A long-term good control of diabetes, first control of diabetes, later on in the study, there was able to that 42% risk reduction in coronary artery disease. This is what is called as EDIC trial, extension of DCCT trial. So we can see that the whole concept after these things and look into that VADT trial and etc., it said that what is glycemic legacy has been learned from us, legacy. You can see that if you don't control diabetes in the beginning, what happens is that if you do it late, like what we have seen in VADT trial, what happens is that we may not get benefit later on after 10 years of diabetes. If you try to control tightly, you may not get the same benefits that you can get when you control the diabetes in the beginning itself. And this is what is called as the legacy, glycemic legacy. Now, clearly these two studies have really told us, or we have learned from these two studies, extraordinary studies, how to treat diabetes is the most important. Later on we have studies which said how not to treat diabetes as well. So EDIC and the DCCT, EDIC and UKPDS follow-up studies underscore the fact that good control of diabetes achieved early in the natural history of diabetes has a long-lasting effect with metabolic memory and legacy effect in reduction of complications. So friends, do it as soon as possible. Now, this is my favorite actually study. You remember that there is a difference between UKPDS and DCCT trial. If you come to STENO-2 trial, this is an extraordinary trial. What happens is very simple. It is nothing but multifactorial management. It's not just glycemic control. You address the lipids, you address the hypertension. A holistic approach to type 2 diabetics is taken into great strides, and you can see that 4 years follow-up. In fact, you can see that there is a reduction in nephropathy by 63%, extraordinary, even beyond DCCT. Retinopathy by 55%, and the neuropathy, autonomic neuropathy by 70% almost. This is at the end of 4 years. In fact, they have to stop this study because the conventional group are devoid of these advantages, including cardiovascular disease reduction. So they have to stop this study because it becomes an ethical issue. You are denying the people who are in the conventional group the benefits that you got in the tight control group. And that's the reason they had to stop it, and everybody has put on to multifactorial management. Look at what has happened about 8 years follow-up. You can see that there is a 53% risk reduction in cardiovascular endpoints. It's phenomenal. And then you can see that the same effect on microvascular complications continued. At 13 years, you can see that there is 57%, there is further improvement on 57% reduction, and there is 46% reduction in mortality. This is again extraordinary with that. At 20 years follow-up after STENO trial, you can see that clinical benefits of a legacy effect that we have seen with both the DCCT and UKPDS. The intensive multifactorial treatment of patients with type 2 diabetes and microalbuminuria, that it has increased, there is an increase, the gain of 7.8 years of life, according to the calculation. So that means it's not just glycemic control. Along with that, glycemic control has benefits. If you can control also, what we learned from STENO-2 is that apart from glycemic control, which has got benefits, if you can control also the other comorbidities that are associated, majority of the people who have got type 2 diabetes have got hypertension and dyslipidemia. If we can do that, the benefits are going to be, now 1 + 1 is not 2, rather 4. That's what it has said. Now then came, about 15 years ago, a landmark trials in the form of ACCORD, ADVANCE and VADT trials. These are the 3 trials have shown, so far you can see that the UKPDS, DCCT and as well as the STENO2 trials have shown how to treat diabetes. But whereas these trials, these 3 trials, which has come again, landmark trials, the results look very negative. But it's also said that how we should not treat diabetes is the main thing that we learned from these 3 trials. Now look at the ACCORD trial. These are all about average duration of first 10 years, and the inclusion criteria itself has got high risk population, and then the study is supposed to be for 3.5 years, but they have to end this study at the end of 2 years and 3 months. I'll tell you the reason. And also the 35% of these subjects had already macrovascular disease, and then they said by hook or crook, within 6 months you need to bring down the blood glucose level or HbA1c level less than 7. We don't know what is it. And 65% of the population in ACCORD trial had rosiglitazone. We see that. The primary endpoint, if you see that, the non-fatal MI, if you can see that, non-fatal MI, there is a good reduction. This is a primary endpoint, 186 and 235. But whereas you look at the CVD death, which is increased by 135 versus 94, and this prompted that they have to stop the study. Okay? So now it showed how not to treat diabetes as well. So this trial stopped. The mortality is higher in patients with severe hypoglycemia because when they were so in a great hurry to bring down the blood glucose, in a 10-year diabetic patient, long-lasting diabetes, who had HbA1c more than 8.5, and suddenly you try to bring down the HbA1c, there is increased mortality, mainly because of hypoglycemia. The autopsy has not been done in these people. It is suspected to be myocardial infarction, but it could be hypoglycemia. Most often, about half the people are supposed to be due to hypoglycemia. So it suggested that we have to have an individualized treatment is suggested, less aggressive lowering of HbA1c in high-risk population, patients in the intensive group who did not have history of CVD, and those baseline HbA1c was less than 8 had a significantly low events, indicating that short duration of diabetes and healthy people, we can be aggressive, rest of the people, we should not be aggressive. So there are so many, that the sub-analysis of ACCORD trial, which is a negative trial. I always, though people say that negative trial, I take it a positivity that how not to treat diabetes. We can see that there's a physiological hypothesis, behavioral hypothesis, and health system hypothesis in this. The hypoglycemia preconditioning is very, very important. Instead of having a sudden severe hypoglycemia, even if people have some, you got that ischemic precondition, we talk about that. There is something they have evolved stating that it's a hypoglycemia precondition. Mild hypoglycemia, which is not dangerous, could be beneficial. That is number one. And behavioral hypotheses include that those people who did not quickly come down HbA1c, have a look at those people and don't treat too aggressively, try to bring down a bit slowly. Otherwise, they'll get into severe hypoglycemia, and that can be detrimental for the life as well. And then, all this is also said that health system hypothesis is said that algorithm basic tactics increase the risk in high risk population, and then you need to have a individualized tailor-made goals for these people. So these are the things it taught us, if you look into the sub-analysis of what has happened there. So this is an important in the sense that though it's a negative trial, they had to stop the trial, we learned something from there. Advanced trial, again, it's a, it's again the trial has been suggested or done in people who got a long-standing diabetes, who got a cardiovascular disease, and then, they were able to try to treat diabetes in this population. We should do minimum about, again, here also you can see the 32% per macrovascular event. Now, what has happened was that there is not much of a result. It is only that intensive glycemic control reduced combined primary outcome, that is both micro and macro together. There is no difference at all. There is no statistical difference at all between the intervention group. What has been found in this particular thing is that the usefulness of sulfonylureas did not increase the mortality. before even the Carolina trial has come. So this is told like this, and then there is no harm in continuing sulfonylureas. That's one thing that is shown. But again, you can see that the VADT trial, again, this is very old people with all complications together. You can see that 40% had prior CVD, 80% had hypertension, 50% dyslipidemia, and baseline HbA1c is 9.4, and then they followed for 7.5 years and got the results. So look at this. There's a good improvement, but not to such significance. So you can see that all these three trials seems to be looking negative, but what you need to understand is that these are all having all the macrovascular complications, a long-standing diabetes, and baseline HbA1c is very, very high, and there's no point in doing this. These results do not apply to patients with less advanced disease, younger patients, and early aggressive treated patients. It doesn't happen. That's what is seen in UK PDS and STENO2. That's a different issue. For intensive glucose control, to yield significant CVD reduction, you may have to do it early. If you go into population that already had multiple risk factors, cannot expect benefits from glucose control in the short term. This is what we have learned from these studies. Now then came the molecular base. These are all, the studies with glycemic control. Then came a very important molecules that we have in the last 10 years or so, in last 5-6 years or so. We have a fantastic, which changed the, the way we need to treat them. What we say that it has given us a lot of opportunities to have better control. One is DPP-4 inhibitors. About 15 years ago we had. It has changed the way we thought about the disease. Now we go to EMPIRIC outcome. You can see that all of you know about that. It reduced the CV death by 43% and mortality by 38%, and and so on and so on. Heart failure, basically heart failure, hospitalization is reduced to a great extent. So we can see that then, apart from that, we have CREDENCE trial, which we got it, and even DAPA kidney we got, and EMPA renal is to be out shortly. This has showed that the benefit on renal aspect as well. 2 minutes. So that it will increase the, it will increase the, and then these are, what are the benefits you got in these trials? It looks like seem to be the class effect. All the SGLT inhibitors will have the same benefit for all the benefits that we have. Then we had a lot of GLP-1 receptor agonists, which also showed CV benefits. Now, if you see that, you look into that, the philosophy of treatment is changed now. That is that there's no point in, remember what has found in UK PDS, it's a monotherapy. Now we have to come to a state that the philosophy of treatment is don't address hyperglycemia, rather address the pathophysiological factors that cause hypoglycemia. And then the benefits, it should be there in that place, that reduce hypoglycemia, reduce weight gain also should be there. For that we have to be proactive, not reactive therapy. Go for a combination therapy from the beginning itself. That's the main thing that we can think about. Now, to suggest this or to confirm this, what we have learned from VERIFY study, especially Indian population, is that we can see that if you have an early combination of therapy, there is 53% risk reduction in time to initial failure versus monotherapy. And then if you can see that, when you have a monotherapy, it is about, they fail at 1.5 years. And when you have a combination therapy with DPP-4 in the beginning, the failure is going to be at 4.75 years. This is something extraordinary, 3 times. This is much better than in Indian population compared to the whole population of 2,000 patients all over the world. So if you can see that the need for third agent when you are in a combination therapy is reduced by 58%. So it indicates that we need to address more and more pathophysiological factors. That's what it says actually. Carolina trial basically done to know the efficacy and safety of linagliptin, but what you have found is that this has been taken over by the sulfonylureas, the linagliptin. So linagliptin has been Carmelina trial, it has been found to be cardiovascular safe. So the compared again with sulfonylurea, they found equally good results. There's no one is non-inferior trial actually, non-inferiority has been found. So sulfonylureas can be a very good agent, which are very, especially glimepiride, in this study is only glimepiride. It said that it's a safe coronary artery receptor. So friends, if you look into that, what is it we have learned from these studies is that most of the landmark trials have made us understand the disease better, change the philosophy of management is explained and taught how to treat and also how not to treat diabetes. Thank you for your patience.
Thank you very much, sir, for very elaborative talk. Any questions from the audience?
I think this was a very beautiful journey you presented, and I was really happy that about how to treat and how not to treat. Suppose out of all these trials, and I say you to pick up only three trials, the best trials, which changed our practice. What could be that?
Steno 2. That's my favorite. Sir? Parag is there. That's one. No. That's the first one I think about. That. No, this philosophy is that.
It was an excellent coverage, Dr. Vijay Kumar. There are two different separation between the kind of a trials. Also the reference to what he mentioned. Some are regulatory required trial. Like Empareg was a regulatory required trial versus a disease behavior or the treatment change. Lot of lessons we learned from Accord, what you presented. So it's a Steno, Accord, which teach you many things versus a small Kaplan-Meier curves separating in a regulatory CV outcome trial.
Thank you, sir.
So with this, we are at the end of this session. Hand over mic to the organizers.
Good evening, everybody. For the next session, I would like to call the chairs. Dr. Shailja. Shailja ma'am is here. Okay, thank you. And Dr. I'm really sorry, Dr. Shailja is really sorry. I'll call the next chairs. Dr. Bhupendra sir. Dr. Alpesh Patel. Dr. Sanjay Chaudhary. Okay, I'll do the chairing then. Yes. Thank you, sir. I'll welcome Dr. Shailja.
Welcome to NGPA Symposium. First of all, I am very much thankful to Dr. Bansi Bhai for honoring NGPA by keeping this NGPA Symposium in his prestigious conference, and also thankful to him for inviting me to chair this session. We have three talks in this session. For first talk, I invite Dr. Shailja Kale. He is MD Medicine and MD FRCP London, FSCP USA. He is a professor in internal medicine and consultant diabetes.
Same time, one word of caution, it can coexist. So it can, both the things can be there in one patient. So these are the drugs which we are aware, but just to list it, I'm not going into details, but we need to rule out what the patient is on drugs. Now, if you take type 2 diabetic patient, almost 75 to 80% will be having a NAFLD diagnosed on ultrasound, which may be fatty liver grade 1, 2, etc. But type 2 diabetes itself is a risk factor for severe fibrosis. So a non-diabetic getting fatty liver and a diabetic person getting fatty liver, there is a difference. A type 2 diabetic person, when he gets fatty liver, he has a more chance of getting fibrosis, to get end-stage liver disease, more cardiovascular mortality, and more chances of overall mortality. So in general, as we see in type 2 diabetes, the risk is much more just by that beta cell deficiency diagnosis whenever there is additional fatty liver. And we know it's a continuum. So advanced NASH or advanced cirrhosis is much higher if someone has diabetes. So in a diabetic clinic, someone comes with fatty liver, it should raise an alarm, which is not happening. So patient with fatty liver or maybe NAFLD grade 1 to 2, they die not because of the advanced cirrhosis, but they die because of the cardiovascular event. 38% mortality is because of the cardiovascular event before they reach the grade 3 stage, F3 stage of NASH. Non-hepatic malignancy. So once there is a kind of a NASH, one should be aware that this person needs aggressive treatment for cardiovascular risk reduction and also then screening or surveillance for advanced liver disease. So these are the kind of a grading done, and previously it was said that once there is cirrhosis or fibrosis, it is not reversible, and now we have lots of studies that even there is a fibrosis, it is reversible. Even a partial early cirrhosis is reversible, and many new drugs are also coming. So that's the new knowledge in NASH, which is showing great trials are on the way, which is a good time where we can really do something for these patients other than subjecting them to the liver transplant. So simple fact, and without inflammation, we know it can be just a healthy liver, but it can progress to the next stages where it is steatohepatitis, where there is some inflammation and ballooning. So the diagnosis usually is by histology, by liver biopsy. That's what the definition says. Now our job as a working in the clinics, how to diagnose it clinically or without doing a liver biopsy. That's what I will discuss in next 10 minutes. So let's understand the fibrosis-based algorithm for NASH management. So if you can see here, earlier stages, the mortality is because of cardiovascular or extrahepatic cancer. At the late stage, it's a liver-related disease. In between, it is both. So these patients with stage 0 to 1 are entirely with physicians in the clinic. So the whole responsibility of a physician to prevent not only advanced liver disease, but also to prevent cardiovascular events and the other thing. So one needs to be extremely aware of this problem. Stage 1 and 2 is slightly advanced. We will come to it how to diagnose them clinically. You need a joint management with a gastroenterologist and a physician. And for advanced stages, of course, we need a tertiary care, kind of a care for all these patients, maybe liver transplant. So lifestyle intervention, bariatric surgery has shown a great results in reversal, even in up to the grade NASH stage 3. It can be reversed here. Once it's not only weight loss, but in bariatry, as the GLP-1 goes very high, which we have now GLP-1 studies as well. We'll discuss about the drugs more when we are in the last few slides, after I present the clinical picture or diagnosis of NASH. So it is not that it progresses like this, like we see in albuminuria, stage 1, stage through CKD. It can be from multiple directions. It can diabetes, he doesn't have hypertension. On routine checkup, BMI 26.5, his AST, ALT, OT and PT are 58 and 49. Rest of his LFTs are normal. Count 12.5, 7,152 platelets. A1C 5.9, lipids normal. No proteinuria. Sonography showed grade 1 fatty liver. So if someone comes, we say, no, there must be alcohol. When have you done? Did you have some viral fever last few weeks with that slight increase? Okay, repeat it after 3 months. Many times patient may not come back. So what should we do when there is a gentleman like this? There is very mild raised SGPT-OT and there is a grade 1 fatty liver, which we usually say, oh, it's wo to sabko hota hai. You don't have to do anything. So really we need to be more aware of this patient. I will come to that what this gentleman actually has when you investigate him for NASH. He is on metformin. So what next? We need to rule out other causes of hepatitis. HOMA-IR was calculated 1.4. It's showing some resistance. Autoimmune hepatitis also one needs to work out before we subject a patient for MR elastography or some fancy investigations. Then comes fibroscan and liver biopsy. So when this person comes, what 2 questions one needs to ask to oneself in the clinic? Does my patient have NASH based on clinical criteria? Is my patient at risk for clinically relevant liver fibrosis? So what is the chance that this patient will have fibrosis? What is the stage of this patient for NASH just by clinical diagnosis? So there is this study by Veteran Hospital which they have published, a simple kind of a clinical parameters for clinical definition of NASH. So this is population management of non-alcoholic liver fat, steatosis on imaging as this gentleman has fatty liver or on biopsy, but also mostly on the imaging, ALT more than 25 and either obesity or type 2 diabetes or dyslipidemia or metabolic syndrome. This is enough for a clinical definition of NASH. So this is important. So one should start suspecting that this gentleman has NASH. Now we need to see what is the stage or grading of this. Now there is lot of things which are assessed by different scans about how much is fat in the liver. So assessing the severity of the fat in the liver, ultrasound will say grade 2, grade 3, and for that we all feel physicians, oh grade 3 it is very bad, oh grade 1 is mild. That concept needs to be removed because the amount of fat has nothing to do with the prognosis of or kind of a developing end-stage liver disease. So higher liver fat is associated with high insulin resistance and metabolic complications. So even though grade 2, 3 fat on ultrasound, patient has to be motivated. So it helps to motivate the patient. That's all. But quantity of fat does not predict. So even the grade 1 fatty liver may progress to the fibrosis and the cirrhosis. That's what I mean. And that's what all the experts say, that severity just helps a physician to be more kind of aggressive and patient who gets motivated faster. There are some scores which we can do it on clinical basis. I have just taken one APRI score which takes into account AST level divided by upper limit of the AST divided by platelet count multiplied by 100. And this APRI score for this person, gentleman, is 0.95. If it is less than 0.5, it rules out advanced fibrosis. And if it is more than 1.5, it suggests cirrhosis. So this gentleman has 0.95, so we cannot ignore it. We can't say just he had some viral fever 10 days back and that's why PTOT are high, or maybe there was alcohol which he is denying. And so one needs to be very careful looking into this. Then there are FIB scores, which is a bit complicated, but you need to take into account along with liver enzymes, albumin, and impaired fasting flow. All these parameters will give us a FIB score, which also helps for the clinical diagnosis and staging of the NASH before we subject a patient to the MRI or fibroscan. So what it shows that simple biochemical parameters and a novel score, which is published by this Mumbai team, Akash Shukla, in the Indian Journal of Gastroenterology. Excuse me, can I have some water, please? So if we are seeing a patient of fatty liver, one needs to see the liver enzymes. Platelet count is very important. And we can give a scoring with each point. So higher the score, 75% chance for advanced fibrosis. So once we see fatty liver, look at the liver enzymes, do the quantification, and also see the platelet count, which is very important. So the red flag signs less than 2 lakhs, more than GGT, coarse liver, bright is only fat, the coarse echo texture, and of course liver and then these enzymes. So this gentleman was subjected APRI score, as I said, fibroscan was 12.5. So it is not to be ignored. He has NASH, which is stage 2 or 3. So a simple gentleman who, if we come in the clinic, it says ASCVD no. So you just think he doesn't need aggressive cardiovascular risk reduction. Because doesn't, no hypertension, no microalbuminuria, no smoking. But he has just grade 1 fatty liver, and you can see that he has fibroscan 12.5, a very high risk of cardiovascular risk factor. So I'll come to this next. I just want to have 2 slides for saraglitazar. We know this molecule as a dual PPAR alpha and gamma agonist. This PPAR alpha action, like fibrates, has a very good effects on triglycerides and ApoA1, and then that's why it improves lipids. At the same time, PPAR gamma effect, it improves insulin sensitivity. So the main hepatocyte ballooning, excess fat among the hepatocytes, and insulin resistance, both are tackled by this dual PPAR gamma and alpha agonist saraglitazar. It has very good studies shown that in a simple trial that it improves insulin sensitivity index within 4 months, and also we are using to treat simple type 2 diabetes as an insulin sensitizer that we all are in clinical practice. Now in last few years, it has taken a great leap to show that effect on NAFLD, which actually shows, this study was MRI driven. On MRI, it showed a good improvement of the use of saraglitazar, and at the end of 16 weeks, 104 NAFLD patients diagnosed with MR elastography, so which is a gold standard. So it is showing a good effect, saraglitazar at 16 weeks. And now the latest one, which was actually, this is again a biopsy-driven phase 3 study from India, where it's a 1-year treatment of saraglitazar, biopsy-proved patients of NASH, and grade stage 1, 2 or 3, they were recruited and treated with saraglitazar for 52 weeks, and there was a progression of NASH was significantly reduced in the group which was used saraglitazar. So points for discussion for my talk are, one should think of lifestyle intervention. I think less than 5% improves fatty liver, less than 7% of weight loss can have a effect on good in the even stage 2, 3 reversing of the NASH. Pioglitazone, DPP-4 inhibitors, SGLT2 inhibitors have all shown good effects. Empagliflozin has shown on the effect on the liver biopsy, proven like saraglitazar, good effect. DPP-4 inhibitors, sitagliptin has shown. There are also studies with vildagliptin, but DPP-4 inhibitors, there's interesting, if any questions, I will go about how the DPP-4 inhibitors act in the liver, and the great results from GLP-1 analog. I cannot end my talk unless I say this, that these incretin-based drugs are actually showing a good result for the NASH, and which can help in reversing the NASH. So thank you so much. It is just that a person comes with fatty liver and ASCVD, no, we can't just rule out. We need to be aggressive. Look at the liver enzymes, look at the platelet count. We can do the APRI score and the FIB score in clinical practice, and CAP fibroscan, which is available, which can be done. MR elastography is gold standard. Maybe sometimes radiologists say it is better than liver biopsy to diagnose NASH. Thank you so much.
Thank you. Thank you very much, ma'am, for very excellent and informative talk. Any question from audience? Okay, then proceed. I request Dr. Sanjay to invite next speaker for next talk.
Hi, good evening. I would like to invite Dr. Anke Singh from Dhanbad. He would deliver a talk on severe risk reduction in type 2 diabetic patients. He is practicing as diabetologist at Dhanbad. He is director at Diabetes and Heart Research Institute. He is chairman RSSDI Jharkhand, also ex-governing body member at National MPPI. Also, he has edited Millennium Book of Medicine. He also published more than 30 national and international publications. Also, he is admin and founder of CMA India. So now he will discuss how to reduce the severe risk reduction in type 2 diabetic patients.
Good afternoon. Thanks Dr. Bansi and whole this Diacare team for giving me this talk. I think this talk is very favorite to Dr. Bansi Sabu. I told that I have talked many times on this subject, but he told no, this is you have to do. Why this is so important that in India, you know that the CVD attributes to nearly 25% of all this. And the overall diabetes prevalence of type 2 diabetes in India is increasing. And it has been also found that the Indian progress faster than from the pre-diabetes to diabetes compared to other ethnic groups. So this will be the scope of my talk, which I will going to discuss. Look, it is very difficult to reduce the severe risk. This is the reality. But today we have the evidence. They say that if you target the main risk factors like dyslipidemia, hypertension, smoking, or family history of premature coronary disease, if you take care, you see the albuminuria and BMI and presence of hyperuricemia, this is going to help you. So this is a very, very huge problem, as you are seeing here. I admit that this time, in 2022, the concept of glucocentric approach is weakening. While the tight glycemic control is the backbone of diabetes, the management of, you see the recent trials, they have focused on the cardiovascular risk reduction as the primary objective. So what we find, a contemporary shift in the recommended strategy which extends beyond the glycemic control. This is from the evidence from the CBOTs. But remember that we must not forget that there are compelling and established data which support the benefit of long-term glycemic control in reducing the risk of microvascular complications, and also the importance of legacy effect that is quite clear. So this is my first point I want to make it clear. Now, do you know the risk factors? If you know अगर आप अपने enemy को जानते हो, अपने दुश्मन को जानते हो, you can make a better strategy. So we know the risk factors. We have got lots of studies on that. So let us identify and discuss about it. This is a very recent data presented at just now, this month itself, at the ESC Congress, DENCAB trial. You see here, they took a cardiac and truncal non-contrast computed tomography to detect coronary artery calcification score, the brachial and ankle blood pressure, and the blood test to identify high cholesterol and diabetes. And what it showed, at least 11% decrease in those aged 65 to 69 years. And in the post-hoc analysis, reduced the risk of composite endpoint of death, stroke, or myocardial infarction by 7%. So this shows that at least what you are going to tackle, these risk factors, this works. And if you go for the so many guidelines, ADA, ACE, KIDGO, ESC, ESD, HA, ACC, many others, this is a very, very challenging task to tell you the exact points what we are going to do. But this is editorial, he wrote Dr. Martin, that the guidelines are generally aligned in recommending lifestyle interventions, number one, aggressive management of blood pressure, LDLC and blood glucose, and providing renal protection. So this is a very, very important statement by him. So main differences involve risk stratification criteria, lipids and blood pressure, treatment targets, and indications for addition of these days, the SGLT2 inhibitors and GLP-1 RH. So prevention of vascular disease and mortality recommendations, you are well aware, whom to screen. But my point is, we will follow the ADA 2022, and this is also supported by the RSSDI, that in asymptomatic patients, the routine screening for coronary artery disease is not recommended, as it does not improve the outcomes as long as atherosclerotic cardiovascular disease risk factors are treated. This is a very, very important point. The second point is more important, that consider investigations for coronary artery disease. If suppose a diabetic patient is coming in your clinic, and if you find he's saying that there is atypical cardiac symptoms, like unexplained dyspnea, chest discomfort, signs and symptoms of associated vascular disease, you have found the carotid bursts or transient ischemic attack history there, a stroke, claudication, or peripheral artery disease. These are the very, very important clinical pointers which you should take care. And then you categorize whether your patients come in a moderate risk, high risk, or very high risk. You can see how it is being done. Then the question comes, how you accurately CVD risk estimation you are going to do. And there are lots of systems, like ESC says you follow the SCORE2, but I will say for the tools for early detection, the QRISK-3 or JBS3 and coronary artery calcium, lipoprotein A, remnant cholesterol, TRLA, these are very, very important things which you should take care. And basically, ideally, country and risk calculator specific risk reduction, these such calculators should be used, which we don't have exactly in India at present. What RSSDI mentions, that I would like to tell you to follow, that is the QRISK-3, and this is very, very important again. That this is a very simple and very relevant to our population. Then let us how to prioritize it. So this I think Dr. Sanjeev Phatak is here, and has published so many papers also on the coronary artery, this calcium scoring system. I'm not going into detail of that, but this is a very, very important modality which has become emerged. And I think this is a very important slide which says you how to using the 10-year atherosclerotic cardiovascular risk estimate. If you take your also the CSC score, how when do you should take, recommend the statins, when not to start. So I will also, this is, you can see here, so this is very, very important things that is emerging. Regarding all of these modalities, this coronary artery calcium scoring can reclassify the CVD risk. Number one, the CCTA, the contrast computed tomography coronary angiography, this allows identification of coronary stenosis. IMT, intima media thickness is not recommended. Arterial stiffness, these studies show that the predicts future CVD risk, and other are BMI based. Now it is very important clinical things. A diabetic patient coming to you saying that there is migraine, suffering from migraine. You know, a 2-fold increased risk of ischemic stroke and 1.5-fold increase in the risk of cardiac ischemic disease happens if it's suffering from migraine. In the same way, periodontal disease has been linked. The inflammatory conditions like rheumatoid arthritis, psoriasis, HIV, 19% increased risk. In the same way, ischemic stroke, sex-specific CKD, patient is suffering from atrial fibrillation, NFLD, ED, erectile dysfunction, COAD, OSA. So you take also history to your patients. If they are suffering from these things, be very careful. Then you know the optimal levels, the target goals. I think it is well known to you. I will proceed here. Now let us start what we are going to exactly do for our patients. The first thing is go for modification of the diet. You see that the prospective urban and rural research study, pure study, that if you are taking a diet that is highest quintile of glycemic index had a significant 25% higher risk of combined total deaths and CVD. So this pre-debate study also says that if you are following something around a Mediterranean diet, there is 30% reduction in risk of cardiovascular events. So this is very important, and this is given everywhere, the RSSD, ESI clinical practice recommendations, how you go for carbohydrates, fats, protein. I will not go in detail, but the important point is on average, a 2% increase in energy intake from trans fatty acid, which you are taking every day, is associated with a 23% higher CHD risk. Here you can do something. And these are very practical tips. Only you take 7 grams per day higher intake of total fiber, 9% lower risk of CAD. 10 gram higher fiber intake you can see here. A meta-analysis also shows that if salt reduction, 2.5 gram per day, resulted in 20% reduction of atherosclerotic cardiovascular events. So even the nuts, a simple thing, a meta-analysis of the prospective cohort studies has shown that daily if you take 30 gram of mixed nuts, associated with a 30% lower risk of atherosclerotic cardiovascular disease. Otherwise, you know about the fish oil supplements. So these are all important things. The second thing, after modifying the diet, never forget your patient to tell the exercise is a muscle mitochondrial medicine, the most important thing. And my slogan is make your mitochondria green. You can do it, how the list looks this mitochondria of a sedentary person and the exercise trained person. This is a very, very important message. This is the most important intervention you can suggest to your patient. I'm not going detail now, but even the cardiovascular improvements is immense with the exercise. And also on the NFLD, I will go so these are the things. Even if you go for the data, the recent evidence suggests that adequate physical activity may reduce the risk by up to 27%. If your patient is not able to do daily walking or running, you just suggest 5 to 10 minutes of doing Surya Namaskara that combines both aerobics, resistance, and even the mind healing, everything by Surya Namaskara. And other thing you can do also the high interval training, this is takes only 5 to 10 minutes. Next point is if your patient is suffering from hypertension, this is again the most important intervention you are going to do. And if I ask you, if your patient says, which one is more important, tackling hypertension or tackling diabetes, your sugar, what could be the answer? It is a unique fact that tight control of glucose decreases risk of microvascular complications, but the tight control of blood pressure reduces both micro and macrovascular complications. So this is very, very important thing. We have lots of data for that. then you must have this is chart in your clinic. This is very, very important ki how you start with one drug or two drugs in a patient of diabetes. If there is patient have even the albuminuria or CAD and the initial BP is less than 160 and 100, I think no or else accordingly you should start the ACE inhibitor therapy. But if the patient is having a BP of 160 and 100 more, and also you must start two agents. And if patient is suffering from albuminuria, you must start at least ACE inhibitors. That is a compelling indication again. And if it is not controlled, what to do, then it can showing here. One pill or two pill, that is very, very important. This is all available. The next point is the high intensity statin. This is very, very important point again. Which statin, the moderate intensity or high intensity, and there is lots of things there, but the ADA says that obtain a lipid profile at the initiation of your treatment, and for patients with diabetes, if they're suffering from 40 to 75 years without atherosclerotic cardiovascular disease, use moderate intensity statin. Addition to the lifestyle, this is a level A indication. In the same way, patients with diabetes, suppose the age is 20 to 39 years, but with additional atherosclerotic cardiovascular disease risk factors, it may be reasonable to initiate a statin therapy in addition to lifestyle therapy. For primary prevention, this is the thing. For secondary prevention, I think you are well aware. I will not go in detail for that. Again, the patient is only suffering from the high triglyceride, you must tackle it. And these days, this recent trial, I think just published from the reduced IT trial, it has demonstrated a drug like icosapentalethyl. This is have been found very, very effective. A significant reduction in the clinically important ischemic events with this drug, including the primary composite endpoints of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, or unstable angina. So what is the point here? Taken together, these findings call for a re-evaluation and expansion of all the worldwide guidelines to incorporate IP, which is very available in India also, and that dose is something around 4 grams per day. Now antiplatelets, the use aspirin therapy, and even for the primary prevention, there are some points where you could consider it. This is regarding this, even if you are suffering from the peripheral artery disease, there are lots of things which you can do. And I think lastly, in the concept is changing in diabetology today, that from the very beginning, even for the primary prevention, the SGLT inhibitor should be given. The chamatkar ko namaskar kijiye. I will not go in details for that, but this is what is happening with the latest guidelines from the American College of Cardiology. So my final takeaways are, a key step in the care of patients with type 2 diabetes is to address lifestyle modification. इसके बिना काम नहीं चल सकता है. That is dietary modification, physical exercise, the most important things. And let us impress the importance of prescribing evidence-based glucose-lowering therapies, that is SGLT inhibitors. That is now cheap drug for the diabetes also. It only 7 to 10 rupees you can get it, so get it. And the screening for CAD in asymptomatic type 2 diabetes patient remains debatable at present. And the CCTA, routine use of ischemic testing in asymptomatic patient is strongly discouraged. But coronary artery calcium score appears to provide the most actionable triggers for considering preventable therapies, including antithrombotic drugs, lipid-lowering therapies, and GLP-1 RH for primary prevention. And also you take whether your patient is suffering from DKD. This is very, very important. This DKD is independently associated with poor outcome. So you should then must choose SGLT inhibitors or GLP-1 RH, and the most recently a drug like finerenone, a selective non-steroidal mineralocorticoid receptor antagonist that improves renal and CV outcomes in prevention of the DKD. And traditional strategy for delaying the progression of DKD, you know, so individualize the approach for the hypertension. And lastly, I think even the non-statin therapy that is going to emerge in the next few years, and like PCSK9 or icosapentalethyl. So lifestyle modifications, CV imaging, medications you see here, and follow this mantra of A, B, C, D. HbA1c reduction, blood pressure, cholesterol, diet, and exercise. So last point is that adherence to treatment, a healthy diet, and lifestyle modification are important. Believe it, in patients with reduced Residual risk and hypertriglyceridemia, lifestyle modification plays a critical role. Appreciate it, and reducing the CV risk requires a multifactorial risk reduction strategy. It happens, and team-based approach is needed. This is an art to tackle. Thank you very much. Thank you.
Thanks for patient hearing. Dr. Anke Singh has nicely deliberated how we reduce the CV reduction in type 2 diabetic patients. So, any question from audience?
Dr. Sajeev, I will ask rather a question, because you are more experienced with doing this coronary calcium scoring. So what is your experience?
Thank you for acknowledging that work. But my question to you is, ADA does not recommend routine screening in absence of symptoms.
Yeah.
Is it relevant for our Indian patients also? Because time and again we find that there are patients who are asymptomatic, high risk, and if we get their coronary calcium score, it turns out to be 1,000, 2,000, the treadmill comes to be positive, though they are not symptomatic, whether to intervene or not.
I think you have raised a very, very pertinent question, that Indian patients definitely differ in lots of senses. So what we are following in most of our guidelines, even in the Indian guidelines, maybe the Endocrine Society guidelines or RSSDI guidelines, basically I don't think we have a proper study at present in India so that we can recommend you, but I think this must be taken care by the RSSDI, and we must have some inputs on that for evidence-based strategy. At present we don't have, so we follow the Americans, but I think your point is very valid. So in the event, even the Indian diabetics asymptomatic, but if there is any clinical pointer, then I think you should go for the...
True, because the Dan Canvas study also mentioned that the routine screening may be helpful in selected group of patients depending upon age and gender.
Exactly.
Any other question? Okay, nice. I hand over mic to Bhupendra Shah sir to discuss next lecturer for our session. Yeah.
First, I congratulate Bansi for organizing such a nice conference, and we are also thankful that for our North Gujarat Physician Association, he kept NGPA symposium. Our next 20-minute talks on modern sulfonylurea in the era of cardiorenal outcome. And Dr. Jimit Vadgama is our next speaker. He is a fellowship in endocrinology, diabetes and metabolism, Mumbai, MD Medicine, cardiodiabetic, consultant endocrine, diabetes and metabolic physician at Surat, co-author of RSSDI guidelines for inpatient management of hyperglycemia 2016. Executive Editor, RSSDI Textbook of Diabetes, 4th edition. 2019 Rising Star Award from Indian Academy of Diabetes. TYCA National Award winner 2016. Member of American Association of Clinical Endocrinologists, USA. Former Assistant Professor of Medicine, GMC Surat. And he published multiple research publications with greater than 10 chapters in books.
Thank you.
Over to Dr. Jimit.
Thank you so much, respected chairpersons, for the kind introduction, and thank you, Dr. Bansi sir and the organizers of DIACON for inviting me here. And today I am going to discuss one of the which modern sulfonylurea and metformin fixed dose combination we should choose. So these are the disclosures. This is a sponsored topic, but the main disclosure is I like the molecule gliclazide, and I exclusively write gliclazide. That is one of the reasons why I am given this topic. So, starting with the topic, the current place of sulfonylurea in all the international guidelines. So, we have seen last couple of years the guidelines have changed and recommended the individualization of treatment. So, and they recommend the molecule based on the risk factor or the current characteristic. And sulfonylurea they have reserved lastly just for the cost purpose. Where cost is an issue, you can use sulfonylurea or pioglitazone. This is the main area where they recommend. But Indian realities, they come different. And that's why we have our own guidelines and recommendation. Why? Because if you see the real world data, the major CVOT trials, we change these guidelines. Okay. they included the high-risk patients, and the actual population, study population, didn't correlate with the actual or actual real-world data. If you see, 64 to 95% of the patients seen in clinical practice, they do not have a proper or established cardiovascular disease, and they do not represent the proper CVOT population. And this means there is a uncertainty that the CVOT trials results benefit the applicable to patients seen in real world scenarios or not. So this is a question everywhere. So that's why Indian guidelines are different, and you must be sure about the RSSDI wheel also, where treatment decision is based on multiple factors, not just the established cardiovascular disease or the ADA guidelines. It depends on the glycemic efficacy. This is the first word they've used: route of administration, safety profile, minimum hypoglycemia, patient's preference also, comorbidities also, and very important in India is the cost of treatment. So this is why Indian guidelines are different, and the Indian scenario is very, very different, and we all know in our OPD. We have a huge population of type 2 diabetes patients in India. And very important thing, we are seeing a patient at younger age also. And we can see the average A1C at diagnosis is around 9. So this is very high. And 70% of them are still uncontrolled in actual practice also. So they need to spend out of their pocket also. This cost is also again a very important issue. And this younger and newly diagnosed, I am sure in your OPD also you are seeing the tremendous increase in the young type 2 diabetes in post-COVID era. Very important thing is they are going to spend a lot of decades of their life with type 2 diabetes. And this is very important. The importance of initial tight glycemic control comes. And if you delay intensive treatment by 1 year in conjugation with poor glycemic control, significantly leads to increased risk of MI, heart failure, stroke, and even any cardiovascular event. So we have seen data from UKPDS also. I'm sure some of you might be present what Dr. G. Vijay Kumar sir has already told. The early intensive treatment leads to a very wonderful legacy effects, and that is what we want to give our all type 2 diabetes and younger and newly diagnosed patient. And if you see the data, even the trial has ended in 1997, you can see 12% reduction in any diabetes related endpoints, 25% reduction in the microvascular disease, and 16% reduction in the myocardial infarction. The very important legacy what we want to see is the 10 years post-trial also, where there was no intervention. Still, the well-controlled group in the initial days continued to enjoy the benefit of event-free survival. So this is again very important thing. So this is a legacy effect where we want our patient to have this initial. So this is a kind of similar patient, young, office work, male, type 2 diabetes, recently diagnosed, hypertensive also, BMI of around 26, family history of diabetes and coronary artery disease, no other risk factor, okay? And he is following his diet and exercise on metformin, and still his FBG is 176, PPG 196, and A1C is 8.2. So kind of patients we frequently encounter in OPD, and I'm sure post-COVID we are seeing numerous cases of like this. So which agent we should choose? So can sulfonylurea improve the glycemic control and help better outcome? Yes. So that is why we are going to discuss this molecule. The first and foremost thing is we want to give our patient an efficacious molecule. So two important molecules you can see with the highest A1C reduction. So I would say non-injectable, and oral therapy wise you can see sulfonylurea and pioglitazone. They are one of the highest efficacious A1C reduction capacity. And unfortunately in all the conferences these two are neglected, and we are all discussing the newer CVOT trials only. So very important thing is the efficacy. We want to give our patient a highly efficacious agent, and where sulfonylurea scores the most out of all OHAs. And also if you see the recommendation from the group headed by Dr. Sanjay Kalra, this was published in Indian Journal of Endocrinology and Metabolism, for a sulfonylurea treatment and sulfonylurea combination in management of type 2 diabetes. This was an international task force, and it clearly suggested that we can use model sulfonylurea. That means gliclazide and glimepiride, and they are effective also, they are safe also as initial therapy also, and if used in combination with lifestyle and metformin. Very important thing, the Indian recommendation says we can use fixed dose combinations also containing sulfonylurea that definitely will help us reduce the cost of treatment. It will offer convenience to our patient, and ultimately our patient adherence and compliance will be improved that we want in our patients. Also, sulfonylurea may be considered for use in combination with all other oral drugs except glinides, and this can be used in all comorbid patients. So this is again very important thing. So coming to the again Indian data. So coming to the gliclazide and metformin combination data. So this was Indian data published more than around 700 patients, where epidemiological surveillance was done for scored breakable tablet of fixed dose combination of gliclazide, extended release, and metformin in patient with type 2 diabetes. And clearly you can see the data. It showed rapid fasting blood sugar correction. So fixed dose combination where 60 milligram gliclazide extended release and metformin 500 milligram they were given, and the dose was either 1 milligram in the 1 tablet in the morning, 1.5 tablet, or 2 tablets in the morning they were given. And the primary data collected was for the 15, 30, and 60 days for FPG and control data they were measured. So 8 out of 10% got rapid reduction in FPG, just less than 2 months. This is again very important thing. And the fasting plasma sugar level were also reduced by 49 milligram per deciliter. Coming to the real world data also, we have United Kingdom clinical practice research data link data. This is again very important thing where numerous cases were compared for sitagliptin and metformin, DPV4 treatment and a sulfonylurea treatment, they were compared. So this UK CPRD study 2 years back, they were suggested that we can use gliclazide 60 milligram and metformin combination. In compared to Sita and metformin, we can get a rapid clearance or rapid correction of the hyperglycemia in less than 3 months. And you can see the separation starts very early, even before 3 months also, we get the better result as compared to sitagliptin. Again, interesting data you can see from here is the durability part, where everywhere sulfonylureas are blamed for beta cell exhaustion. But in this slide also you can see data up to 3 years, the continuity or the durability of data of the durability of glycemic control is preserved. So again, these are the real world data with gliclazide. Also, what we are all worried and thought about is the hypoglycemia risk. Yes, risk is always there when we are using sulfonylurea, but when we use modern sulfonylurea, it is very less. And even with the new guide study, you can see the comparison, 70% less risk of hypoglycemia versus glimepiride combinations. This is again a big difference when we use this combination. We will see the mechanism why it is different. Also, CV safety wise. So I'm sure most of you were there where Dr. G. Vijay Kumar sir has mentioned a few of the studies where the actual molecule used for intensive treatment is gliclazide and metformin, okay, where no newer sulfonylureas, no other newer generation treatment were available. And we have this meta-analysis published a couple of years back in the Lancet also, which was a wonderful meta-analysis which clearly showed that gliclazide is CV safe, and robust CV safety data you can see from here, 17% reduction in MACE, 19% reduction in myocardial infarction, 16% reduction in stroke. So we can say, though there is no proper cardiovascular outcome trial for sulfonylurea or gliclazide, but these are the clear-cut safety data, CV safety data for gliclazide, and as compared to glimepiride, where you can see the MACE event were increased, myocardial infarction was also increased by 1%, and stroke increased by 101%. That was compared to gliclazide. But for glimepiride also, we have seen the Carolina and Carmelina trial, which has found to be safe only, where the trial was initially done for a gliptin. But still, this gives us emphasis that gliclazide has superior CV safety. Coming to the Steno-2 study, Dr. Vijay Kumar has already mentioned a couple of minutes back, so I won't go into details, but what I want to convey, the wonderful trial where intensive treatment gave so much benefit to our patient. The weapons used for diabetes control were gliclazide and metformin. So this is all you have to mention that with these two molecules, you can give your patient this benefit of wonderful legacy effect. And what did this study show? With the gliclazide and metformin combination, 7.8 years of intensive treatment, And you can see robust reduction in the macro and microvascular complication. So these benefits you can give to your patient at the end of 7.8 years also. Even the legacy continues here, not only in Wikipedia, Steno 2 also shows the good legacy effect, and patient lived 8.1 years of free of cardiovascular event in this study, and 7.9 years of increased lifespan also in this study. Also, there was 70% reduction in the risk of heart failure. So this is the occurrence of heart failure. So we have data now with gliclazide also that it protects from hospitalization for heart failure, and these are the real world, well-conducted long-term studies. So why are these differences there? Is there any difference in mechanism of action? So these are all sulfonylurea, but the difference comes is the receptor binding. So what is important is the gliclazide has, when we talk about the SUR1 receptor, you can see these are SUR1 receptor, and gliclazide binds here rapidly but reversibility. Okay, so this is very important thing, and that's why there is minimal risk of hypoglycemia. And if you compare glimepiride, which has one of the longest half-life, I would not say compare with glibenclamide, but for modern sulfonylurea, it has the longest half-life of around 24 hours because it binds prolonged to the SUR1 receptor, and it is irreversible binding to the beta cell receptor. So there is increased risk of hypoglycemia, and this especially increase when patient has CKD. Another difference, why this difference in the cardiovascular safety data? So another probable mechanism is the no relation with the cardiac sulfonylurea receptor. So we all know cardiac myocytes, they have SUR2A receptors. So these are cardiac sulfonylurea receptors where gliclazide has no effect on these cardiac sulfonylurea receptors. But for glimepiride, it works here. So it can be a reason for other older sulfonylurea also for their cardiovascular effects. So coming to our patient, we have added the fixed dose combination of gliclazide 60 milligram and metformin 500 milligram with breakfast. Rest other recommendations were advised for also followed for lifestyle modification. At 1 month visit, his fasting came 135, PP came 150, and again the patient was advised instead of 1, he was taken 1.5 tablets in the breakfast only, very convenient dosing, and rest other recommendations were also advised to follow. And 3 months, his FPG came 150 and PPG came 130. So clearly the improvement were there, and he continued all the recommendation. To summarize, the glycemic control remains important in diabetes management, and early initiation of intensive treatment, we have seen the benefit of positive legacy effect. And gliclazide extended release and metformin combination offers a rapid and powerful glycemic control with minimal risk of hypoglycemia and best-in-class CV safety. So we can use this combination in newly diagnosed also for rapid and powerful glycemic control, and for patient who has uncontrolled metformin, we can uptitrate to them also, and we can give them life free of complications. So I thank you everyone for listening to me. If there are any questions, I'll be happy to help.
Nice points in favor of our gliclazide, but as you thought this about the glimepiride, so far still, do you think that it is cardiac not safe?
No, sir. I don't think at all. It is safe only, and we have seen from the Carmelina and Carolina trial about the CV safety trial. This was just the comparison from that meta-analysis, that Lancet meta-analysis, that it was comparison of both these two molecules. So as compared to gliclazide, glimepiride group has little bit more events, but it never said that glimepiride increases the risk of stroke or MI or this thing.
Or in CKD cases, what will be your choice, gliclazide or glipizide?
Depending upon the patient, sir. If patients, gliclazide is the measure of use in CKD, but sometimes gliclazide has a little bit longer half-life as compared to glipizide. So sometimes the nocturnal doses we cannot give gliclazide, and especially elderly also I have found glipizide works best for short duration of time, and when patient is not affording for glinides. So this is where the glipizide is still used more frequently.
Thank you very much for nice talk.
Thank you, sir.
Thank you, chairpersons. Do we have any questions? Are we open to discussion for all the three speakers? Or we can shift to the next symposium? Okay. The next symposium is Care Me approach, which involves the cardiac and renal systems for the management of diabetes. For that, I would like to invite the chairpersons, Dr. Bhagirath Solanki, Professor of Medicine, BJ Medical College, Ahmedabad. Yes, sir. And Dr. Nikhil Pursnani, Associate Professor of Diabetes of Department of Medicine at SN Medical College, Agra. Over to you, chairpersons. Thank you.
अच्छा, तो पहला किसका है? कमल शर्मा? He is not there. Dr. Shishir Gang? Dr. Shishir Gang, na? Yeah, he is there. Okay, so good evening, and there is a warm welcome from the Diacon side, and we are enjoying the academic feast, although the weather outside is very much under turmoil. This session will have 3 lectures. We have bit change in the order. The diabetes no longer remain digitally managed, that the number of fasting blood sugar and PPBS and glycosylated hemoglobin. But now we look to the cardio, renal, heart failure, and all other clinical endpoints. So for that, how to act on CKD, chronic kidney disease, and accelerate the change in reducing the mortality. So how to reduce the mortality in CKD that can be achieved will be delivered by Dr. Shishir Gang, who is at the Moljibai Patel Urological Hospital since last more than 25 years. And he is a chairman of the nephrology services there. He is a visiting faculty position at PS Medical College, Karamsad. And he is awarded gold medal from Baroda Medical College during his MD. His training in nephrology with degree of DM and DNB from the Christian Medical College and Hospital Vellore and NGR University. He has been awarded international fellowship from international societies. His main area of interest is renal transplantation, and we know the Moljibai Patel Hospital is one of the center of carrying the renal transplant. He has authored multiple original articles, books, and chapters, several presentations at national and international conferences, and he has trained more than 50 nephrologists. So a very senior person, Dr. Shishir Gang. Now over to Dr. Shishir Gang.
Thank you, Bhagirath Bhai, for the kind introduction, and would also like to echo the sentiments of the previous speakers. Thank Dr. Bansi for getting all of us here, and as usual, organizing a very, both in the academic as well as the non-academic area, a wonderful conference. The task given to me was to talk about what we as nephrologists can do in the rapidly increasing scene of diabetes, and which eventually leads to chronic kidney disease. So as you're all aware, that the global prevalence of the chronic kidney disease is about 843 million patients. And about 40 to 50% of these patients are actually because of diabetes. And since our country is one of the diabetic capitals, it is not surprising that over the years we are going to see large number of patients who will eventually suffer from chronic kidney disease. The important to note is that though we have a lot of patients with diabetes and who have chronic kidney disease, not necessarily all of them are having diabetic nephropathy. A small segment will have diabetic nephropathy, that they will have persistent proteinuria. But another segment will be having no proteinuria but still have a low GFR, so diabetic kidney disease. And another segment will have diabetes but of a chronic kidney disease of some other etiology. So in a diabetic, whenever you find a renal dysfunction or you find proteinuria, think whether it is diabetic nephropathy or other diseases can also coexist. Now, what would be the natural history of most of the patients with diabetic thing? So if you have about 500 odd million patients with it, about 95% are type 2 diabetics. Half of them will eventually develop chronic kidney disease. But the important thing to remember is that out of this half of the patient who develop chronic kidney disease, only 10% actually will reach to the end-stage kidney disease, because during their journey of the chronic kidney disease, most of them will succumb to cardiovascular disease. So it's very important, though the order of the talk was to initial cardiovascular disease, I'm sure, that to address both the things, cardiovascular disease as well as the chronic kidney disease. And why it is important to note that is patients who have increased proteinuria in the urine. So if you find normal albumin in the urine is only about 15 milligram in about 24 hours. As your albumin increases in the urine, albumin is a very good marker for a microvascular disease. And not only disease in the kidney, but disease in the heart and also in the peripheral vascular disease. So because we can't measure the vascular health in other organs, the urine protein, that is urine albumin, is a very good marker of the vascular health. And our vascular health actually decides how we'll do later on. So any increase in the proteinuria leads to increased risk of cardiovascular disease. Any reduction in the GFR also leads to increased incidence of the cardiovascular disease, and all of them would eventually lead to increased mortality. So, but what you can see that despite a lot of theory, a lot of work has been gone through in the diabetic management, unfortunately, till now, though there has been reduction in the acute myocardial infarction, reduction in the stroke, reduction in amputation, but the end-stage kidney disease has not really reduced since 1990s due to diabetes. And if you do get an end-stage kidney disease and if you are on dialysis, your mortality is much higher than even most of the prostate cancers or a breast cancer and things like that. So a diagnosis of end-stage kidney disease in a patient with diabetes of type 2 is a bad sign. And they would do much worse. The 5-year mortality may be as much as about 40%. So what can you do to retard the progression of diabetic kidney disease? So there are several things which you can address now, which you were not able to address earlier. The 3 key drivers to the progression of diabetic kidney disease is hyperglycemia, which we all can have heard lots about it, that we can address that issue. Then there is a hemodynamic dysregulation, which we have the ACE and ARBs as SGLT2 inhibitors, and now we have the new kid on the block, non-steroidal mineralocortical receptor antagonist. And also the inflammation which comes with the diabetic kidney disease can be addressed by some of the drugs which I mentioned on the slide. So I'll briefly talk about the flow will be what each of these factors which are listed over here. So first thing is to, as has been repeatedly shown, that if you have I don't know whether this will work better here. If you have, the UKPDS included patients who were actually newly diagnosed diabetes, and if you controlled their sugars, they had both reduction in the micro and microvascular complications. But in advanced and ACCORD and BADT studies, they have shown that if you have the late start, then you might have some reduction in the microvascular complication, but not so much in the macrovascular complication. So diabetic memory is very, very important. It has been very well elegantly shown by the previous speakers that it's very, very important. And the second important thing, or I would rather say for diabetic kidney disease, is a more important thing than even the glycemic control, the blood pressure control. And there are numerous papers to show that the real alteration in the outcome of diabetes kidney disease has been because of the control of blood pressure. Even before the introduction of ACE and ARB, as early as 1989, Parving showed that normally if you have a diabetic patient, the rate of fall of the GFR will be about 10 ml per year, whereas the normal aging you have fall of GFR of 1 ml per year. And with good blood pressure control, you can reduce that from 10 ml to about 5 ml, if you do it about 140/90, and you can go down as much as 4 ml if you bring the blood pressure down to 130/85. Of course, now we have better drugs like ACE and ARBs, so you can use them to reduce and control the blood pressure. Blood pressure control is another key thing for management of diabetic kidney disease. And this algorithm has, as you all very well know, that either if they have proteinuria, then it makes sense to use ACE and ARB. If not controlled, then go on to the calcium channel blockers. If not controlled, add a diuretic. And if not, then you can still go further therapies about it. The key thing now is that beyond diabetes and beyond the blood pressure control, do we have therapies which can still retard the progression further? Unfortunately, if you see from the early 2000s to 2020, the only therapy which we had was the ACE and ARB. So ACE and ARB came in about 2000s, and they made a big dent in the progression of chronic kidney disease. But from 2000 onwards to 2020, we had several molecules, like avocentan, that endothelin antagonist, pirfenidone, that is the TGF-beta, aliskiren, renin inhibitor, pseudodoxide, which has various mechanisms of action, dual ACE and ARB blockades, and bardolexin. All of them, though they had a very sound science, but they all failed in the clinic. None of them actually showed a beneficial effects. So then, which we now have are the 4 therapies which are likely to have an impact on the chronic kidney disease. And ACE and ARB you are all very well aware of. And I'll talk briefly about the SGLT2 inhibitors, the mineralocorticoid receptor antagonist, and very briefly about GLP-1 receptor agonist. So if you see that, even if you use ACE and ARB, there's a reduction in the chronic kidney disease, but there is a residual risk. So despite using adequate amount of ACE or ARB, you are still left with some residual effect of that. So what do you do next? Next comes the SGLT2 inhibitors. As you all very well know, that SGLT2 inhibitors act on the proximal tubule. They can send the glucose and the sodium down to the macula densa, where they actually cause the efferent arterial vasoconstriction. And they have other effects also. They reduce the weight, they control the blood pressure, they reduce uric acid, and they also reduce the plasma glucose. And of course, because the efferent arterial constriction, they reduce the intraglomerular pressure. So as you all very well know, the ACE and ARB act on the efferent arteriole, and the SGLT2 inhibitors enter the efferent arteriole. Both of them actually reduce the intraglomerular hypertension. By reduction in intraglomerular hypertension, they have a beneficial effect. And these drugs were actually studied for CVOT trials, which you already all very well know. They reduce the heart failure, atherosclerotic, cardiovascular 3-point MACE, and cardiovascular disease. But along with that, the more important thing was noted was a reduction in the macroalbuminuria, eGFR decline, and in the kidney failure. There are numerous trials. I will not go through all of them. A ton of trials are there to show that. And with each of the therapies, either it be dapagliflozin, either it be canagliflozin, or with empagliflozin, all of them have showed a beneficial effect on not only the proteinuria reduction, but also in the rate of progression of the chronic kidney disease and the incidence of end-stage renal failure. Briefly, this is one of the trials with the DAPA-CKD trial, which was one of the largest trial in the chronic kidney disease, where they have shown that if you use dapagliflozin in patients with chronic kidney disease, out of which about 70% of the patients had type 2 diabetes, they showed that there was a significant reduction in the renal outcome. So if you treat 19 patients, one patient will have, in the 3 years' time, a reduction in one of the kidney endpoints. So it's very, very important that patients with diabetes and with indications for it should be on dapagliflozin. Now, important to note is that when there are a plethora of trials, what is the right time to introduce a drug so that you have the maximum benefit? So what it has been shown that though in all the drugs, when you start using it much earlier and earlier, the gains are very small. But if you use them later on, the gains are much larger, because many of the pathophysiological things and the patient who are prone to get it are more likely to benefit from SGLT2 inhibitors than using it much early in the game. However, there are other indications to use SGLT2 inhibitors early in the game, and therefore this discussion may be a little relevant. But from the kidney point of view, the absolute reduction in the risk of kidney failure is higher in clinical trials such as Credence and DAPA-CKD, because they used it in patients with established kidney failure, that is, they had some degree of proteinuria or they had reduction in the GFR. Again, there was a lot of feeling that these drugs may cause acute kidney injury, may have several other side effects, but none of them have been shown, at least in the trials, both the last trials, the DAPA-CKD trial and the Credence trial. Important note is these trials and these drugs don't come without side effects. So there are some sick day rules which you need to remember, that if you're using SGLT2 inhibitor, they should be held if there is any sickness. If they're going for surgery, if they're going for short surgery, you may hold it for a day. If they're going for long surgery, you may hold it for a couple of days, because you can get significant alteration in the hemodynamics, which you do not want around the perioperative period. They can get sometimes, if they're fasting, then they can get diabetic ketoacidosis, which you do not want. So these drugs, excellent drugs, good drugs to use, but always remember some of the problems which come along with these drugs. But if you can see here that despite the renal study showed that there was a residual risk, the Credence study, that is, that if you add canagliflozin to ACE and ARB, still there was a residual risk. And with the DAPA-CKD, still there's a residual risk. So still patients will progress, with chronic kidney disease, will progress eventually to end-stage renal failure. So can we address this problem further? So here comes a new drug which is known as a Finrenone. Finrenone is a non-steroidal mineralocorticoid receptor antagonist. It is a little different from the aldosterone antagonist spironolactone, because it is a very bulky molecule. It acts such that it recruits certain different genes which are silenced compared to that which happens with spironolactone. So the risk of hyperkalemia is much lower, and the risk of gynecomastia is also lower. And on the effect side, its effect on the blood pressure is much lower compared to spironolactone. So, though it is a mineralocorticoid receptor antagonist, three differences: less hyperkalemia, less gynecomastia and other effects, but also less reduction in the blood pressure. Therefore, this drug has a lot of anti-inflammatory effect. So one of the problems of diabetes and heart failure is that there is some degree of inflammation, which this drug tries to address. What about the trials in that? So we have the Fidelio and the Figaro trial. I just discussed very briefly of the Fidelio trial, which showed that if you use them in patients with proteinuria and use them in stage 3 CKD, in this group of patients, you find that there is a reduction in the outcome. That is, if you use about 29 patients you treat at 3 years, one of the events will be reduced. So they have reduction in the kidney failure or sustained reduction in the GFR or the renal death. So these are good drugs which are coming up, and they have already been launched. I think last week or 2 weeks ago they've been launched in the country also. So and this just shows that there is an increase in the potassium as it expected with the drug, but the increase is not significant as to cause withdrawal of the therapy or to require any admission or any treatment for it. The GLP-1 receptor agonist is the last drug, which the kidney trials are not so many of them, but they do have some beneficial nephroprotective effects. And they also have effects on the obesity. They have effects on many other parameters of inflammation also. And they can be introduced very early in the game. They have less hypoglycemic effects. And they can be used with a GFR as much as up to when the patient up to reaches about dialysis. So that way they are safe for the kidney. And therefore there are many surrogate trials or trials which are trying to look at it. One of the trials which I'll just bring your attention is the AWARD 7 trial, which showed that if you compare dulaglutide with insulin glargine, there is a reduction in the macroalbuminuria. But we have to wait to see really very big trials coming in, and there are some trials on the way which will address this issue also. So what drugs should come in first, second, third, and the fourth? So if there are indications, of course, SGLT2 inhibitors, the GLP-1 receptor agonist you will use upfront, but which should come next and which should come later on? Should they come as they were discovered and introduced into practice, or should they be based on the pathophysiology? All of us would love to base it on the pathophysiology. So there is going to be some competition between SGLT2 inhibitors and MRA antagonists, but SGLT2 inhibitors, already as I said, they have a hypoglycemic effect, so they may come in first, and then the MRA antagonist. And depending upon the indication, it can be used. There are not many trials actually adding both together, but there are some trials on the way which will tell us later on what's the beneficial effect with both of them combined together. So in effect, in essence, if you have a patient with diabetes and if he has even a moderately increased, that is what was previously known as microalbuminuria, you need to start treatment for them, control the blood pressure with ACE or ARB. If under adequate control of that, still there is a residual proteinuria remaining, you add an SGLT2 inhibitor if not added, and then later on you can add the drug that is the MRA antagonist if still not controlled adequately. So in brief, this is something which is in the draft, but I thought I'll share with you. So after the good things that you do with the lifestyle thing, what is the first line therapy? The SGLT2 inhibitors along with the metformin with the first line therapy, if the GFR is more than 30 ml. If not adequately controlled, you can add the GLP-1 receptor agonist, and still if needed, and if they have proteinuria, you use first the RAS inhibitors, and still the proteinuria is continuing, then you can add, if they are not an SGLT2 inhibitors, add the MRA antagonist, and of course if the blood pressure is not well controlled, you add a calcium channel blocker or a diuretic to them. And of course, you can also take care of the lipids, which really have a role to play in this therapy. So overall, we try to look at both the cardiovascular as well as the kidney parameters. And fortunately, a lot of drugs have combined effect on both heart and the kidney, and they would really do well for your patients. I think I will stop here, and if there are any questions, I'm happy to answer.
Thank you very much, sir. We'll have to stay back here because question answer will be after all the lectures, 3 lectures are over. So very elegantly described, not only the sugar control, but the blood pressure control and lipid control are equally important. And for retarding the progression, apart from of CKD, apart from ACE and ARB, there is a role of SGLT2, GLP-1, and now the MRA is also there. So now we are moving to the first lecture in today's series. For that, I am going to request Dr. Manoj Chawla, who is FRCP Edinburgh. He is a director and consultant diabetologist at Lina Diabetes Care, Mumbai, and he is attached with the PD Hinduja Hospital and also a visiting faculty at D.Y. Patil Medical Sciences, Navi Mumbai. And also the Municipal Hospital of Andheri, West Mumbai, organizing Secretary of Diabetes India 22. He is awarded Fellowship of RSSDI and Fellowship of Royal College of Physicians of Edinburgh, Principal Investigator in various global multinational clinical trials for NCs and devices. He is one of the important member for the Technology Task Force from RSSDI, more than 25 papers in national and international journals, and associated editor for International Journal of Diabetes in Developing Countries. So sir is going to speak on the glycemic management and cardiorenal approach. Where are we in 2022? Over to Manoj Chawla, sir. Thank you.
Good evening, everyone, and thank you. Thank you for, it actually felt good. I hadn't heard my introduction in a long time, such a good one. So that felt nice. Good evening, everyone, and the outset, let me thank Banshi, my close friend, and the entire DiaCareCon team for this wonderful congress and inviting me here. Before I came in here this morning, I was a little apprehensive. I'm practically doing 2 conferences every weekend across the country, and we have seen the crowd dwindle everywhere for the changing trends. So it's been heartening to see almost packed halls and a large audience in most of the rooms, and thank you to all of you who've joined in for this session. My apologies, as I was in another session and Dr. Shishir had to take the first session, but we go a step back and talk about glycemic management and cardiorenal approach. Where are we? This is, the disclosure for this is there is a contract for this conversation with AstraZeneca. Now, while glucose control is fundamental to the management of type 2 diabetes, let's understand that it does not reduce the risk of heart failure events. And when we start today talking about the cardiovascular aspect of managing diabetes, let's understand we are not trying to undermine the importance of glycemic benefit. We are very, very clear that when you're treating your patients with diabetes, glycemic control is extremely important and probably central to your scheme of things. But just glycemic reduction is not good enough. And this is important because very often we've had conversations with doctors where we've said, no, you said that this is not important. No, we are trying to bring about the importance of cardiorenal and cardiovascular approach. Glycemic control is extremely important. But glycemic control gives you certain benefits, as you have seen through UKPDS, through DCCT, through ADVANCE, and many other trials. But here, you can see that in spite of glycemic reduction, what it does not offer you is the reduction in heart failure events. So when you look at the data from all these major trials, where you compared intensive versus conservative glycemic control, you saw the benefits in other aspects, but not in heart failure. We move to the section spoken about nephropathy. What is really happening in nephropathy? So when you look at the data again, from trials which have looked at conventional control and intensive control, and I don't mean only glycemic, but all the parameters. So here you will compare 2 arms where you have had intensive control, be it of blood pressure, HbA1c, lipids, use of ACE inhibitors, use of aspirin, and so on. And then you look at the conventional one where the targets are far more leaner. Is intensive control better in reducing the risk of nephropathy? It surely is. But is it good enough? Probably no. So what this slide is showing us is that in the intensive control arm, you've managed to reduce the risk of diabetic nephropathy. So as compared to conventional treatment here, in maroon, you are able to reduce in the intensive control arm. But what is important to remember is that there is still a lot of residual risk for nephropathy, which is not taken care by just intensive control of glycemia and blood pressure and lipids and so on. We move to looking at the burden of cardiorenal disease in type 2 diabetes, and we will continue to elaborate that both of these, renal and cardiovascular disease, are closely interconnected with type 2 diabetes. So whether it is the altered energetics in patients with diabetes, the hypervolemia, inflammation, ischemia, sodium retention, RAS activation, all these factors do ensure the tri-directional link, if I can use that word, between diabetes, cardiovascular disease, and renal disease. You start looking at these comorbid conditions, heart failure, CKD, and type 2 diabetes, they are often comorbid. You see the prevalence of heart failure, 64 million as per the 2017 data. For CKD, 843 million across the globe. And there is going to be a vicious cycle with heart failure and CKD, very often with diabetes at the center of things. The global prevalence at 463 million. What's important to remember is 24% of patients with type 2 diabetes have heart failure as their first complication. For the longest time, we've been focusing on microvascular complications, retinopathy, neuropathy. But the fact is, heart failure is very often the first complication that we see. And what's troubling is the fact that more than 50%, here we're talking about 58% patients of diabetes will develop some form of CKD in their life course. And that is something that we need to be aware of right from the beginning when you start seeing a patient newly detected with diabetes. Cardiorenal disease is the most frequent first comorbidity in type 2 diabetes, and you can start seeing, and these are patients who've been followed up who did not have any cardiorenal disease. They were cardiovascular renal disease free. But in the years to come, as they've been followed up, what is happening? The first comorbidity which has been identified in this cohort, you start seeing heart failure in 24% patients, peripheral artery disease in 10%, MI in 14%, stroke in 16%, and CKD in 36%. So if you put the cardiorenal disease together as a cohort, you're talking about 60% of your patients will end up with one of these as the first comorbid complication in the years to come. Let's move on to look at the glycemic efficacy of dapagliflozin. I did start off by saying that today when we talk about cardiovascular protection and renal protection, let's not forget glycemic improvement. It continues to be extremely crucial for our patients. Now you look at the data for add-on therapy with dapagliflozin, and you look at what's happening when you're adding it on to metformin, you're getting a 0.84% A1C reduction. You're adding it on to metformin and sulfonylurea, you're still getting a 0.86% reduction. You're looking in combination with a GLP-1 and metformin, and you're still seeing a reduction there for DAPA up to the tune of 2%. You're looking at add-on to sita and metformin, so a DPP for metformin, further 0.5% reduction, and you're looking at adding it on to insulin with or without other glucose-lowering therapies, and you're still getting a 0.9 or close to 1% reduction. Now, every time, friends, learn to see this data, and you do attend a lot of conferences, every time you're shown efficacy data, start looking at the baseline HbA1c. There is no meaning of me telling you 0.8% reduction, 1%, if the baseline is much higher. And most of these, if you'll see, the baseline is somewhere around 8%, barring one odd combination where we're looking at 9. So from 8% baseline, if you're getting a 0.8% reduction on average, that is significant. Some of these patients will have a 9% baseline, you will see a 1.5 to 2% reduction. What about body weight? So here we're looking at data that add-on therapy with DAPA resulted in significant reductions in body weight, which is extremely important. Now this is important even for somebody with the Indian phenotype who you may consider as a lean individual. Because when you talk about body weight reduction, it's largely the visceral, the perivisceral fat reduction that we are interested in, and that's what the data is for drugs like SGLT2 inhibitors, where you're seeing reduction in this perivisceral fat. So here again, when you look at add-on to metformin, you're seeing a 2.9 kg weight reduction, along with metformin and sulfonylurea, 2.7 in combination with GLP-1, 3.55 kgs, and along with insulin as well, 1.6. So irrespective of what combination you're using an SGLT2 inhibitor like dapagliflozin, you're seeing further reduction in body weight besides the HbA1c reduction. Some very interesting data that has been generated by Dr. Anup Mishra's group, which has spoken about dapagliflozin improving the body fat patterns. And today we know that one of the pathophysiological mechanisms landing with the high numbers in type 2 diabetes is the perihepatic and peripancreatic fat. This perihepatic and peripancreatic fat is responsible for a lot of metabolic mechanisms which is landing our patients with early and more aggressive type 2 diabetes. So any drug today which is showing evidence in reduction of the peripancreatic and hepatic fat is going to be an added advantage. So in this trial, after 120 days of treatment with dapagliflozin, there was significant decrease in the mean liver fat fraction and the mean pancreatic fat fraction. So they concluded that dapagliflozin improves the body fat patterning. They saw improvements in various parameters, be it body weight, BMI, and various skin fold ratios. They saw reductions in sugar metrics, in lipids, in the HOMA-IR and HOMA-beta and HOMA indexes. They saw mean values of body fat in terms of percentage, the trunk regional fat. They all significantly decreased at the end of the 120-day observation period. And they also looked at the liver span, which decreased significantly at the end of this period, along with reduction in the pancreatic fat fraction, as I mentioned earlier. So let's move on and have a look at the prevention of cardiorenal outcomes. Today, we keep telling our patients that please screen. Let's do your creatinine, let's do your urine albumin, let's look at your GFR, let's try and understand that. Similarly, on the cardiac front, we tell our patients that let's look at cardiograms, let's do a 2D echo, let's probably even move ahead and do a CT coronary angiography. Today, a lot of my patients and a lot of people known to me, my friends, my others, anybody who's above 40, I have pushed all of them that I know that please go and get a CT coronary angiography done. Right? If you can afford to do it, please do it. You want to give a birthday gift, you want to give a Diwali gift, you want to give an anniversary gift, give one of those vouchers which is going to get you done. Is there a chance that people around us have aclinical, subclinical atherosclerotic cardiovascular disease? Yes. There are a lot of us out there who are going to have that problem. Today you land up with an attack, you go to the hospital, you get an angioplasty done, and then you start taking care, there is no big deal. That is secondary prevention. Are we not aware of the risk that every individual probably living in an urban setting has? If every individual has, a person with diabetes is far higher up there in the risk ratio. Somebody with diabetes, with hypertension, with dyslipidemia, probably smoking, it is silly if you don't think that this person is going to land up with a cardiorenal event in the years to come. So primary prevention is the way ahead. And which is where, when you talk about the cardiovascular outcome trial scenarios, the DECLARE trial is probably the most realistic in terms of to our population that we see in our clinics. How is it different? It enrolled patients, 60% patients in this trial were the ones who had only risk factors. About 40% patients were the ones who had established cardiovascular disease, as compared to the other trials like EMPA-REG and all, which had almost 99.8% patients who had established cardiovascular disease. All of you physicians here, when you're treating your patients, do 90% of your patients have established cardiovascular disease? No. In our clinics, you will have 25 to 40% patients who will have established cardiovascular disease. The rest are all going to be with risk factors, and hence, the DECLARE trial is so closer to reality what we see in our clinics. You look at the right side here and you look at the renal function. So what was the baseline renal function of patients included in the DECLARE trial? It was closer to, the GFR was closer to 85.2, so it's almost close to normal. Those who had micro or macroalbuminuria was about 30% as compared to that in CANVAS or EMPA-REG, who had much lower GFRs or much higher percentage of patients with microalbuminuria. Essentially telling you that patients in DECLARE were healthier and closer to what you and me see in the clinic than the sicker population in other cardiovascular outcome trials. So you look at the renal endpoints from the DECLARE trial, and it showed that dapagliflozin slowed the renal disease progression in patients with type 2 diabetes, predominantly those with predominantly preserved renal function. And you're seeing a 47% relative risk reduction in all the renal endpoints in the dapagliflozin arm as compared to the placebo arm. You also appreciate that dapagliflozin had a favorable effect on albuminuria across the baseline USER category. So whether you're looking at improvement from baseline, all the metrics of improvement from baseline, you see the DAPA arm doing better as compared to placebo. You see deterioration from the baseline, from micro to macro, from normal to micro, and so on. Again, you see that the placebo arm did worse in that scenario. So irrespective of your baseline kidney function or microalbuminuria state, the patients in the DAPA arm did better. What about prevention of hospitalization for heart failure? So DECLARE again enroll patients early in the disease continuum, as I said, including those without ASCVD. And this is a clear comparison between the 4 cardiovascular outcome trials. And you're talking about EMPA-REG, more than 99% with established ASCVD. You're talking about CANVAS, again, 66%. VERTIS was pretty similar to EMPA-REG. And it was only 41% patients in the DECLARE trial who had the established disease. Here, what was the result? You see the composite endpoint of hospitalization for heart failure and cardiovascular death, and you see reduction in the events in the DAPA arm as compared to placebo. You look at the MACE, you see again numerical reduction in the DAPA arm as compared to placebo. Might not have been statistically significant, but you see the numerical reduction in both these endpoints. What about hospitalization for heart failure? You see significant reduction in the dapagliflozin arm, 27% relative risk reduction in DAPA arm as compared to placebo, which was found to be statistically significant. What's important in this data is also to see that how many of these patients really had baseline heart failure. And it is 10% patients who had some history of heart failure, 90% patients did not have any history of heart failure, and yet DAPA could prevent any such hospitalization as compared to placebo. Effects of DAPA on hospitalization for heart failure by baseline cardiovascular disease or heart failure status, almost similar to the renal data. We see whether the patients had established CVD or risk factors. You saw improvement in the baseline in the cardiovascular disease status. And irrespective of baseline heart failure status, you saw improvement in the DAPA arm as compared to placebo. So irrespective of baseline cardiovascular disease status or heart failure status, you saw improvement in the endpoints for dapagliflozin as compared to placebo. And which is why today, friends, we have these recommendations which are being followed across the globe. The standards of medical care in diabetes, which has changed from 2020, and we are looking at the 2022 data, clearly speaks to us about that you look at lifestyle change, and then you start looking at the presence of comorbid conditions to treat your patients with diabetes. What does it say? If you have ASCVD indicators of high risk, you are going to choose a GLP-1 or an SGLT2 inhibitor. SGLT2 inhibitor with proven cardiovascular disease benefit, right? And I think that's extremely important. Do we generalize an SGLT2 inhibitor here? No. Even the recommendations are clear in saying only that with proven cardiovascular disease benefit. If you have heart failure as your baseline condition, it's a no-brainer anymore. You will directly consider an SGLT2 inhibitor with proven benefit in this population. Your patient has CKD. And again, let me remind you, almost 50% of your patients with diabetes around will have some form of CKD. It's just that we ignore that. You just start looking at creatinine. You don't probably do a microalbumin, and you miss the stage 1 and the stage 2 CKD very often. If your patient has CKD, again, you're going to be preferably using an SGLT2 inhibitor with primary evidence of reducing CKD progression. And there will be sessions as already done, which is showing data from DAPA CKD and other trials. So SGLT2 recommended independent of glycemic control in patients with CKD, heart failure, and high CV risk. You look at the ACE and ACE 2020 algorithm again, which is a beautiful algorithm, and I like it personally because it talks about CGM right in the beginning, something that I believe in strongly. But more than that, it is telling you how to go about it. It speaks about your entry A1C. So depending on the A1C, whether it's less than 7.5, 7.5 to 9, or more than 9, it tells you as a physician whether you should be going with monotherapy, dual, or triple therapy. But here again, let's move down in this recommendation. And across the segment here, you will see after monotherapy, in a lot of segments, hierarchically, they're putting up GLP-1 and SGLT2 inhibitor. GLP-1 receptor agonist, great therapies. Larger advantage today lies in patients with atherosclerotic cardiovascular disease. You put heart failure, you put CKD, it's directly SGLT2. Even in ASCVD and cardiovascular disease, your patients who cannot tolerate or afford GLP-1, your direct choice becomes SGLT2 inhibitor. Yes, we individualize, we do use DPP-4 inhibitors, we do use sulfonylureas, we do use AGIs and so on, but they go hierarchically below, and that is important. And as I hear the bell for my time, let me conclude, friends, by saying dapagliflozin reduces hyperglycemia on top of other anti-diabetic medications. So right from the glycemic efficacy aspect, a great drug to have in our armamentarium. Heart failure and CKD are the most prevalent comorbidity in our patients with type 2 diabetes, and that's something that you refer to right from the beginning. Type 2 diabetes, patients do land up with heart failure and CKD. So while you consider your drugs, oral drugs or whatever to use for your patients, keep that comorbidity aspect in mind. SGLT2s are the only class of drugs with evidence of benefits in heart failure in patients with diabetes and CKD. Guidelines are very, very clear, and the new RSSDI guidelines that we are going to release on 8th of October in Chennai will also be mentioning the same, if I can just give you a sneaky prelude into that. SGLT2 inhibitors are the only class of drugs which have all these benefits. And finally, I would say, in the whole rush of out there, do start giving a thought also to the drug quality and the delivery of the drug, and whether you want to use the innovator or other drugs, but you do give some thought to what your patient deserves in terms of the efficacy and side effects, or the lack of side effects, which is going to be extremely important, especially when you give them this drug right in the beginning of their life with diabetes. With that, let me thank you all for having me here. And
oh, thank you, sir. Sir, are you going to stay back for 15 minutes?
I have another session, Chairperson,
okay.
Sir. So if you can allow questions to me and Dr. Shishi, we'll take that.
Question, any question from the audience? So, sir, have very elegantly discussed about the primary prevention, let us say like that. The previously Dr. Shishi Gang sir told about the secondary prevention, and the residual risk issue still remains in the CKD also, not only in myocardial infarction. So any question from the audience?
Yes, Praveen.
Thank you, sir. Wonderful oration. So I have a question on the point that you really put across about the fat redistribution or the fat repatterning you spoke about. What is the mechanism of that particular, the fat repatterning that happened? And is that, is it across all the gliflozins or only seen with the dapagliflozin?
So,
thank you.
Well, the evidence is with dapagliflozin. So in this data which has come from Dr. Anup Mishra's group, it is with dapagliflozin. Can I stand here and say it's not happening with other SGLT2 inhibitors? I can't. But the fact is, do we have evidence? So as you understand with a person of science that for any particular drug, they have to show us that benefit for us to understand whether it is a general class effect or it is a specific drug effect. You do realize that when you talk about heart failure, many can probably say that this may be a more general class effect of SGLT2 inhibitors, but when you talk about other aspects of cardiovascular death and other benefits, it may not yet be generalized as a class effect. The mechanism for peripancreatic and perihepatic fat reduction seems to be the similar benefit of fat breakdown, which is similar to what we have seen in the reduction in the visceral adipose tissue. So the worry when SGLT inhibitors came in is when the patient is losing weight, are they losing muscle mass? So it's somebody who's extremely hyperglycemic, and you go back into the history of diabetes, that how are people detected? It is, the definition of diabetes is when the muscle is melting and going out into the urine. So when this drug came in, you were wondering whether is this what is happening? Are you using this drug and are you causing muscle loss? That. Then again, serial CT and MRI studies in the earlier phase 1, phase 2 studies of the developmental program clearly showed that it is the loss of the visceral adipose tissue which is responsible for the weight loss. And I believe that is the mechanism which is responsible for the peripancreatic and perihepatic fat. Right? Thank you.
Sir, is it a proposed primary prevention or evidence-based primary prevention, which is already we have discussed out?
Right. So primary prevention does remain. Now let me put it this way. When you look at the recommendations, today they will tell you, are they telling you that put every patient with type 2 diabetes on an SGLT2 inhibitor from the beginning? The recommendations have not been brave enough to tell us that. The recommendations are telling us that if your patient has heart failure, if your patient has CKD, definitely put them onto that. And which is an acceptable thing. So what's important is that we start screening our patients for even normal ejection fraction heart failure. Preserved ejection fraction heart failure. You start looking for your patients with stage 1 CKD. However, a lot of recommendations from the West are also based on justifying to the insurance companies the price of the drug, and it's extremely high there. I personally feel that if you have your patient who clearly we understand has the risk factors, being an individual with diabetes and comorbid risk condition, you've seen that these are the patients who are going to land up early with CKD or a heart disease. Do I want to give them a drug which not only is reducing glycemia but promises all the other pleiotropic benefits at a cost which is largely affordable in India? I would say yes. And which is where probably the Indian recommendations have to be brave enough to say that, and we'll always get caught up in the circle that do we have enough evidence and whether it's level A or it is more experts' recommendation and so on. So as of today, there is primary prevention remains a gray zone, but it's up to the physician to decide for their patient's best interest.
But yeah, it is a very important drug which is linking both heart and kidney benefits. So thank you, sir.
Thank you. Thank you so much.
Now moving on to the very nice lecture. Now moving on to the third lecture of the today's session. For that, I'll invite Dr. Kamal Sharma, good friend of us. Mine rather, he is MD and DM and DNB in medicine and cardiology, MNMAS, FACC and FSCI. He is a senior interventional cardiologist with vast experience of coronary angioplasty, stenting, valvuloplasty, pacemakers, and pediatric intervention. He is a rare combination, both DNB degree in the medicine as well as cardiology. He is practicing at UN Mehta, SAL, and also teaching at BJ Medical College. He has, you see, very impressive, 22 gold medals for academic excellence during his medical studies. He did world's first vagal nerve stimulation device implant as a part of the clinical trial. And he is a principal investigator in the trials like Paradigm HF, Atlas, TIMI, TIPS. And he has discovered the winking coronary sign of VSR on angiography, is also known as Kamal Sharma's sign. So it's a very great credit. 205 publications and more than 11,500 Google Scholar citations, awarded Excellence Teacher Award by Gujarat University, is the only cardiologist who has cleared the Union Public Service Commission Civil Services exam in his student days 20 years before, but he has chosen to serve the field of cardiology. And he is author of 8 books and many chapters. He is going to speak on the what's new in the heart failure. Over to Dr. Kamal Sharma, sir.
Good evening. Thank you, Bhagirath Bhai and respected chair. Thank you, Dr. Bansi. Thank you, Astra, for believing in me and, as a part of disclosure as well. I'm going to touch upon what's new in heart failure. And I'm so glad that ever since DICON started, I've been talking only on one molecule, and that's on SGLT2s. So it's a pleasure that I believed in, and I used to remember that I used to be the only cardiologist coming to a diabetes conference those days. And everybody would be frowning what this guy is doing here. Now nobody questions that why this SGLT2 is being talked about by a cardiologist. So that's a pleasure change. My convictions, my belief in the molecule has been proven, and with one more important and a fantastic trial. And I'm going to touch upon that trial, which is called as DELIVER. So let's look at heart failure. It's a growing public health problem. We all know high mortality. Dr. Chawla also covered it. A huge burden, 64 million people. You require a lot of patients to be hospitalized every year. Your beds are occupied with them, and heart failure hospitalization is further expected to rise by 50% in the next 25 years. So if you're seeing 1 or 2 patients of heart failure in a 10-bedded ICU right now, you can anticipate them probably to double. What about mortality? Despite therapies like ARNI, 5-year mortality continues to be 50%, and it's going to rise after each hospitalization despite availability of newer therapies. Despite the poor prognosis, there is lack of urgency of early identification and initiation of guideline-directed therapy. Over 40% of heart failures have been diagnosed up to symptoms of 5 years prior to the diagnosis, and 75% of those who are diagnosed with heart failure, they end up requiring an unplanned hospitalization. This is primarily from the US data that the guideline-directed therapies are not optimal in majority of the country, a majority of the patients, even in countries like US. 30% mortality is anticipated if you have an admitted patient within a year. So you'll end up losing 1 patient within a year out of 3. The major recommendations, of course, this is not something I need to enlighten you on. You all know that if the patient is reduced ejection fraction, nobody is doubting that it's class 1, level of 1. European Society guideline calls it level of evidence as level A. And for the others, however, the mid-range, it was 2A, and Heart Failure Society in PRESERVE talk about 2A, but I'm sure this is going to change soon with the 2 important trials breaking in. Emperor PRESERVE came a couple of years, 1 year back, and then you have now DELIVER coming in this year. Now, somebody was asking, do you believe it's molecule? I strongly believe it's molecule. Why? Otherwise, if you had Emperor PRESERVE, why would you require data from DAPA to be asked from DELIVER? And on top of that, you have trials that have been copied in the trial design like EMPA-REG. For ertugliflozin in Voltis, absolutely same inclusion-exclusion criteria, does not reduce mortality. So I strongly believe that the SGLT2 and SGLT1 ratio is an important predictor and a determinant how the class, the molecules within the class differ. And is it true only for SGLT2? No. Do you have data for all sartans for heart failure? No. Have they been evaluated? Yes. Do you have same data for all beta blockers? No. So I believe that we have to move from signs of the class effects to signs of molecules. And now we are moving a step ahead. We are moving to personalized medicine, which is a separate chapter now in Harrison, in diabetology, in cardiology. People talk about personalized medicine. Each patient is different. Guidelines will tell you, but then if you were to ask me primary prevention, I will say yes, SGLT2 all. So why do I believe it? We can discuss it off late, but my topic, sticking to what I talk, I usually should be sticking to, is DAPA-HF, which we all know, and it's much easier to understand in patients with reduced ejection fraction. 4,700 patients, placebo-controlled, a mean BNPs of 1400 plus, ejection fraction of 31%, and 55% without diabetes. Now, this is one trial that tells you, yes, we have less diabetics, more non-diabetics studied in this therapy. Investigators were driven primarily by cardiologists, published in a cardiology forum, and of course published in an EGM as well. 41% without an EGFR with less than 60 were the CKD patients that Dr. Gang was talking about. And how early the differences arise. As early as 28 days. The curves start diverging as early as 28 days when they become significant. How many patients you need to treat? Just 21. You put this 21 patients on this therapy and you end up preventing one event of composite of death or worsening of heart failure. And remember, worsening is hospitalization. You just treat 21 patients of your heart failure with dapagliflozin. You have prevented either a death within 1 month or prevented one patient getting admitted to ICU. Tell me any one therapy in diabetology, forget even diabetology, in cardiology, except acute coronary syndrome when you do an angioplasty. No therapy, even in cardiology, has shown these kind of data. Even if you look at trials like RAILS, which talked about so much of spironolactone in class 3, 4, much sicker patients, 16% reduction, still they did not achieve it within 28 days. So CV death of worsening of heart failure, relative risk reduction was 26%, absolute reductions like this 5%, nearly 5%. Which other trial in a non-inclusion would get up even absolute reduction of 5% with 4 zeros after a dot and then comes 1 of a p-value. You talk about ARNI trials in Paragon HF and you debate wo 0.06 क्यों हो गया, थोड़ा सा धक्का लगता वो significant हो जाता. That's the debate on Paragon HF in preserved ejection fraction of ARNI. But what about SGLT2? Hands down, as many zeros as you can take for the test of significance. But all-cause mortality, this is my favorite. What matters? No patient is going to come and tell you कि मेरे को urine में कितना albumin आपने कम किया. I mean, it's important. But if you tell you I'm going to save your life, I mean, does anything else matter? If you are going to prevent death, there is no strong predictor or a determinant of choosing a therapy. If you give a drug and death is prevented, there cannot be a debate of not choosing that therapy. 17% reduction reaching statistical significance. Now let me come to deliver. So this is well established reduced ejection fraction. What about preserved ejection fraction? How rampant it is, Dr. Bansi and I were discussing. We had started doing BNPs in our diabetic and I had started doing in hypertensive patient, outpatient basis NT-proBNP. And we were shocked. We used to think these labs are wrong. Most of our patients, Dr. Bansi says most of his patients had BNP elevated and they all were practically asymptomatic. These probably are the patients who probably had some element of preserved ejection fraction with occult heart failure. These were the patients who were not manifesting because either they were too obese, not doing activities enough, limiting their lifestyle changes, and if they were to be subjected to activities which were we consider as class 1, probably they will class 2, they would end up becoming significant. So the deliver was then evaluated. What about ejection fraction more than 40% with elevated BNP, ambulatory or hospitalized with EGFR more than 25. Remember, in DAPA HF had EGFR of 30. Now you have data up to 25. You, of course, EMPA had data of 20. Randomized 1:1, baseline 1000 of NT-proBNP, 54% was the average EF, 55% still majority were non-diabetic, 10% of these were recently hospitalized or discharged, and 18% were patients with prior ejection fraction less than 40%. So this also tells you answer. What about those patients whose EF has improved? You've started ARNI, you've started DAPA, and they have now EF is 55. Do you still consider them? Yes, you still consider 18% were representative in this sample. Of course, completely matched, but very importantly, I talk about this. The Emperor Preserve did not have 20% kind of a representation of Asian population, which is still there. So this is geographic distribution. 1 out of 5 patients were from our part of the world. And remember, 3/4 of the patients were class 2. When you look at the BNP on atrial fibrillation or without atrial fibrillation, there were of course different cutoffs, and prior heart failure hospitalized patients had EF of 40% mean, and nearly half of the patient had EGFR below 60. 3/4 of the patients were on loop diuretics. one third were on ACE, 1/3 on ARBs, and even 5% were on ARNI. If you are a very strong believer of ARNI as a therapy from Paragon as a treatment for reduced ejection or preserved ejection fraction or mid-range ejection fraction. And we heard a wonderful talk from Dr. Gang talking about MRA as a therapy, and one half of them were on this therapy as well. Now, when you compare what happened in the DELIVER trial, in patients, there was reduced risk of death or worsening heart failure. Remember, this is one trial. When you compare EMPEROR preserved versus EMPAREG trial versus other trials, the inclusion exclusions were very different and changing to confuse you all the more. EMPEROR preserved, EMPEROR reduced. Here, the primary endpoint in dapagliflozin across DELIVER or DAPA-HF has remained same. Composite of death or worsening of heart failure, to make it simple. No cutoffs of itna EGFR. I mean, at this NT-proBNP, you end up with this EF, which is a problem with the EMPEROR preserved. If you had X amount of EF, this is your inclusion criteria for that amount of NT-proBNP. No confusion was there with regards to that in patients with the DELIVER trial. So, full population and the EF with less than 60, if there were dual analysis was done, if you include all patients, dapagliflozin showed P of 0.008 with 18% reduction with hazards of 0.82 across the study population. But what about patients whose EF was not so high? If you only include patients with EF less than 60, which included patients with EF more than 40 to have improved up to 60, it was even better with 17%, almost nearly the same, 17% reduction in that subgroup. So the worsening heart failure, which included the combination of heart failure hospitalization versus urgent heart failure visit, also was significantly reduced with a hazards ratio of 0.79 of 21% reduction. And again, you can see the curves start diverging very early within a couple of days, and the curves have been like wonderfully separated out as early as 3 months. With regards to the death alone as an endpoint, it was not statistically significant, though there was a trend, and the curves have started diverging. Maybe you end up looking at 7 or 10 years down the line, like I always tell my surgical friends, the STITCH trial. 5 years, no difference. 10 years, there is a difference in surgical reduction. So you don't know. But as of now, at the end point of this trial, there was no difference in mortality as a lower endpoint. Outcomes, when you compare EF less than 60 versus more than 60, across the class, there is a difference in significance of improvement, but there is small amount of difference in terms of CV death. In patients whose ejection fraction was more than 60%, it favored mortality reduction. Now, this is something that has not been observed with empagliflozin. This is really interesting. You get more heart failure reduction. You need to go through the subgroup analysis, why this has happened. What were the subgroup of patients? Maybe they were more amyloidosis, maybe more sarcoidosis, maybe more infiltrative disorder, maybe these were more sicker patients with higher BNP, but these were the patients who actually did better in terms of mortality benefit. The primary endpoint, if you look at the ejection fraction class, again, the EF, the more it was, the benefits were tending to be more for the hazards improvement for the primary endpoint, and for the within 30 days of heart failure, again, the sicker patients more quickly you pick up are going to benefit even more. What about improved ejection fraction? Of course, they did better. Means if you had a patient whose EF was now 42 and has now become 50, and now you've enrolled him, he is going to do better naturally, because he still has some amount of risk of getting into reduced ejection fraction. Again, looking at in terms of the ethnicity, Asians did not do any differently much for the Europeans or Saudi Arabia, and Latin Americans, again, the hazards are slightly different, but not very much different. All individual components were attributed to superiority to the primary composite endpoint. All of them contributed. Death also contributed to the primary composite endpoint reaching its significance, but it individually did not reach a significance. The worsening of heart failure did reach individual significance, though study was not designed to look death as a primary composite endpoint reduction. It was for the primary endpoint of a composite endpoint of hospitalization with death. So total heart failure events with and cardiovascular death, which was secondary endpoint, the cumulative incidence for heart failure events with CV death, when was compared, the hazards ratio was down at 3 years, and then again the curves were starting to separate out much earlier, and the number of events were much lower right from the first event to composite events. The number of events, when you add up, all of them were tending to be significantly reduced. So was the quality life. Mean change in KCCQ total score was significantly improved, with the win ratio defined as 11% improvement. And if it was worse, when you compare with placebo, it was worse, right, for more than 5 versus plus 15 improvement again. So all across the class, how many significant, which characteristic, cumulatively, each of them, individual parameters, some of the parameters, all of them were significantly different. Safety, tolerability, when you look at Fourier's gangrene, there's none in DAPA-HF and none in DELIVER. DKA was there in DAPA-HF in 3, which is 0.1%, and again it remains the same. Otherwise, no significant signal, with volume depletion being similar in patients in DAPA versus placebo. So to conclude, this is the largest, most inclusive trial of heart failure. You don't have to look at NT-proBNP to include for different cutoffs of ejection fraction. Of course, you diagnose diastolic heart failure based on your NT-proBNP and a good echocardiography, but in a patient with reduced or preserved ejection fraction, dapagliflozin reduced the risk of primary composite of death or heart worsening of heart failure. It reduced all components, including total heart failure events, and resulted in improvement in symptom burden with the KCCQ total sum score. And these are consistent across the subgroups defined with EF, with no attenuation even in the highest subgroup of ejection fraction, which is more than 65%. And this is actually the trial you need to analyze why the sickest of the patients not only do well, that is understandable, but why the patients with ejection fraction more than 65 actually had a trend in reduction in mortality. Dapagliflozin was effective in recent hospitalization with prior reduced ejection fraction whose EF had now improved to more than 40%. Even those patients were doing well. So serious adverse events leading to discontinuation was similar between the two groups, and these data hence provide evidence to support SGLT2 as one of the 4 pillars, as we call, regardless of the ejection fraction. So heart failure, put on in dapagliflozin. That's to conclude. So we have the exclusion to 11,000 patients, DAPA-HF less than 40, DELIVER more than 40%, and it has shown consistent different benefit with hazards all across the spectrum of EF, DAPA being better with 14% relative risk reduction and pre-specified level reaching in the pooled analysis also with 14% relative risk reduction on death for DAPA-HF versus 26% reduction of heart failure hospitalization. So initiate DAPA to transform patients' ejection fraction. We have significant benefit across the range of EF and significant 14% reduction in CV death, and it's the only SGLT2 which has mortality benefit with heart failure, and it's a key component of guideline directed therapy with ejection fraction, with reduced ejection fraction or preserved. Thank you very much.
Thank you, Dr. Kamal Sharma sir, for finishing in time. So all 3 lectures we have finished just a few minutes before time. We'll request Dr. Shishir Gang to be on stage also because his question answer were pending. Sir, would you like to sit here or?
Yeah, comfortable here. Yeah.
So questions from the audience.
Dr. Kamal, it was an excellent lecture.
Thank you, sir.
Having learnt everything on dapagliflozin in heart failure, I have a little clinical question. A patient who is on a standard of care for heart failure, dapagliflozin naive, I add 10 milligram of DAPA in the clinic. Now after how many days I would be able to find an improvement in LVEF, LV mass, pro-BNP, NYHA classification, 6 minutes walk test, and quality of life questionnaire?
Fantastic question,
The
sir.
graph and the Kaplan-Meier separates at 90 days and then separates, but how early we would be able to see visible clinical effect?
So there is a pooled analysis from the Milton Packers group where they've looked at the quality life improvement. Firstly, we all need to define that all patients don't do the same and they don't fall into the clinical guideline picture. So some who are more congested will take more time. Some who are less congested may improve more. Some whose blood pressures are on the lower range may actually have more renal impairment if you don't take off diuretics. If the blood pressure margins are good and you have taken off diuretics and make it half, which I usually do, most of them would do much earlier better. But the functional improvement starts as early as 7 days. Mortality starts reducing as early as 28 days. This is from the regression analysis done for the pooled significance values of all the SGLT2 trials that have been done. So your first functional class improvement is within 1 week, and first death is prevented on an average to reach a statistical significance within a month. The other questions were ejection fraction improvement. Now, on an average, EF improves by 8 to 10%. That's all. Don't expect miracles. This is the on an average. We have had patients, you put them on ARNI beta blocker and some of the reversible cause with preserved ejection fraction, they would come to normal EF. That also happens. And there are patients whose ejection fraction has turned out just to 5%, and then you just have to tell you. But very important thing in echocardiography is what improves first. First thing to improve when you put them on the standard care is regression of regurgitant lesion, because the volume starts going down. So first thing is the regurgitation going down. So you had a patient who's got severe MR, now gets you moderate MR. Somebody who's got moderate MR, because you've reduced some amount of volume, it gets into mild MR. Next thing that changes is the LV volume. So your ejection fraction may remain the same, but your volumes will regress slightly. Third thing that will improve will be your ejection fraction. So EF improves at the end of 3 to 6 months in the range of 8 to 10%. So I tell my patients, I don't even do their echo on the first follow-up. I tell them, let's just look at how you're improving. Their 6-minute walk text starts improving. So first thing is the patient telling you, sir, मुझे अच्छा लग रहा है, इसलिए आपके पास दोबारा दिखाने आया हूं. Of course, the heart failure has been moving around with a lot of doctors in between. So that's the first thing that you get. Improvement in the functional class. Second thing is change in the volumes. And then is the rise in the ejection fraction. So quality life is the first thing to improve, then comes the ejection fraction.
For Dr. Bang and also for you. So presuming that patient has not improved or patient is static, at what stage one would consider to add MRA, which was not there in the background, and we have a new MRA coming up in addition to which would be tolerated much better. So 2D echo is not the criteria. BNP, anti-BNP you think could improve, and we are okay that patient is improving, we don't need to add more drugs.
Good question again.
So because now there is a rapid addition of a drug which is changing the guideline. True. Instead of sequential.
Absolutely.
So how do we manage?
Very fantastic. You want, shall I, or you want to take? So as a cardiologist, maybe we are more aggressive guys. I always used to say when Milton Packer proposed the sequentialing, we can't do this in India. If I was to call, तू एक बार आना मैं तेरे को आर्नी दूंगा, दूसरी बार आना मैं SGLT दूंगा, तीसरी बार वो आएगा ही नहीं. वो वीक में 7 बार सर 500 रुपया आपको देता हूं, 300 रुपया रिक्शा वाले को देता हूं, 800 रुपया हर वीक, और अब मेरे 500 रुपए की रोजी रोटी चली जाती है. He will not come. This cannot happen in India. वहां पे ठीक है, you have insurance, you report 6, you are paid by the social schemes for your sick holidays. You can't do this kind of a Milton Packer's formulation of Indian guidelines. We have to go with all 4 pillars at the first go. This is what I do. I just be watchful. So what I do is I take off drugs which can reduce blood pressure. Like there are a lot of nonsense drugs that so उसको isolazine, hydralazine भी चल रहा है, उसको high dose of double diuretics भी चल रहा है, उसको वो Ditor plus भी चल रहा है. एक तरफ आप Dr. Gang will tell you, you have a toric study which tells you that आप उसको जब torsemide देते हो तो potassium वैसे ही 0.7 ज़्यादा है, ऊपर से आपने aldactone ऐड कर दिया और बढ़ गया, फिर आपने आर्नी दिया, उसके बाद उसका potassium 6 हो गया, फिर आपने सब बंद कर दिया, फिर वो worsening of heart failure में आ गया. So this is a problem, a lot of unnecessary. So what I do is I come with anybody who's got class 3 or 4, which is anticipated in a patient, I go with all 4 pillars: MRA, ARNI, SGLT2 and low-dose beta blockers, and take off diuretics if I can, which nephrologists are also happy. Nikal do saab, badhiya hai, diuretics kam do, and any other dilators if are there, like isolazine, hydralazine, any calcium channel blocker, which we don't give. But if any of the other drugs, I just take them off. This is what I do. So all 4 I go together. Doses may be low. Like ARNI, I'll probably go low, 50 BD, and then try to escalate.
I would echo some of the things that what he has already said, that what we do would go sequential. So if you have a ACE inhibitor, ARB used to the maximal doses, and then, but I feel that with all the talk about DAPA patient would be already on it by the time they would come to even ACE or ARB, because of the glycemia management, they would probably come, and a lot of physicians are going to put them early. The thing is, for the reduction of the proteinuria, if for 3 months you use the maximal doses and it has not come below say 500 milligram, you can still have a scope to add an MRA. with the understanding that you keep checking their potassium, despite whatever we say, keep checking their creatinine. Generally, a creatinine rise of about 15 to 20% is an acceptable thing with any of the therapies, even with SGLT2 inhibitors or MRA. But if there's continued rise, then you would be really alarmed to see if there are other factors, like he has taken an NSAID or he has got volume depletion because of another diuretic, which was not necessary, but he was told because you have kidney failure, you have to be on diuretic, which I would really take off and then see. So like that, I think, as has been said, that we will now have to see patients and individualize some of them to a thing. But I have a question for you, now that you have been in the DAPA field much longer than even one of us, that we have a lot of patients who have evidence of, as you said, volume overload by any neurohumoral mechanism. So do you think they would be candidate to use SGLT2 inhibitors, or what would you think of it?
If you know, in one of the debates that I was doing with Dr. A.K. Singh at DICON again, मिल जाएगा इन लोगों के YouTube channel भी इन्होंने बहुत बना रखे हैं. So there also I said, I think it's the apple a day that keeps the doctor away. And where does the SGLT2 come from? Apple bark root. I mean, the first fluorescein was basically apple bark root. And why I believe in that? Because I think it's the statin of the new era. अभी आपके पास NFLD में भी data आ रहा है, nephroprotection भी आ रहा है, stroke reduction भी आ रहा है. If you were to ask me for any volume overload, I think if you can achieve volume loss with an SGLT2, I think you are bigger person than me to emphasize that it's a better way of losing those volumes than giving them diuretics. So if there is any patient where you want to choose diuretics, and if you think the mechanism would allow SGLT to work, it's better to lose volume in the interstitium rather than push the plasma volumes out of the kidney and end up with more nephrotoxicity than what we all know as from DAPA CKD, how nephroprotective the agent is. So I strongly believe in this. I used to talk about its usage in pre-diabetic patients for the sake of dyspneas before the heart failure thing whole started off. And then we got the evidence. We had our own data set. The paper was published, sent to a lot of journals on acute coronary syndromes being discharged on SGLT2. 450 patients, 3 came back with euglycemic ketosis, incidence is 1%, similar to what you have internationally. And then the data came now from Impulse. हमारे 5 जगह paper घूम के आया. Ultimately, the company, I'm not claiming they copied my idea or whatever. They did the Impulse trial and now it's published. Our paper is still in circulation, so it's moving around. But I strongly feel any condition, whereas neurohormonal that you're talking, including say acute coronary syndrome, where you have acute LV dysfunction, acute volume retention, there is no edema. Where is the volume? Volume is in the lung. I want to get rid of it. I will think of SGLT.
Sir, yeah, please.
So, wonderful talk, Dr. Kamal Sharma.
Thank you, sir.
I have few reservations regarding the talk and the implication of the talk. So, for example, the data was really wonderful, and just going by the DELIVER trial and looking at the future ahead of management of diabetes means every diabetic patient at the very outset is a candidate for DAPA.
If heart failure, yes. If he has CVD, yes. That's what the guidelines are, right?
Yeah. So my next question is, say for example, detection of heart failure is relatively delayed in countries like India. So what is your take on the assessment of heart failure by global longitudinal strain? Number one, because it can detect the heart failure at a very early stage, even when it is not clinically manifested,
absolutely,
not echocardiographically manifested, or otherwise not, manifested by ECG. Or by symptomatology even.
True.
So I just want to have your highlight on this issue.
Yeah, so it's an important point. GLS is one of the important parameter, and they say it's a combination of parameter of systolic and diastolic function both. So you can do a GLS. If the GLS is low, that patient is having either or both systolic as well as diastolic heart failure. And that way, there have been small papers where they've looked at improvement in GLS with the other molecule, not the molecule that I'm talking about. They have papers. I believe there are some papers with DAPA as well, but I am aware of a paper with EMPA where they have looked at GLS improvement with dapagliflozin. Now, if you were to ask me, and then this can be again a debate, कि आप क्या हर diabetic type 2 को, type 1 नहीं बोल रहा, हर type 2 diabetic को SGLT2 दोगे? if you were to ask me, yes, because otherwise you tell me a trial of any other therapy apart from say GLP-1 analogs, which has got ASCVD and has got renal impairment, and if you look at the subgroup analysis of the GLP-1 trials, that the patients who benefited most were the EGFR less than 60, age more than 60, obese patients. Those were the subgroup of patients who did better as compared to the other subgroup, and that's why the dilution of the outcomes with the GLP-1 analogs was there for the therapy with SEMA. But I think we need to have therapies based on most important parameter being mortality reduction. If any therapy tells you that मैं death reduce करती हूँ, I would always choose that therapy over any other therapy which says मैं इससे double HbA1c reduction करती हूँ पर mortality का मुझे नहीं पता. This is my belief. As a cardiologist, I feel if a therapy reduces death, maybe from all-cause mortality or CV death, as it becomes imperative for all of us as treating doctors to embrace to a therapy which is documented. I'm not saying others may not. I mean, you can argue that metformin may be UK PDS में over 25 years mortality reduction का trend था. I'm not arguing against it, and I'm not saying one of the debates was metformin versus SGLT2. Again, I had to debate it for the sake of it, and I'm not questioning any other therapy. But unless I get that kind of a data for any other therapy, as a cardiologist, I am more scared of creating hypoglycemia with sulfonylurea because that is not my cup of tea. And why it's a scare for me? Because a hypo is what creates an acute coronary syndrome. We know that from ACCORD. Why the tighter control led to more CV events? People dug it out. It was probably insulin and SUs which created more hypos, and these hypos triggered more acute coronary syndromes, and that's why the tighter control did not translate into event reduction. So why to choose a therapy which is a stronger drug? I have no argument. Maybe it's a stronger drug. There are trials to compare SU with SGLT2 and tell you A1C ultimately to same hi hota hai. But even if it is assuming that other therapies are stronger or better in terms of glycemic control, it should not lead to more CV events when a patient is walking into a cardiologist chamber.
Newer drugs are there, they have to qualify to the mortality benefit.
Absolutely.
But the older drugs were not tested for the same.
Absolutely. So you will have to go back, check them out, and prove it.
Probably a question for both the speciality. Having understood all these drugs now, how do you see Kamal as a sodium toxicity compared to we physicians in a standard clinic, sodium toxicity at myocardium, and a water toxicity? Do you visualize differently today compared to earlier? Our picture of sodium toxicity did not exist.
Absolutely.
And a water toxicity was seen as edema or a pulmonary edema and a standard treatment was diuretic. Now we understand water toxicity differently and sodium toxicity differently at myocardium.
You want to take water first?
So I think, and as I always feel, is that whenever our whole system is driven to maintain the milieu interior, that is to maintain the volume. So there are 10 hormones, 10 systems to maintain the volume. And if the volume is not maintained, we have to address what is the cause of the volume, and that's what we've been talking about. Similarly, yes, if you're taking extra salt and you're retaining salt and water, you need to address that. And if you're taking extra fluid is retained, you have to address it. So I always give example of hyperaldosteronism. If you see hyperaldosteronism, patient appears clinically euvolemic, but it has a lot of cardiovascular effect. You treat hyperaldosteronism, and there is evidence that this salt, extra salt, gets into the subcutaneous tissue where it acts as a neurohumoral mechanisms and lead to problems. So I think the next address is going to be finding out, unlocking what are the causes for it, rather than so if you find hypertension, next goal is going to be looking for hyperaldosteronism, looking for what other manifestations are there. So I think, as I said, long story short, that individualize and control all of that. That's the reason I asked him about if the body is giving any signals that is trying to modify things, you would ask. I have, of course, a bit of reservation on too much on the SGLT2 because what happens is that SGLT2 is upregulated whenever there is hyperglycemia in type 2 diabetes. So a point comes when that upregulation is no longer there. And therefore, this sodium and glucose will come to the distal tubule if you're using a dapagliflozin, say in a normal individual, and that might cause some degree of medullary hypoxia. So there is some concern, and I think trying to push it too earlier, I would be a bit cautious on that part.
You mean to say for CKD?
Not
or
for
even
CKD,
otherwise?
even for normal. Now, as the debate used to happen for ACE and ARB, anyway it is helping, why not start early along with the diabetes diagnosis? So here SGLT2 with diabetes diagnosis, if you are able to control your sugar and your SGLT2s are not upregulated, and you're using something which is pushing the sodium and glucose down, it might induce some degree of medullary hypoxia, which might have long-term fibrotic implications.
But that's the thing. I mean, I always say you approve of pudding lies in eating. I mean, you show that it leads to worsening of renal function. Doesn't happen that way. You look at declared TIMI data, you look at DAPA CKD. If that was the case, at least there should have been some signal of worsening renal function, worsening proteinuria, hypoxia leading to rise in EGFR, doubling of creatinine, no need of dialysis. Doesn't happen. I mean, if you look at even primary prevention data, there is no signal of actually declared TIMI showed improvement for all comer population, including in primary. That's the very reason DAPA CKD was designed. So, yeah, your hypothesis I'm not questioning. I mean, with due respect.
There is no data actually to show that somebody walks in with a, say, blood sugar of 220 and has otherwise A1C of, say, 6.8. Should you use DAPA? Should you use metformin? So should you really go to the pathophysiology of the diabetes rather than something to get the sugar down through pushing into the urine? So that's the question that we have to answer. When you're trying to push it to the urine, what you're trying to do is that you're increasing, as I said, to some degree of a little bit of non-physiological thing that we're doing. That's the reason it took a lot of years for defronzo and all to come up that it might have a beneficial effect. But as you move farther and further away, for the debate's sake, I mean, I do agree with a lot of the things, is that lifeboat saves life, but there can't be a replacement for the ship. So you can't say that I saved a life, so lifeboats are better than the ship. Not at all. Only in situations where there is trouble, they may be better. So I think we have to still, I would be a little hesitant to go more
so I would stick to the guidelines in terms of the evidences of the trials that have been done. If you were to document that the early diabetes or pre-diabetics, when treated with an SGLT2, is more likely to end up with harm in the long run, I'll not give them.
But they are not
unless you document that,
they're beneficial.
Or you tell me, sir, metformin this will do it, then I'll give metformin.
Sir, just I would add to that a supplementary question, because
type 1, yes, it is not.
Because it is going to raise one more question, that once the patient is coming from 8 or 7.5 to 7, probably we should rethink for the DAPA. It comes to the same.
I think there's always going to be some mean coming. Eventually there'll be exceptions, non-exceptions. So I think it's going to fine tune. But I agree with him that there is an interesting molecule. We need to keep a watch for it and train ourselves to look at it more carefully, because we are seeing.
If you look at the US data, patients on SGLT2 in patients with heart failure are not even 50% for any SGLT2. I think if we were to tell our, the learners that be slow, be gentle, I think there is more need to push that be more aggressive. That's what I feel. Because if heart failure patients are not receiving, who are indicated patients, even in US, I wonder, I mean, how many of cardiologists are using for that matter? You know, I mean, when I go through my institute, I tell my fellows every other patient, isko kyun nahi diya, isko kyun nahi diya, isko kyun nahi diya. You know, there is always, sir, abhi add karna baki hai, iska creatinine 1.2 hai, maine kaha tum creatinine 1.2 mein EGFR calculate karoge, to bhi beta DAPA CKD se eligible ho jayega. DAPA HF se nahi hota, to bhi eligible ho jayega. So I think the underusage, I feel, is stronger a problem. I agree to you, you cannot be overuser order. And for the volume thing that you asked, the sodium toxicity and volume toxicity, I think the concept has to move from depleting the intravascular volume, which is such a big problem with diuretics. You just need to drive the interstitial fluid out. Aap kahin pe bhi de do, what the nephrologists are worried about? Interstitium. Right? I mean, nephrons apart, the next thing is interstitial. Cardiologist, interstitial edema. इधर cerebral में वो neurons का edema नहीं है, interneural edema. Everywhere the fluid that is giving a trouble is giving through the interstitium. And what we are doing, flogging whole of the intravascular system and pushing that water out and end up actually creating more nephrotoxicity. And for that concept, it is so important what you mentioned, that the volume, the water and the sodium need to be driven more from the interstitium out than from the vascular bed itself. And that's the reason why SGLT2s would do better than the other diuretics.
We are
Sir,
done or?
yeah, last question probably, because
Yeah.
you want to have a question?
No, that's how the indication has shifted in a heart failure from stage A, B, C, D into the other direction. And with stage A, large majority, 70% of diabetics get into a indication for.
Absolutely.
Or you are putting them into kind of a pre-heart failure category. Or creating a new indication, a new category.
Absolutely.
On the other side, when I look at a DELIVER trial patient participant, you showed a data, age was 72 years with confidence interval of 9, which means that 63 to 80-year-old people were part of DELIVER, which we extrapolate into so young a diabetic of 40.
These are diastolic heart failures. These are diastolic heart failures.
Agreed.
Yeah.
This is a DELIVER population
Yes.
versus a clinic population of all this, including me as a diabetologist, are 40-year-old, where he would be far away, few years, 10 or 20, where a question of putting SGLT2, the current scenario of use of SGLT2I in a practice, are 9 out of 10 receive DPP-4I, but are 2 out of 10 receive SGLT2I, which in our practice as a diabetologist has improved to 4 out of 10.
True.
In the direction what you are suggesting.
Correct.
Most. And Dr. Bang, as you say, when they reach a A1C 6.5, at that level glycosuria part goes down. And the benefit of SGLT2 is there or not is again debatable. The weight loss has stopped. Now there is no benefit of weight loss. And the mechanism which we get with GLP-1 RA are far more additional compared to SGLT2I.
I weigh GLP-1s with equal respect because of the mortality reduction as I do with the SGLT2.
3-point MACE also, if you compare, I would say that 12% in declare TIMI, similar in EMPA, reg outcome, similar percent. Leader trial, liraglutide showed 12%. Dulaglutide in Rewind trial showed 13%. And even a pioglitazone in proactive trial showed 3-point MACE 12%.
Inclusion groups in all of them were very different.
All
That's the
different
biggest.
at
All
different
different.
time, everything. In spite of that, in diabetology, it was a 3-point MACE, only 12-13%. And they were comparable. In SGLT2I, we got heart failure and CV mortality as additional benefit with different
Mortality.
background inclusion. So diabetology still remains a challenge to add more and more people on SGLT2I.
Absolutely.
A huge vacuum and might get filled up with whatever, how people practice.
I think that's the whole idea, because I mean, if I was to look at heart failure per se as an individual therapy, even there, if there is a scope where there is no question, diabetes or no diabetes, if more than 50% of the patients of heart failure are not receiving an SGLT2, that's why the sessions like this become important.
Sir, very fundamental question. We have a microangiopathy, retinopathy, nephropathy, neuropathy. Do you consider the early asymptomatic heart failure as a evolving microangiopathy or still a part of macroangiopathy?
Diabetic,
like
non-diabetic.
in diabetes, in reference to diabetes only, because we are talking about diabetes.
Right. So again, if you were to ask me, if you have TOD, target organ damage, in a diabetic, it's a precluder of development of end organ damages in terms of more events. Like if somebody's got nephropathy, he is more likely to end up with heart failure, which Dr. Gang showed. If you have heart failure, again, it's a precluder of development, precursor of developing a renal failure. If you have an evidence of TOD, you need to choose a therapy which is going to reduce event rates. This is what I strongly believe. You can debate कि इससे वो होता है, इससे ये नहीं होता है, semaglutide से retinopathy होती है. We can debate on that, but you will have to choose a therapy which will reduce event rates.
Sir, I am not talking about the therapy. I am talking, would you consider, or is it considered as a microangiopathy? Because we have macroangiopathy, coronaries, stroke, and
No,
amputation.
it's not a macroangiopathy, but what I'm saying, if
Will-
you have
will you-
macrovascular or microvascular
Because
disease,
is it a problem of cardiac syncytium earlier, and then as the coronaries are involved, then the patient goes to the reduced ejection fraction?
so there are papers that have looked into association of retinopathy with coronary artery disease and heart failure. Most of the patients usually develop retinopathy beyond 8 to 10 years of diabetes. And the same has been true for development of cardiomyopathy. There is a paper on CT angio in India in diabetic patients where in 10 years of diabetes, incidence of coronary artery calcification is 60%. Indian paper, what was talked about.
Sir, you want to say anything for that, the last thing?
I would only add that we do not have very good marker of microvascular disease. The only marker that we have is microalbuminuria. And therefore, microalbuminuria actually is not useful for the nephrologist. It's more useful as a marker that any metabolic disease will affect the blood vessels. And once they affect the blood vessels, there will be alteration in the endothelia. Endothelia is where the affection is. So it will affect the heart, it will affect the different organs differently. So I think when you get evidence of that, it's in the normal albumin excretion is only 15 milligram. So even if you go to 60 milligram, there is something happening there, little bit happening there, which tells
But
you.
that isn't his anti-pro-BNP is equivalent to that?
No,
for the heart?
anti-pro-BNP will come when your atria starts kicking and decides that, okay, I'm finding more fluid, I must now secrete something. So this might come
Part of a microangiopathy,
early. But we
maybe.
don't really test everywhere, so but it can come out.
It's just a...
So I feel, again, that brings the same point. Do you want to wait till you develop TOD or you want to give a therapy that prevents a TOD?
Therapy
Here the balance of the treatment, it is not without adverse events.
No, absolutely. You're
So-
going to treat diabetes, right? You're going to choose something. So when you're going to choose something, is that therapy
it's
that
going
you're going to
be
choose?
the adverse event thing debate between metformin and SGLT2 will be an adverse event debate rather than efficacy debate in the very early part of the.
So we can take that as well.
Okay. Thank you, all the speakers, and particularly Dr. Shishir Gang and Dr. Kamal Sharma. A very interactive, useful session. And over to our from the organizing committee, because I think we are going to have a D-Tech accelerator at Benting Hall, and here everything I think is concluded. Thank you.